different kind. We were light and full of pain. You were never once so late. Cut the cord that kept us connected, blacking out the mirror where your light once reflected. All of the love from up above, we used to feel like a glove. I still think about the you that only exists in my brain. Nothing ever stays the same. Guess it's just a shame with no one to blame. Together in our prime, we were birds of a feather, different kind. We were light and full of pain. We were never once so late. Cut the cord that kept us connected, blacking out the mirror where your light once reflected. All of the love from up above, we used to feel like a glove. I still think about the you that only exists in my you want. Don't give it up. Tell me what you want. Don't give it up. Tell me what you want. Don't give it up. Tell me what you want. Don't give it up. feather, different kind. We were light and full of pain. You were never once sober. Cut the cord that kept us connected, blacking out the mirror where your light once reflected. All of the love from up above, we used to feel like a glove. I still think about the you that only exists in my brain. Nothing ever stays the same. Guess it's just a shame with no one to blame. Together in our prime, we were birds of a feather, different kind. We were light and full of pain. You were never once sober. Cut the cord that kept us connected, blacking out the mirror where your light once reflected. All of the love from up above, we used to feel like a glove. I still think about the you that only exists in my brain. Nothing ever stays the same. Guess it's just a shame with no one to blame.
you want. Don't give it up.
This retreat from San Raffaele, now we have been gathering together here for many years. My name is Francesco Montorsi. I am the Chief of Urology at this place. We are delighted to have you here. And as you know, this is an invention, a creation of Andrea Necchi, who has been our professor of medical oncology at San Raffaele for many years now. And we are a very united group. Sometimes we are more medical oncologists than they are, and sometimes they are more surgeons than we are. So this is the secret, probably, because we are a successful team. We are delighted to have you here. It's going to be an excellent program. So welcome again. Please count on us on whatever need you may have today. And with this, I would ask Professor Guidotti, who is the scientific director of the place, to welcome you also. Thank you, and then we're going to start. Luca?
Thank you, Francesco. So, well, let me extend, first of all, a very warm welcome to everyone. In particular to those who have traveled from afar, including the distinguished American experts who are here today. And for those of you who are not yet familiar with this institution, let me remind you that you're in the most important research hospital in the country, especially when you look at its scientific output, meaning number, quality of publications, patents, clinical studies, especially early phase trials. And we have over 1,000 clinicians who not only conduct high quality clinical research, but closely collaborate with over 2,000 basic scientists in trying to improve diagnosis and therapy for our patients. And in this context, this retreat, which, as Francesco said, is becoming now a significant tradition of the institution. It's its fourth edition, represents a great opportunity to exchange ideas and discussions about new technology, new drugs, and everything related to these urological oncology. And so with no further ado, let me again extend the warm welcome on behalf of our institution. So I really wish you a fruitful day of great discussions and fights over ideas. Okay, thank you, and we can now move on with the program.
These are yours. So welcome in Milan again. So may I have my slides? Okay, that's great. So we have come to the fourth edition, you know, already. So this is the agenda for today. We made just a bit of disconnection from the past, but the structure of the meeting is pretty much the same. So we have an initial session that is conceived this year as a more dynamic session with the presentation of urologists and oncologists for prostate, bladder, and renal cell cancer. Can we move forward? Okay, that's great. We have new friends for the retreat. Sharok is the new one. Sia will join virtually later. We have Jason as a new friend. So we have a new addition, new piece in the puzzle. You know, we are composing a big puzzle. You know, that is growing and growing quite fast, as compared to the initial core business that I see here with many friends that you know today. Well, we have an interesting breakout session. So in between lunches and then breaks, you will be able to know and to meet our residents, our students from various specialties, from oncology, radiology, pathology, and so on. So it would be, I think, a good occasion, a nice occasion for you and for all of them to exchange ideas and to share ideas with you, with the faculty. It's a unique situation. Please, Guy, take the occasion of changing ideas and sharing thoughts with his team. I cannot say most importantly, but part of the success of this meeting will be rely on the lunch. We have a new location for the lunch. The team out there will guide you in the lunch. It is located in the church on the second floor, just in front of the DNA, so it will be easier for us to make the picture under the DNA, so we are lucky. And then I am particularly happy this year to have a special session that will be co-chaired by Shilpa and by Smriti Patodia, another new friend of the retreat. It is dedicated to the research, to the gender disparity issue in clinical research, in particular with a focus on GU cancer. So we'll be able to discuss about this and to know if we can move forward, we can overcome a few limitations that may be considered, maybe acknowledged when it comes to the issue of disparity in doing research, with a particular focus on GU cancers. I have to thank the sponsors, without which we cannot realize anything that we did in this fourth year. So thank you to the sponsors. Thanks to the supporters, academic supporters, patient organization, Europa Uomo, Palinuro, prostate cancer, bladder cancer, Anture also for renal cancer, are participating and are supporting our initiative, as well as today, everyday clinical practice. And then, as we did last year, we doubled the efforts with the second half a day, which is a focus meeting, like a consensus meeting, you know. We did this meeting in the past, last year. Last year, the focus meeting, the guideline meeting, the consensus meeting was regarding the definition of clinical complete response in patients with bladder cancer. This resulted in an important paper that we just published in JCO, providing guidance from multi-stakeholder perspective, regulators from both FDA, EMA, academic investigators, companies, industry, and so, patient organization, in regards to the issue of clinical CR and endpoints for clinical research in the bladder-sparing approach in bladder cancer. This year, the second half a day, which will come tomorrow at the NH Hotel in Segrate, 5 minutes by walk here, will be focused on liquid biomarkers. So we have important representation here from industry. We have important representation here from the academic parties. And the focus will be entirely on liquid biomarkers, with a special focus on bladder for reasons that you will understand quite easily based on the result that we will show you today. And there will be a nice meeting, I think, and a nice addition to the report that we did last year, an integration to the report that we did last year. We are under voting time, you know. The ASCO, the American Society of Clinical Oncology, is our society. We are all part of the society, so you have still time to vote. Please make your choice here. This is these are the nominees for the nominating committee, which is the committee in ASCO, which is in charge of nominating the leadership position within ASCO. So an important position within ASCO. Please cast your vote here. You will be able to know one of these guys here, and you will easily understand who is among these. Lastly, the guys out there, Elena, I just started thanking you and the entire team for all the organization, logistical organization, your patient in changes, and so on. Thank you very much for supporting us, continued support of our work. Thank you for everything that you did for the meeting. So, without spending further words, just as now keeping note, the meeting is entirely broadcasted via YouTube, so we are now live on YouTube. So say hello to our virtual partners. There are a lot of patients also that are connecting virtually. Welcome to all of you. So this means that for the entire session, you will be asked to speak with mic, using mic when addressing question and you're answering question, you know. Please use the mic, otherwise on live streaming it will be very difficult to follow you. Thank you very much. So we just started with the first session, Francesco, and please have a very, very important day, a fresh day, fresh data, science, fun. So welcome to the entire day. Thank you.
So, welcome again. May I call Brigida up here with me. Dr. Brigida Majorano is one of the pillars of the medical oncology unit dealing with GU things. So, Brigida, it's a pleasure to be here today with you. And we start this exciting program with Professor Alberto Briganti. Albi is professor of urology since many years now. He's the editor-in-chief of the top surgical journal in the field of urology, and he's going to discuss for you the latest updates on prostate cancer with then discussion with Professor Agarwal. So, Albi?
Thank you very much, and thank you, Andrea, for this incredible organizing for this outstanding meeting, and thank you, all of you, for coming from abroad, and all of you being here today. I see many friends in the room. It's very nice to actually having all the GU community together discussing some advances in prostate cancer in my case. So I will focus on actually localized disease, while Niraj will focus on metastatic disease. So I don't know why it's working like that, but it's not moving forward. So basically, my presentation is divided into three main topics. One is screening and early diagnosis. Then I will touch upon local treatment and then post-operative therapies. So I will focus on the major advances in the field in the 2025. So I don't think it's working, but we will try to address the major news. Okay, this one, perfect. Okay, so first the update of the ERSPC study. As you know, this is one of the major screening efforts done in the field of prostate cancer based only on PSA. And the results have been reported in New England Journal of Medicine about the very long-term outcomes and 23-year follow-up. This is an old way to do screening in prostate cancer based only on PSA. And the study indeed showed that actually there is a slight increase in the prostate cancer which are detected in patients who are screened for prostate cancer by using PSA every 4 years. And actually there is a small but significant decrease in prostate cancer-specific mortality at 23 years. As you can see from these slides, the main message of this study is that as the follow-up goes on, the number needed to invite, the number needed to diagnose decreases significantly, but still, main concerns of PSA-based screening only is the presence of overdiagnosis and eventually overtreatment. So that's the reason why in 2025 we are not supporting any longer the use of PSA-based screening in all comers, but actually we are proposing individualized, personalized approach based on eventually a first biomarker which might be PSA upfront, and then you stratify patients according to the risk of having prostate cancer by using secondary tests like MRI, and then you may save biopsies and overdiagnosis of clinically insignificant disease. And in this context, actually, it's important to note that this study has been recently published on the New England Journal of Medicine, which includes stratification of patients first, not based on PSA, but based on a polygeny risk score, based on 120 SNPs, which have been known to be associated with prostate cancer, and only those with higher risk of having prostate cancer actually when then offered PSA test and eventually MRI. And this is a smart way to go in the sense that we are selecting upfront of patients which might be suitable for further screening. And by doing this, you actually may half the patients which really do need PSA and eventually MRI, and you significantly decrease the number of participants who actually have then biopsy and selecting those with more aggressive disease in terms of intermediate and high-risk prostate cancer. The second study or the second topic I would like to touch upon is the so-called PRIME trial. We also have contributed to these studies recently, and it has been published on JAMA, and it's a very first prospective evidence that actually we can skip eventually contrast what we are doing MRI for prostate cancer diagnosis. These are quite sophisticated analyses in which first radiologists were blinded to the results of the DCE, then they were unblinded, and actually there was a comparison on biopsy strategies based on the known DCE-based images versus DCA-based imaging. And actually, what the main message of this study is that we can skip DCE. So we can skip contrast-enhanced approach, at least in the vast majority of these patients. So biparametric MRI is eventually as sensitive and as accurate as multiparametric MRI, of course, with significant cost savings and time savings. As you know, in the UK, there is a big trial, which is in the Transform trial, which is giving biparametric MRI upfront in all men, regardless of PSA value. So the first 3 years test for screening is not going to be PSA any longer, but eventually biparametric MRI done in 10 minutes in centers of excellence, because we all know that quality of MRI is very important. What about local treatment? There have been some interesting data on local therapy. Again, I think this is one of the most interesting ones, which is the PACE-B study. We actually randomized patients to different forms of fractionations in terms of radiation therapy as a primary treatment for prostate cancer. ADT was not allowed, and actually I think that this goes in the direction of hypofractionation in prostate cancer as compared to conventional fractionation. Actually, this study included only patients with low to intermediate risk. So we are talking about patients that we are no longer treating like those with low risk prostate cancer, but still there is further evidence that we may go in the direction of hypofractionation. A word of caution here, because the cumulative events of late GU toxicity was higher in the hypofractionation arm, which means that some of these patients eventually at 2 years follow-up may have higher toxicity in terms of GU toxicity as compared to those with normal fractionation. So I think that in the future we may select those patients properly. Those with significant LUTs up front might not be the best candidate, at least to me, for this kind of therapy. In this study, I would like to highlight, not only because I'm the editor of European Urology, but also because this is one of the very few randomized evidence comparing radical prostatectomy versus SBRT in prostate cancer. And the main message here is that patients do not want to be randomized. So this is a significant failure of any comparative treatment for localized disease, because eventually this has been the first power for oncological outcomes. Patient refused. That was re-evaluated by using patient-reported outcomes and main endpoints, and still underpowered. And eventually, only 100 patients were randomized. And in this study, you see from these slides that the patients who had a 2 years follow-up were in PED were 50%. So 1 out of 2, which is, again, not what is, evident in practice, where our rates of patients who were in PED at 2 years is about 15%, not 50%. So food for thoughts when we do prospective randomized trials, even done in the best possible way. So this study has not yet been published, but I would like to report the ENZARA trial, which has been recently reported at ESMO by my very good friend Paul Nguyen. We actually showed the possible use of intensification therapy in the setting of localized or locally advanced disease. And the trial is pretty much negative, in the sense that patients were randomized to either ADT plus 2 years of enzalutamide versus ADT alone, long-term again, because we are talking about high-risk prostate cancer. And the main endpoint was metastasis-free survival by conventional imaging. And you can see here from the two curves, there is actually no difference, and there is some benefit in terms of PSA progression-free survival. However, in the sub-analysis, which of course we always caution when we evaluate sub-analysis, there was a benefit in patients with node-positive prostate cancer, which is in line of what already reported by the STAMPEDE study that showed that ADT plus abiraterone was beneficial in patients with node-positive disease. And I like this slide, which summarizes what Paul Nguyen thinks about the possible intensification strategy in the setting of localized or locally advanced disease. It's likely that those patients with very high-risk disease, or those patients, again, with node-positive disease, may benefit from intensification strategies, including ADT plus RP. Next one, again, is a study which we want to support because we are surgeons and we like, in a way, to fight in a way, very friendly way, against the use of radiation therapy as a primary treatment for patients with oligometastatic prostate cancer. This is the only randomized evidence which was supposed to be a phase 3 study, but that was prematurely closed due to the lack of accrual, and also because of the study STAMPEDE was published in the meanwhile. So basically several hundred patients were supposed to be randomized, but eventually only 100 of them. to radical prostatectomy versus best systemic treatments that back then was mainly ADT, which of course is not the standard of treatment any longer. Many patients had 1 to 3 bone mets, and there was a benefit in terms of cancer-specific mortality over time. But again, underpowered trial, which anyway give us a signal of a possible use of radical prostatectomy in the setting of oligometastatic prostate cancer. What about postoperative treatment and recurrence? We all know about the EMBARK trial, which is a huge study that made a lot of rumors in terms of intensification strategies earlier while patients recur. I mean, all these patients had recurrent disease after radical prostatectomy or radiation therapy or a combination of both, and all these patients had the so-called high-risk BCR, which include high PSA values and fast PSA doubling time. And the group recently reported on New England Journal of Medicine the results of the overall survival analysis, which was a secondary endpoint of the study. And actually there was, again, a benefit of the combination therapy, including ADT plus enzalutamide as compared to enzalutamide alone or ADT alone. Of course, this is not the primary endpoint, but all the other secondary endpoints were also confirmed in a way that we do believe, this can be a possible game changer in a way we treat late and aggressive biochemical recurrence in patients previously treated with either radical or radiation therapy. A couple of phase 2 studies, which I believe is very interesting. One of these is the so-called STORM or PEACE 5 study, which actually is a phase 2 small study coming from Europe that included patients with oligo-recurrent nodal disease only, with the idea to randomize these patients to either SBRT of the node, which was mainly seen either at PET or conventional imaging, versus elective nodal radiation therapy in the entire pelvis. And the study is quite compelling in terms of results, showing that if you see something in the recurrent setting in a small node in the pelvis, 1 or 2 or 3 nodes, you should irradiate the entire field because of the lack of sensitivity of mainly PET in detected small micrometastatic disease. So basically, this goes in the direction that if we go for salvage therapy, SBRT to the node might not be sufficient, and we may be a little bit larger in terms of fields of treatments. The second study, which I'd like to highlight, is coming from Italy, and this is another study also in the setting of oligo-recurrent disease, either in the node or in the bone. And the idea beyond the study was, should we go for radiation therapy alone while we see something, or should we add on top of it ADT? And eventually, the study is positive in suggesting that the combination treatment with radiation therapy plus ADT is beneficial in terms of progression-free survival. This is something that we already knew in a way as clinicians. So we always see, or we often see in our offices, that the combination therapy in this setting might be beneficial, and intensification strategies might be indeed the way to go. That there might be some subgroup of patients which might be treated by radiation therapy alone, but still the combination seems to be beneficial in this setting. And the other study I would like to highlight in this setting is also the highest level of evidence in terms of combination between ADT and salvage radiation therapy in patients recurring after primary therapy. And there is a debate based on large 6 prospective randomized studies, and this is an individual patient meta-analysis that showed that there is a benefit of a combination in terms of metastasis-free survival and prostate cancer-specific survival of about 4%, not much. And the benefit is lost when overall survival is taken as endpoint. So food for thought, we may select more properly those patients suitable for a combination therapy. It's likely that those are benefiting from the combination treatment are those with more aggressive recurrence, like high Gleason score and fast PSA doubling time. Last, I'd like to highlight this study because I see Eli in the room, by the way, because it's a concept that we may use some form of signatures to better select our patients. And the Porto signature is a signature which has been derived from this huge data set that Eli has put together over the last decades, in which there was a signature of genes that are related to immune response and DNA damage repairs, in which you may use this signature to select those patients more candidate, in this case, for dose escalation. both in the setting of primary treatment and both in the setting of salvage radiation therapy. I like this study because we as institution have been supportive of dose escalation in the salvage setting in many patients despite the lack of stroke evidence. And this goes in the direction of better selection of patients who may benefit from higher doses of salvage radiation therapy when these patients recur. So with this, I would like to conclude my talk. I see many friends here in the room. We had a nice editorial board dinner recently of European Urology, which is not only one journal, it's 4 journals, it's a family of journals. And I would like to thank you all for being here on behalf of the journals and on behalf of our team. Thank you.
Thank you, Professor Briganti, for your terrific and very comprehensive presentation. And now it's a pleasure to introduce another very important key opinion leader in prostate cancer, which is Professor Agarwal from Salt Lake City, from the Huntsman Cancer Center in Utah. If you like playing the game Guess Who, you could recognize him among the candidates on the slide for the ASCO committee.
First of all, thank you so much for having me here. It's amazing to see how you, Andrea, and the team have grown this meeting. It's recognized, it's discussed all over the world now. So thank you for organizing this and for having me. So my job in the next 10 minutes to give you a snapshot of what happened in this year in the metastatic prostate cancer setting. And these are obviously not every study, but I decided to pick up like phase 3 trials, which I thought were quite important, and some of them are practice changing. So this is my conflict of interest. I have travel support and research funding to my institution. This is a snapshot of all the targets which are evolving. Finally, prostate cancer is catching up with many other cancer types. And look at the cell surface. That is a new hotspot for development of new drugs. So PSMA, B7H3 and all that. And they are being targeted by radioligand therapies, T-cell engagers, CAR T cells. So this is an unprecedented era in prostate cancer from the perspective of drug development. So I'll start with the PARP inhibitors, obviously. We showed overall survival benefit. As we know, 30%, up to 25 to 30% of patients with metastatic prostate cancer have these DNA repair gene alterations or HRR mutations. And this is the snapshot of all these 3 trials which happened in the first-line mCRPC setting, combining the ARPIs with PARP inhibitors. I'll just focus on the TALA-PRO-2 trial, which reported overall survival benefit in Lancet this year. And we showed that in patients with HRR mutations, combining talazoparib with enzalutamide was associated with an overall survival improvement of 14 months, absolute 14-month improvement in survival with a 40% reduction in risk of death. This kind of magnitude of survival benefit has not been shown ever in any trial in metastatic CRPC setting. Even in all-comer patients and patients who did not have HRR mutations, there were absolute 9-month overall survival benefit. But I'm not going to only focus on the HRR mutation patients. So this is just the Kaplan-Meier curve showing the overall survival benefit in patients who have HRR mutations. And this is striking if you look at the overall Kaplan-Meier curves and the hazard ratio and the absolute benefit. So every patient should be sequenced now with NGS testing. There is no excuse to do that. Now next is Amplitude trial. So we reported Amplitude trial earlier this year in ASCO meeting by Dr. Gert Attard, just published in Nature Medicine. So in this trial, this is hormone-sensitive setting. And in this trial, patients were randomized to abiraterone versus abiraterone plus minus niraparib, which is another PARP inhibitor. And these patients had to have HRR mutations, and ATM mutation was not allowed. So what really happened was 50% of these patients had BRCA1 and BRCA2 mutations. Primary endpoint was radiographic progression-free survival. And this is the snapshot of all the results. So if you look at the primary endpoint, it was met. If you look at BRCA1 and BRCA2 mutation positive patients, the PFS was improved statistically. It was significant, 50% reduction in risk of progression or death. If you look at all-comer patient population, meaning HRR mutation positive patients, including BRCA1 and BRCA2, there was a hazard ratio of 0.63, favoring niraparib plus abiraterone, 40% reduction in risk of progression or death. Time to pain progression was also improved with the combination, and overall survival data are immature right now. And we'll come to and we can argue whether it was BRCA1 and BRCA2 versus should we offer this to other HRR mutation subtypes? And answer is, we will never have a trial which was going to be powering for each one of these subsets of HRR mutations. So clinical judgment is all we need down the line to select these therapies for all these patients. Next, coming to lutetium therapy, lutetium 177, PSMA 617. I think one of the most striking results was this phase 2 trial. It happened in a very kind of obscure session in ESMO meeting. It was not a presential session. It was not a prostate session. So I happened to just saw the slides on the presentation. I thought I learned a lot from this talk by Dr. Kimchi. So just to give you a snapshot, 200 patients were randomized to lutetium versus docetaxel chemotherapy. The mean SUV of was 7 or 8. These are 200 patients progressing on an ARPI, so androgen receptor pathway inhibitor. And they were randomized to lutetium versus docetaxel, and they were allowed to cross over from lutetium to docetaxel versus docetaxel to lutetium. Radiographic progression-free survival favored docetaxel chemotherapy, not significant, but what was striking was that overall survival, even in 200 patient trial, favored docetaxel chemotherapy with an absolute 4-month improvement in overall survival with a hazard ratio which is 1.64 favoring docetaxel, a p-value of 0.02. So this is very interesting finding. These are very interesting findings. And what I learned from this trial, obviously these are docetaxel candidates, and I'll compare this trial with the PSMA4 trial. So if you look at the PSMA4 trial, that compared lutetium with ARPI after prior progression on ARPI. If you look at overall survival in the lutetium arm, in the PSMA4 trial, that was 24 months. If you look at the overall survival in the lutetium arm, in the phase 2 trial, that Canadian trial, PR21 trial, it was 14 months. So it is very obvious that these are different patient population. I think investigators were randomizing patients on PSMA4 trial who had slowly rising PSA versus in the PR21 trial, these patients had more aggressive disease and they were chemotherapy candidates. And the crux, the message here is that docetaxel therapy is a viable therapy, cannot be ruled out, and not everybody should be getting lutetium. I think there are many candidates, many patients out there who should be getting docetaxel chemotherapy followed by lutetium. One thing which was striking was that many patients got lutetium first, did not get docetaxel chemotherapy. That was one of the arguments given for the positive overall survival favoring docetaxel chemotherapy, that patients didn't cross over from lutetium to docetaxel, but they crossed over from docetaxel to lutetium. I think this favored the result of the trial. If patients are not able to cross over from lutetium to docetaxel, I think that's a problem. And these patients were willing to get docetaxel because they were randomized to a docetaxel versus lutetium therapy. So anyway, very interesting results. And then this brings me to the PSMA addition trial. PSMA addition trial was in hormone-sensitive setting. Everybody got 6 doses of lutetium, and the hazard ratio for PFS was 0.72. We don't have medians yet. Overall survival is not positive yet. It will never be positive, as the discussant, Dr. Arun Azad, fantastic discussion by the way, mentioned that patients are going to cross over, so it will never be, we'll never see overall survival benefit. So I think lutetium is a validated therapy in CRPC setting. It showed the trial is positive for rPFS, and I'm sure it will be a treatment for some of the patients. That brings me to Capitolo trial. This trial selected PTEN deficient patients as detected by immunohistochemistry, not NGS testing. I don't know why, but IHC was done, and these patients had to have 90% IHC-based P10 loss. They were randomized to abiraterone versus abiraterone plus capivasertib, which is AKT inhibitor. As you know, AKT pathway is upregulated in P10 deficient patients or tumors. And trial met the primary endpoint of radiographic progression-free survival, which was 7th or 8 months higher in the abiraterone plus capivasertib, hazard ratio of 0.81. We are looking forward to more mature data. Hopefully, PFS and OS benefit will continue to improve. As the discussant mentioned, that Dr. Fizazi, who presented the trial, the P10 deficient patients who had 100% deficiency had higher magnitude of benefit versus 90%, which was the eligibility criteria. So we look forward to seeing more mature results down the line, but this is a first biomarker, one of the first biomarker trials with selected patients based on IHC in the metastatic hormone-sensitive prostate cancer. So this is my summary of the 2025 updates in the metastatic prostate cancer setting. Enzalutamide plus talazoparib should be considered treatment standard of care option for patients with mCRPC with HRR mutation, where you are considering enzalutamide as the ARPI backbone. I won't go into the debate of how many patients are there and so on, but enzalutamide is the most commonly used CRPC treatment in the United States and elsewhere in the world. And if you are considering enzalutamide, and if they have HRR mutation, and talazoparib should be considered standard of care. Docetaxel remains a viable therapy and is appropriate for many patients with mCRPC before lutetium. In the MHSPC setting, my take is many patients, actually a lot of my patients, I will continue to offer ADT plus ARPI. And if we can do that for most of the patients, that will be a big deal, because still a lot of patients are not getting even ARPI, doublet therapy, based on the real world data we have published and many others have published. ADT plus abiraterone plus niraparib is a standard of care for BRCA mutation positive MHSPC patients and is an option for non-BRCA HRR mutation patients. For PSMA addition trial, I don't think this is for everyone. There are going to be a lot of patients, obviously some patients where you will offer lutetium-177, but I personally think personalized dosing is the key. I think that is the next step for the trial investigators. Can we give 2 doses? Because if PSMA PET scan become negative after 2 doses, these patients are not going to benefit with 4th, 5th, and 6th doses, and all that lutetium is going to go to salivary glands and bone marrow and so on. So I think personalized dosing is going to be the key. Abiraterone plus capivasertib is not ready yet. I think we are going to see more data on patients who have P10 loss, 100% P10 loss. It is not approved yet, so it's not ready for clinic. I'm really hoping that we have this option in the clinic, because we want to decide in discussion with our patients whether they need it or not. And I personally think patients with P10 loss, which is at 100%, may have higher magnitude of benefit. And bottom line is, we need to be offering NGS testing and germline testing to all patients with prostate cancer, and quality of life is more important than ever, because our patients are going to be living much longer compared to 10 years ago. I think we all have many patients who are going beyond 5 years, 10 years with MHSPC disease or metastatic prostate cancer. So great news for our patients, but quality of life is more important than ever. Thank you very much.
Thank you very much for this brilliant talk. Thank you. And so we proceed with the bladder cancer session. We will have a general discussion at the end, and Professor Kamat is the first to talk. So Ashish, it's a pleasure to have you here with us in Milan, and the floor is yours.
Thank you so much. I want to once again thank Andrea, Alberto, Francesco for inviting all of us here. This really has quickly become one of my favorite meetings, and except for one time when it was right around Thanksgiving, and I told Andrea, never again, please. I have a wife and I have kids. I did it for you once, but otherwise, every year I will be here. Please don't have it around Thanksgiving. It's my favorite meeting, and it's so good to see so many young attendees in the room, making new friends, catch up with old friends. It's wonderful. So You know, a lot has happened when it comes to non-muscle invasive bladder cancer in 2025, and I gave an overview of this at EMUC just last week, and Kiara, who's here in the audience, did a phenomenal job covering the advances as well. So what I thought I would do here, especially since the title says versus, I'm going to focus on one specific aspect of the development that occurred in 2025 for the management of non-muscle invasive bladder cancer, and that essentially is the combination of systemic immunotherapy with BCG. These are my disclosures. I work with every company that does bladder cancer work. If anybody is in here that's in bladder cancer and I'm not working with you, please contact me because I'd love to work with you. But you guys know this, right? So BCG was first tried for cancer in the 1970s for melanoma, lung cancer, and in the 1990, Don Lamb, essentially along with Alvaro Morales, got it used, tried out for bladder cancer. And since then, it has made it into every possible guidelines, right? Because BCG is the original immunotherapy. There's more than 1.2 million doses of BCG that are used every year, and that's why we know there's a shortage of BCG. And there's always this debate. Can we improve upon BCG? So I organized the EAU's bladder cancer debate sessions, and this year as well, we had this question, and essentially, is BCG still king? Yes, but it is time to dethrone it. So because of this desire to improve upon BCG, there have been several trials that have been ongoing, and these were read out last year and then again this year. So we had the CREST study, which is subcutaneous adalimumab plus BCG, and then Durva along with BCG, and then Atezo, the Alban study with BCG that were read out. But these trials have been ongoing for the past almost 5 years, right? 5 or 6 years. And one of the things is, why did it take so long for these trials to read out? So back in 2022 at the EAU, I gave this talk and I was giving this presentation, and I hypothesized at that time, this was not me revealing any confidential information, that the results are being delayed, that they're overdue by 3 years even at that time, probably because the events are occurring much lower than expected. And I got calls from each and every one of these companies afterwards saying, how do you know? And I said, I don't know. This is not confidential information. This is just something that makes sense. Because all of these studies were powered for BCG response in the old days when people said 40, 50% progression rates, 70% of patients recur. But we know nowadays with better scopes, better resection, better BCG selection, this is our series. Justin Madeley, who was a fellow with me many years ago, published this in 2021. You can see here that in contemporary BCG series, the progression rates are in single digits, right? Not 40%, not 30%, like all these trials were powered for. And because the progression rates are so low, all these studies had to wait quite a while to get the events in order for them to actually read out. And if you look at the EAU risk calculator as well, you can see on that side there, if you plug in the numbers into the risk calculator, you can see in the patients that are considered high risk or very high risk group, the predicted progression rates are 40% at 5 years. And this is what people use. This is the EAU risk calculator. But when Niyati Lobo spent some time here with Anderson and we analyzed our results, you can see that no, in contemporary series, if you give the patient BCG, progression is not 40%, it's more like 14% or 16%, even in the very high risk population, not just high risk, but very high risk population. So BCG clearly works well, and that's why these studies took a long time to report. But they did report, right? So these studies reported, and one thing that was clear from all the studies was that you can't just do induction BCG plus something, you need the maintenance therapy. So this is very clear. The studies did not report on the induction BCG only arm plus more IO. They did, but there was reported more to tell you don't do that, right? So if you look at CREST, Potomac, hazard ratio is the same, 0.68. Alban was negative. We can go into a discussion as to why Alban was negative, partly because they looked at any recurrence, including low-grade recurrence, the design of the study. But all that being said, it's okay to have 2 positive studies with a hazard ratio of 0.68. But if you look at the curves, there's a benefit to adding IO, in this case it's Durva, of roughly about 5%. Right, so it's a 5% benefit with event-free survival. Now here, event-free survival includes recurrence. And when you have a recurrence, those of us in the room that deal with these patients know, you can go in and cauterize, you could resect. It is a recurrence, sure, but it's not a progression event. It's not a life-changing event for the patient. And as we summarized recently, there's a whole explosion of drugs they can use in this setting. So keep in mind, yes, there's a 5% absolute benefit. It ends up being a 32% relative benefit, but 5% absolute benefit. But it comes at the expense of toxicity. The grade 3 or greater AEs are 29, 21, 23%. So these are really significant toxicities for these patients when you add an IO. And you'll hear people talk about, well, it's just steroids, I can give steroids, it's not a big deal. But if you actually break it down and see, a large percent of these patients are getting steroids, they're getting 40 milligrams or greater. So you clearly know that this is real toxicity related to IO, and it's not something that we can take very mildly and say it's not a problem for patients. So we all like to figure out, well, we still need to improve on BCG. There's that about 8 or 9, 10% of patients that clearly could do better. Can we figure out who those patients are? So now let's look at the CREST study, right? Let's look at CREST study, and if you look at the difference in 5% there is a numerical difference in patients who progress to N+, M+. There's no difference anywhere else when it comes to progression. So recurrences, yes, slightly better. Progression to muscle invasive, et cetera, all the same. But metastatic disease, even with the caveats of small numbers, there is some signal. So most of us feel that if a patient, by their characteristics, deep T1, et cetera, might have a sense that they have micrometastatic disease, that's probably the patient that I personally would use BCG plus IO. But if you look at the breakup, it doesn't tell us that. So this is data from CREST. It looks like there's a signal for patients who are younger, don't use TICE, and have CIS. If you look at Potomac, exactly the opposite. There's a signal against CIS, and Alban was negative, so there's no real true signal there at all. So in conclusion, I just want to emphasize today, BCG still is the most effective immunotherapy we have for cancer, not just bladder cancer. IO plus BCG is about a 5 to 7% benefit, and it's a true benefit, but we have to figure out which patients it truly will benefit because the risk of AEs is not insignificant. And shared decision making is important always, but especially today, because a patient sitting in front of us, we don't want them to have an added toxicity for something that today, because of drugs such as STAR-200, drugs such as Adstiladrin, all these newer agents, is not really a life-threatening event. So a patient after BCG has a recurrence today, they have options. 8 years ago, they had no options other than radical cystectomy. So those are the points, and thank you very much.
Thank you, Professor Kamak, for this fantastic presentation. And now it's my pleasure to introduce Professor Necchi. No needs of a presentation, but he is simply the co-host of this wonderful meeting, a well-renowned KOL in bladder cancer and a mentor. Thank you, Professor Necchi. The floor is yours.
Bridget, what is happening in bladder? I don't know what is happening, so the field is exploding, right? So you have seen from a shish what is happening in non-muscle invasive disease. What is happening in muscle invasive and metastatic tumor, you know. This year we had 3 presidential sessions for bladder at ESMO. It was incredible. Just competing with lung cancer, with breast cancer. The field is exploding. The point is how to best metabolize and digest all the data that we are accumulating quite fast in a very short time frame is usually quite difficult. So we will try to metabolize a little bit what is happening and what has happened in this last year. So let's start from MIBC, and the core business of my presentation will be MIBC, muscle invasive bladder cancer, more than metastatic. The struggle is basically here. Moving in between 2024 and 2025, we have, as you well know, the Niagara paradigm. Giuseppe and other Italian colleagues are pretty well aware of the fact that finally in Italy also, not just approved by IFA, but available as an expanded access program. The Niagara paradigm is available here in Italy. So the Durva Gem-Cis immune therapy added to backbone chemotherapy that providing results in terms of improvement in EFS and overall survival. So another therapeutic option that is available, that is expanding worldwide, available in the United States, in most of the European countries and worldwide, as an option for select patients, for patients who are still eligible for backbone chemotherapy, for standard cisplatin-based chemotherapy. This year, just quite a few weeks ago, we heard about outstanding further developments, maybe more impacting at the long run, with different strategies. These are patients who cannot receive or refuse standard chemotherapy. So not the Niagara patients. The other half of the coin, the patients who cannot receive for renal insufficiency or other reasons chemotherapy. So the Keynote 905 was a study, an international study that compared pembro and enfortumab vedotin versus upfront cystectomy with a third arm of pembro monotherapy. I will not focus on the primary analysis did not focus on this arm. So the main comparison was, at least according to the last amendment of the study, was EV pembro versus upfront radical cystectomy. You would say an easy win? Yes. These are the curves. Another standing ovation after the EV302, EV pembro versus chemotherapy 3 years ago at the ESMO meeting, 2023, 2 years ago. In frontline metastatic setting, this time in muscle-invasive disease, improvement in EFS, improvement in overall survival. So clearly, another will come soon as another therapeutic option. But you have consideration to make with regards to the pathological complete response. 57%, in fact, is a very good benchmark. We don't have information on pathological downstaging at the moment. With this trial, the study is still not published in full in manuscript, so we will see the details of the study quite soon, I think. While interrogating the AI tools in order to foresee the future, there is an ongoing study that is testing B15 is called. It is testing EV pembro versus standard chemotherapy in the same population of Niagara patients. So, well, simply asking, okay, Super-Grok, let me foresee what is the future for this combination in cisplatin eligible population. These are the projected hazard ratios for EFS and OS according to AI. It is a projection made on the available data, the published data, meta-analysis, and so. Previous experience with the similar interrogation resulted in in hazard ratio that were quite close to the reality. This happened the same for IMvigor 011. I will show you. So we'll see if the projection of the hazard ratio will be confirmed. In this case, we will have an EV pembro opportunity for all comers also for cisplatin eligible population. The missing piece of the puzzle is just full in charge of Brigida, which is fully responsible of this kind of comparison. Please don't consider me very seriously, and it's entirely due to Brigida. So when it comes to the performance of pembro monotherapy as compared to EV pembro, what is happening? So these curves are the curve from the pure one, the blue one, the curve, the data that have been updated by Valentina with 5-year follow-up from pure one at ASCO meeting this year versus EV pembro. So this means that it would be interesting in the 905 study also to see the performance of pembro monotherapy. And this is the case of pembro neoadjuvant, purely neoadjuvant, versus EV pembro neoadjuvant and adjuvant perioperatively. Sunrise 4, another big step forward. So the possibility of curing muscle-invasive tumors with the combined intravesical therapy and immune checkpoint inhibitor. For the first time, intravesical therapy for muscle-invasive disease is impossible. No, it's a reality. Sunrise 4 is a study testing TAR-200, the gemcitabine intravesical system, formerly called TAR-200, gemcitabine releasing system into the bladder in combination with the checkpoint inhibitor setrelimab versus setrelimab monotherapy. The update of the study was in relation to the biomarker data. We will hear tomorrow, and we're here today with the MRD, minimal residual disease assessment, response of the tumor to systemic therapy by means of ctDNA, circulating tumor DNA, or utDNA, urinary tumor DNA. It's interesting that for the first time in Sunrise 4, while combining the biomarkers from the two cohorts, we saw that utDNA, urinary tumor DNA, in particular post-neoadjuvant therapy, was very strongly associated with pathological response on the left-hand side. On the right-hand side, again, ctDNA confirming to be prognostic and associated with DFS, overall survival, but not so strongly associated with pathological response. So what is happening to the bladder? So when it comes to the consideration with regards to the bladder preservation, when you need to assess what is happening in the bladder wall, maybe utDNA is a bit better position than ctDNA, while ctDNA is clearly strongly associated with the prognosis, and it's an important contribution for patient counseling. Godfather Neo has come to the reality in ESMO. We just presented the primary data. Godfather Neo is a trial that tested combination of visugrumab, an antibody targeting GDF15. Gynecologists know very well what is GDF15, a target that is highly expressed in the placenta tissue, then discovered to be highly expressed in urothelial bladder cancer, as well as in other solid tumor types. Visugrumab is a neutralizing anti-GDF15 antibody that was combined in this case with nivolumab, showing that there was an increase, an enrichment in pathological complete responses or clinical responses assessed with TURBT or radical cystectomy as compared to nivo monotherapy in this patient population. So an opportunity for further development of the combination that was quite well tolerated in our hands. Chinese data are outstanding. And as I anticipated in my talk at the presidential session when commenting the result, the study that we show you, there is an issue in from us as a Western countries when being able to absorb the data that come from Chinese, and we should be able somehow to streamline the pathway for incorporation of Chinese data into real world, into our world, because it makes no sense to replicate the same study or similar studies in the two parts of the world, polarizing the globe with similar studies. Chinese folks are testing anti-HER2 ADCs. This is shown here as a number. An anti-HER2 ADC in HER2 positive urothelial cancer, in combination with checkpoint inhibitor, 75% pathological complete responses that were enriched and moved up to 80% in HER2 3+ tumors. So definitely an opportunity added to the EV-Pembro opportunity in this patient population. ctDNA, we will deal quite a lot on this. InVigor-011 was a big study selecting patients for adjuvant therapy based on ctDNA assessment post-radical cystectomy. These are operated patients with high risk disease for relapse post-radical cystectomy based on pathological assessment, pathological features, and patients with positive ctDNA tests were randomized to receive 1 year of atezolizumab versus observation. And the study resulted in an improvement in survival in DFS, OS, in this patient population with ctDNA positive test post-cystectomy with the high-risk pathological features with the use of immune therapy. So a personalized immunotherapy used based on ctDNA in patients that underwent already a radical cystectomy approach. Most intriguingly to me is the outcome of the ctDNA negative patients. So patients who are negative with ctDNA post-cystectomy, despite having maybe, for example, a PT3 or PN plus pathological examination, they have this kind of flat curve, survival curve. So the possibility of predicting the future based on MRD assessment instead of pathological assessment is a paradigm shift, And we will see if the adjuvant atezo based on ctDNA will be conceived by you as a community of specialists and key opinion leaders as a new standard of care or not. I've already mentioned that the point of clinical CR. The reality is that more and more patients are jumping to our office saying, after any kind of neoadjuvant therapy, saying, okay, doctor, let's try to move in a different way. Let's try to skip radical cystectomy. We have radiation therapy opportunity. We have a different opportunity with continuation of immune therapy or continuation of systemic therapy, observation alone. So there is an ongoing debate, depending on the type of the study that are addressing this opportunity. At least we have tried to put a kind of guidance to follow for the next trials with regards to the endpoints. So as a summary for MIBC, it's a matter of data to me. What it means, data to me, it means that, first of all, you have to treat patients with systemic therapy. First, stop it. Then, when you have a treat patient with any kind of systemic therapy, then you have to discuss. So the patients are fully in the hands of oncologists, you know. And this is a paradigm shift. All the patients are in the hands of oncologists, and then you have to decide depending on the response. And we have many uncertainties related to the duration of the perioperative therapy, the struggle against neoadjuvant only or perioperative adjuvant only, and so. The aggressiveness of local therapy, radical cystectomy, the meaning of radical cystectomy of any kind of local therapy, the type of systemic therapy, EV-Pembro, other ADCs, HER2 ADCs, and so, and the assessment and monitoring of response. These are the pillars to me for MIBC management in this year. Just a quick note regarding metastatic center. I just replicate my consideration that I delivered in the presidential session at ESMO. So we have this kind of improvement in survival. The column are indicated the survival, the median survival from standard chemotherapy up to EV-Pembro. We are dealing with a minority of the patients. So the vast majority of diagnoses jump to the non-muscle invasive and muscle invasive setting. So we are dealing with a minority of the patient. But we have an important consideration to make when it comes to the use of ADCs, in particular Chinese data with anti-HER2 ADCs, disitamab vedotin plus toripalimab, an anti-PD-1, Chinese anti-PD-1 agent versus standard of care chemotherapy. This study provided an incredible improvement in survival, PFS, OS. A new standard of care in China. This is already on file for Chinese approval. We will see. There is a similar study ongoing worldwide. We will see what will be the fate of the future for DVT in particular combination. I'm particularly interested. Again, Brigida, she's particularly smart in trying to compare the Kaplan-Meier curves from studies. And you see that, for example, when merging EV-Pembro, EV302 and DVT Chinese trial, the curve for experimental arm, DVT versus EV-Pembro or chemotherapy arm are pretty much overlapping. This is not a good point because this means that the overlap means basically that we can treat with DVT or EV-Pembro equally without any kind of dissection with any kind of patient selection, you know. And interestingly, Nectin-4, HER2, TROP2 are converging into the luminal subtype, the same tumor subtype. So the impression is that we are treating the same patients. And finally, the attrition of the therapeutic attrition in the bladder has become noteworthy. This means that if we start treating patients with sasanlimab, with BCG naive situation, we may have important consideration to make when it comes to the patient that develop disease progression, disease relapse, and so the impact of prior therapies, in particular prior immune therapy, but today also prior ADCs, and the activity of payload after payload or ADC after ADC has become noteworthy and will be the challenge for the next future. So thank you so much. We will replicate for sure the DNA picture this year. We will make the update of the picture. Ashish and the core business team are already ready to go there. And thank you so much. Let's move on. Thank you.
Thank you, Andrea. Excellent talk as usual. And we now move to the kidney cancer session, and Professor Pal is giving the first part. Please welcome. Delighted to have you here.
Great. Thank you so much. As always, Professor Necki, it's an honor to be here. Thank you to the meeting organizers for having me. I have two objectives. One is to discuss advances over this past year in advanced kidney cancer, and the other is to squeeze this into just 10 minutes. So I'm going to try to go relatively quickly here. Now, I think everybody in this audience is probably familiar with the doublets that we use in the frontline setting for kidney cancer. These 4 pivotal trials have presented over and over and over again. I'm going to just quickly highlight the last of these studies, the CLEAR trial looking at lenvatinib and pembrolizumab. Everyone here will be familiar with this 3-arm study. It's been reported now with several iterations looking at lenvatinib pembrolizumab, lenvatinib everolimus versus sunitinib, and clearly lenvatinib pembrolizumab in this study was indeed the winner. And this has set a bit of a high watermark in terms of progression-free survival, approaching 2 years in this original study, a benefit in overall survival, perhaps a little bit more marginal. But indeed, I think everybody who's used this regimen, lenvatinib and pembrolizumab, would understand that this is actually a fairly challenging regimen, right? From the standpoint of toxicity, lenvatinib causes a fair amount of colitis, fatigue, et cetera. And that really brings us to perhaps one of the most recent data sets this year. This is just hot off the press from ESMO 2025. This is an effort in Keymaker U03 to take the data with lenvatinib and pembrolizumab and turn it into sort of a triplet regimen. This is a complicated study design, so I'll leave the schema up here for just a moment. But you can see that there's a base of lenvatinib and pembrolizumab at the bottom, and there's several comparators. We have lenvatinib and pembro in combination with belzutifan, a HIF-2 inhibitor. We see a combination of quavonlimab, which is a CTLA-4 inhibitor, and we also see anti-TIGIT and anti-LAG-3. Now, it would take a long time to go through each one of these arms and comparisons individually, but what I'll emphasize here, and I'll cut right to the chase, is that much to my surprise, actually, it looks as though this triplet regimen with lenvatinib, pembrolizumab, and belzutifan actually looks very encouraging. So when you look at the progression-free survival against lenvatinib and pembrolizumab here, you see that it approaches 31 months. So a PFS of 31 months in the context of a triplet regimen, I think bodes very, very well for future studies. And for those interested in how all of these arms perform, this is a very busy table here, but what you can see is that the reference column on the right for lenvatinib and pembrolizumab is very much aligned with expectations. A response rate is in the ballpark of 70 to 80%, a PFS of around 2 years. But it really stands that this triplet of lenvatinib, pembrolizumab, and belzutifan is the one that does the best. I think everybody's been disappointed with how LAG-3 is performed, how TIGIT is performed in studies in renal cell carcinoma. And again, this triplet is a surprise, and it bodes very, very well for the 2 frontline studies that we have ongoing in metastatic renal cell carcinoma. I think that for those that are interested in what the evolving landscape is going to look like, it's going to be hard, I think, to displace some frontline regimens. But the LIGHTSPARK-12 study looks at lenvatinib pembro versus lenvatinib pembro plus quavonlimab, the CTLA-4 inhibitor, versus lenvatinib pembro and belzutifan. We don't have results from either one of these studies yet. Now, I've actually used this as an opportunity to highlight the SWOG BioFront study. This isn't activated yet, but this is a trial that looks at IO-based therapy with or without a microbiome modulator called CBM588. For those that aren't familiar with this particular regimen, I refer you to these 2 papers. I won't go into detail, but this is something that we presented at last year's meeting, looking at Nivo-IPI and Cabo-Nivo with CBM588. This is a live bacterial product. I'm actually very encouraged by this data because I think it suggests, first and foremost, that microbiome modulation works, and it does so without really changing the therapeutic index, right? It doesn't add a lot of toxicity. It seems to potentiate the impact of immunotherapy in a very favorable manner. Now, what data do we have more recent than these 2 papers to really support microbiome modulation? Well, again, this is really from our Italian colleagues. This is the Tachido study, which actually came out right around the time of this meeting last year. And this was an effort to look at axitinib and pembrolizumab in combination with fecal microbiome transplant. So this was a very ambitious study with 50 patients. This is very interesting. They actually used a fecal microbiome transplant using stool from a single donor. So one patient actually supplied all the stool in this particular study. And that brings up some questions about reproducibility and so forth. But in any case, with this combination of both fecal microbiome transplant delivered via colonoscopy and tablets, what we see here is that the study met its primary endpoint, improving 1-year progression-free survival survival. There were also improvements in terms of response rate and PFS as well. So again, I do think that microbiome modulation is impactful here. Now, I'm going to shift gears for a second and go to non-clear cell kidney cancer. So within this past year, we've seen updates, in particular this update published in European Urology, the best journal in urologic oncology, which looks at frontline lenvatinib and pembrolizumab in patients with non-clear cell disease. And the data really speaks for itself. If you look to the waterfall plot on the right-hand side, lenvatinib and pembrolizumab clearly is making a very deep impact in patients with papillary, with unclassified, with chromophobe, and so on. Having said that, I do think it's important to keep in mind that this is single-arm data, and I do want to urge the audience to really keep in mind that we have multiple randomized studies that have recently completed. So these are 4 studies that are ongoing. The study in the top left actually is one that we really need support with for those of you in the US, SWOG 2200, looking at frontline cabo plus or minus atezolizumab. But I'm very pleased to say that we've recently wrapped up accrual to the 2 phase 3 clinical trials in the bottom left and the bottom right, Stellar 304, which I've been running with Christina Suarez, looking at zanzalintinib, a novel MET inhibitor with nivolumab versus sunitinib. The SAMETA trial actually is specific to patients with papillary RCC, looking at a MET inhibitor in this context. So please keep an eye out for these randomized trials. I'm going to wrap up by talking about some novel therapies for renal cells. So, I think last year we had some great conversations, some actually led by Brigida, talking about the utility of cellular therapies for renal cell. This is a space that I've been very interested in. So CAR-T, bispecifics, these are things that have only entered into the vernacular for renal cell very recently. I just wanted to walk you through a couple of published examples to date. The first of these are 2 CAR T-cell therapies that hinge on CD70. So what is CD70? It's not a target that we discuss often at these renal cell meetings. It's actually transiently expressed on B cells and T cells. And in fact, there's 2 settings in which we commonly see CD70 expression, and that's going to be renal cell carcinoma and cutaneous T-cell lymphomas. So 2 very divergent diseases. But in fact, CD70 has emerged as an attractive target for CAR-T because of its specificity in renal cell. This is data that we published about 1.5 years ago now, looking at CTX130, which is a CD70-directed CAR-T. Very, very safe compound. We saw very little cytokine release syndrome, or CRS, which is a problem with these therapies. And in fact, one of my patients on this clinical trial had a very durable complete response. In the swimmer's plot, that's the bar on the top there, you can see it extending out to 3 years. In fact, this patient is doing well now at 4.5 years and still remains in CR. So there's some potential. The update this year, actually, from ASCO was for another CD70-directed CAR T-cell therapy called ALLO-316. This is a very similar construct in some regards. This actually has a CD52 swap out. We can go into the details of that later. I will say that by contrast, this is a very toxic regimen. So the other one might have been a little bit too cold. This one might be a little too hot. You do see some responses in patients that are CD70 positive, but to be honest with you, if we were to dive through the data, I think this is going to be a regimen that's very challenging to implement in an RCC population. My last data slide here is actually looking at a target that I honestly hadn't heard of come 5 years ago, and this is a target called ENPP3. ENPP3 is actually a membrane protease that cleaves ATP and nucleic acids in the extracellular domain. And ENPP3 is actually something that's very highly expressed both in clear cell RCC and in papillary RCC as well. So this is a bispecific therapy. So, for those familiar with bispecific T-cell engagers, there's 2 domains here targeting ENPP3. There's one targeting CD3 to engage the T-cell. Now, the problem with a lot of our phase 1 studies in renal cells is that we take a patient population that's very heavily pretreated. So in this study, patients had received a median of 4 prior lines of therapy, up to 8 prior lines of treatment. But what we're seeing on the right, now that we've gotten to target dose ranges, and this is data that we just presented 2 weeks ago at the International Kidney Cancer Symposium, is we're starting to see some very deep responses. I'm starting to see some in my patient population at City of Hope that are actually quite protracted. So I urge everybody to look at this compound as a potential therapeutic option. This study is actually moving to Europe now, and there's sites in France and Italy that are opening up soon. So in conclusion, I think that triplets are poised to enter the frontline space. We've talked about the ones that I'm excited about, in particular microbiome modulation. I think that doublets may be effective in non-clear cell kidney cancer, but I do think that we need randomized data, and that should hopefully be coming soon. And finally, CAR T cells and bispecifics are showing these very encouraging early signals, in particular bispecifics, and they warrant further study. And I'll wrap up by thanking our conference organizer, Professor Necki. I had the honor of actually presiding over this year's GU section at ESMO, and as you know, it was a very busy meeting. Having said that, I think when you're planning these big meetings, as many of the audience have done, you really need to trust the people that you're enlisting to these important roles. So Professor Necki took on a presidential discussion, oral presentation, mini-oral and educational session, and I think he did it very masterfully. So with that, I'll conclude. Thank you.
Thank you, Professor Palf, for your great presentation as usual. And now it's my pleasure to introduce our last speaker, which is Alessandro Larche from Milan. Thank you, Alessandro. The floor is yours.
Thanks a lot. What an honor to close this session. I'll try to be as fast as possible to save some space for our discussion. Can we please update the presentation? Thanks a lot. So basically, let's start from the space of adjuvant therapy, 2021 progression-free survival, 2024 overall survival, and that established pembrolizumab as the best post-surgical therapy for this patient. Now, there are a couple of trials that we'll report soon. We have abstract data so far, further expanding the role of combination therapy and intensification regimen in this space. Darvalumab targets PD-L1, tremelimumab instead targets CTLA-4, which basically from a biological perspective is a double kick on intratumoral T cell, and this is being compared to active monitoring. So in the intention to treat population, we have a positive results with a progression-free, with a disease-free survival higher than 80% relative to 73%. But the concern here is that even when we consider pembrolizumab alone, there is a serious concern for the toxicity related to the potential overtreatment in this very, very specific setting, and this has to be discussed with the patient. So my question for you is, how do we justify treatment intensification if we are already concerned for overtreatment? So let's make a very, very practical example. This is a patient I have operated on this summer, and this is a clear cell carcinoma, 5 centimeter diameter. You can see that we have this very, very tiny tongue over here of tissue touching the renal sinus. So this is high risk going to PT3 stage, grade 2, and no very dangerous red light with respect of other markers of aggressive disease, no sarcomatoid differentiation, no necrosis, no lymphovascular invasion. So clearly, this is a patient that every patient with this feature is discussed together with Andrea, together with Antonio and all the team. But the point is, what is the benefit of an adjuvant therapy in this very specific case? And this is one of the very positive features of the Rampart study, because the investigator planned a pre-specified subgroup analysis according to the individual risk profile of the patient. And as you can see, as anticipated, those who were the very, very high risk instead were those in which the benefit was more pronounced, and instead intermediate risk population, the benefit faded out. Let's change the field. There are key advances in the special setting of systemic agents used to treat primary tumors in hereditary renal cancer. So this center is one of the most relevant in the country for VHL disease, and this study, these results were long awaited. This is a phase 2 study evaluating belzutifan for VHL disease, and there is a very, very reassuring and positive results, not only in the efficacy on clear cell renal cell carcinoma, but also in other sites which are affected by the disease. Almost 50% objective response rate for central nervous system angioblastoma, which are responsible for the detrimental effect in quality of life and symptoms of these patients, and a stellar response with respect to pancreatic neuroendocrine tumor.
as anticipated, so this is a very peculiar field because we have an approved systemic agent, which now is approved also by EMA, based only on phase 2 data with a first report with only 24 months of follow-up. As anticipated, the longer the observation, the higher the risk of progressive disease, which we are starting to observe with longer follow-up. And the other key information here is that these drugs requires a lot of months to show efficacy, basically. So the effect is a kind of slow, which leads us to the difficult task of implementing the indication for systemic agent in our routine practice. If we apply the inclusion criteria of the trial to our real-world population, less than 10% of the patients were eligible for the trial, which basically leads up to the question, how do I select the best candidates for systemic agents? So here, thanks to Andrea, thanks to Antonio, this is the first center that started with this kind of therapy in the country, and we relied on a very, very pragmatic approach, basically. Clearly, this therapy is not a competitor with surveillance, so if we can surveil the patients, we are happy. The dangerous ground is the very high disease burden, so patients that would require an urgent or emergent treatment for a very dangerous lesion. You don't want to wait in this setting 6 months to understand whether the patient is going to respond or not. And basically, whatever is in between those two extreme scenarios then should be regarded as an optimal candidate for systemic agents. So the beauty of real-world data is that T0 in our analysis, it's not trial enrollment, but we can get back to the entire life trajectory of those patients and report and investigate the burden related to the disease and the necessary treatment. And as I said, we're very, very proud that we have these 3 purple dots that are the patients that just started with belzutifan. Final remarks about diagnosis, so different setting. This is a field that is exploding in renal cancer. So nuclear medicine targeting carbonic anhydrase 9 in localized high risk or metastatic renal cancer. Last year, the ZIRCON trial evaluating girentuximab reported 85% accuracy in the field of CT1 disease. The thing is, if we have this 86% sensitivity, that tells us that more than 1 patient out of 10 will have a false negative result, which is very, very disappointing, even if we consider that it is not very clear why. What is the reason behind these rates of false negative? So again, thanks to our nuclear medicine team, Professor Kitty, Fabrizio Giardi, that are here with us, we are the first center in the country that implemented this diagnostic modality in renal cancer, and we have developed a protocol based on radiopharmaceutical administration, in vivo whole body with the purpose of staging also scanning, and then we have planned surgery according to have a little bit of activity in the still present in the specimen in order to allow us to examine this specimen with a high resolution ex vivo imaging scanner. And clearly here the intent is to investigate whether at immunohistochemistry the expression of CA9 is consistent with what we observe with the imaging, which actually was the case, as you can see in this example. So the next step will be to expand this analysis, evaluating the correlation between imaging and cancer aggressiveness. Final thoughts. A couple of notes, updated figures on renal cancer epidemiology. Those are data from the Globocan that gathers all the cancer registries in the world. These data are key to predict what is going on in the next year, because for the very first time, Globocan allowed us also to perform projection about what is happening in the next decades. And basically, this is the expected increase in renal cancer incidence and mortality based on population growth and aging, which is consistent in sexes and clearly very, very different according to geographic variation based on differences in population growth. Thank you very much for your attention. Alessandro, please take a seat. So Professor Necchi is allowing us 5 minutes for the discussion. Can I ask the presenters to come over here and sit with us? I would suggest we have one question per topic. So we will start for prostate cancer. Is there any emergency question on prostate cancer? We can accept one. If there are no questions no, there is one, please.
Raj is running for ASCO election, so we all want to at least make people aware that people can vote for ASCO elections that are ongoing, and Niraj is a candidate. Now, the question to you, my friend, is hormone-sensitive metastatic setting. We came from an era of ADT alone and underutilization, as you published, of escalated therapy, to an era with multiple therapy options. And now we have, of course, the Capitello data, PSMA addition, amplitude data. Do you see a future where we'll have a biomarker-selected patient population for each therapy? Do you think we need a trial to tease that apart? And any comments about how would you modulate, if you ever use Pluvicto in that setting, how would you do that in the context of Arun's discussion? Thank you.
Obviously, I cannot talk about ASCO elections, so I will keep quiet. But thank you for your support. Hello. Okay. So PTEN loss patients, if you look at the median PFS, it was 25 months on ADT plus abiraterone. These patients clearly need something else. I'm not sure if so if you look at two subsets, so first of all, most patients will be fine with ADT plus ARPI. That's the bottom line. If you want to build up on that, I'll look for HRR mutations. And clearly, BRCA1 and BRCA2 mutation positive patients, PFS is half of what you usually see, so they need something else. HRR mutation positive patients, I think many of them will need something else. So PARP inhibitors for those patients, about 25%, 30%. Look at the other spectrum, PTEN loss patients, and these are mutually exclusive. They don't overlap, so there is no problem with decision making here. The median PFS was 25 months. It's a bad player, so they need something else. Is capivasertib sufficient? Is compelling? It's your call. I personally thought PTEN loss 100%. Hazard ratio favored capivasertib more than PTEN loss of 90%. So I think if capivasertib is available, I'll consider that in some of the patients. Regarding lutetium-177, I was hoping for a more compelling data. So I think it is there, a treatment is there, but no, everybody doesn't need 6 cycles. So if I'm using lutetium-177 in any of my patients, I'll give them 2 cycles, look at the PSMA PET scan. If that is turned negative, or uptake is very low, I will hold off on more lutetium-177 treatment until they have more expression. So I think we need some more trial to see the dosing paradigm, how it should be. Thank you.
Any questions on bladder cancer? We can take one. If there are none, from a surgeon's perspective, my request, my plea to all of you who are superstars in medical oncology, I have not yet seen a single patient with muscle-invasive bladder cancer who wants to have his bladder removed. So please do all you can with your studies to allow patients to avoid that operation. Because no one wants to receive that. We have to be honest with ourselves, so it's something which is important. Kidney cancer? Yes, please.
So, wonderful presentations. Congratulations, Professor Corsi, Necchi. I think this is outstanding meetings, all the highlight for all of us to come here with close friends. I think, Monty, I was curious whether you were going to talk on adjuvant treatments. As you know, these are the scenarios we keep seeing in our clinic. Obviously, with Keynote 564 being positive and all the negative studies, I think we're still in this conundrum where with the FDA approval, with the patients coming in using ChatGPT and other AI tools, and patients now are seeking adjuvant treatment. Honestly, I think we're all challenged. We don't necessarily know the right clinical context in terms of which patient should be getting it. How do you do it in practical terms? What's the role of biomarkers? I know we're going to be talking about it tomorrow. Obviously, this is a challenge. We're probably over-treating many patients with adjuvant pembro, for example, based on some of the softer indications. What's the practical, clinical, medical oncology approach to this?
You know, I will say I'm a believer in the overall survival data, as Alessandro had highlighted. You know, and so in my practice, I would say in 9 cases out of 10, if a patient meets eligibility for Keynote 564, they're going to get adjuvant pembrolizumab by their own choice after sort of a balanced discussion of the data. I think, you know, frankly speaking, the field has already moved on from that because we just saw this press release for pembrolizumab with or without belzutifan, the 022 trial. I anticipate that will be presented relatively soon. You know, with that being positive, I think now the discussion isn't adjuvant pembro, it's adjuvant pembro plus belzutifan. You know, we're probably going to be dealing with that in a couple of months.
Can I make a comment on Monty? Because I don't know if it works. So what about the perioperative strategies? So in kidney cancer, there's a huge revival in a way to test in a better way, like neoadjuvant therapies. So what about, is there any big trials which is testing somewhat as done in bladder, like neo, then adjuvant therapy for kidney as well?
Yeah, in the cooperative groups, there's a plan to roll out a study. This is being led by Tony Chiueri and Stephanie Berg, a trial looking at pembrolizumab and belzutifan in that perioperative setting. I think that, you know, we learned a lot from at least one of the perioperative trials in renal cell that was done by actually, you know, ECOG, right, in Alliance. And I think the challenge there is actually that preoperative staging, right? It's so challenging to identify those patients that are high risk, T3 and above, by just looking at a scan. And that was one of the big lessons learned, I would say, from PROSPER.
To Jason. Jason, I need your hint here. A missing part in my personal understanding is the contextualizing the chemoradiotherapy data into the context of new perioperative data, perioperative therapy and radical cystectomy data. You know, if you see the EFS and bladder intact event-free survival curve from the English studies, they're outstanding. Just in light with EV pembro data, you know, what is missing here? So, is it something? Are we getting an improvement with newer perioperative therapies and cystectomy as compared to what we can achieve with the current chemoradiation protocols, or are we treating different population? What is the bias here?
Yeah, I think it's a great question. I think we really need this exciting data with neoadjuvant systemic therapy. I think you can apply more broadly to what might come next, whether it be cystectomy or bladder-preserving chemoradiation. We don't have a lot of great data looking at neoadjuvant therapy followed by standard chemoradiation. And I think we need more of that. I think with these excellent responses to neoadjuvant therapy, with more complete responses, I think as Dr. Montorsi said, no patient really wants a cystectomy. And I think it's going to open up the potential for local consolidation with chemoradiation. And we're going to have to define those patients with complete clinical responses that don't require further local consolidation. We don't know that yet. And we have to see what are the recurrence rates after EV pembro after a period of time. And we also have to define populations of patients that may not need that neoadjuvant therapy. There are probably select patients that do very well with good chemoradiation on its own. And that may avoid some of the side effects of upfront systemic therapy. And so there may be a population that's best served by that. So I think a lot is happening in bladder, but it's opening up a lot more questions.
Thank you.
Thank you. It was fantastic to co-chair this outstanding session with a giant, Professor Francesco Montorsi. So I'm closing the session on behalf of Professor Montorsi. Thank you very much for your presentation. And I'm happy to introduce next session with the other moderator, Massimo Alfano from URI Institute and Marco Moschini from the Urology Department of San Raffaele in Milan. Thank you for co-chairing with me. And I'm happy also to present Professor Sharia from the Vienna University to talk about the integrative profiling of molecular determinants of bladder cancer responsiveness to ADCs. Thank you, Professor.
Thank you very much. It's a true pleasure to be here. I was actually here in Milano for the last 2 weeks, as Marco and Alberto know. I want to thank here Francesco, Alberto, and Marco because my mother broke her hip 3 weeks ago in Milano vacationing, and thanks to this group, we were able to help her and bring her back home and have the surgery and the incredible care at San Raffaele, and I want to thank for that, really. So that is one point. And number two, I will, over the next maybe 20 minutes, they asked me to talk about translational research and a little bit of the components, and I'm certainly not the best person to talk about it, but I spent 4 years in the lab, and now I'm trying to dabble back, 4 years ago, 5 years ago, when I saw the first data on EV and how it's happening in the first phase 1, phase 2 coming out, and I said, wow, that is so interesting. And I was just opening my lab again, and I found a young PhD, and we said, let's work together to see how we could translate that and learn something about that as this new dimension is happening. And I hope in the next 20 minutes I can give you the glimpse of what we're doing and how that has impacted the way we think about this drug and how the sequencing and resistance certainly to those drugs, this new ADC class, is happening and how that's going to influence our thinking, our drug delivery, and strategies we're going to implement in clinical care. As you know, ADCs, this is the new dimension that is being added. We heard about radioligand therapy in prostate cancer. That's also going to happen in bladder cancer. There's a lot of components that are coming, and the checkpoint inhibitors and immune therapies have been a strong component of bladder cancer care. So what about ADCs as they come into the preclinical and clinical scenario, and how they work and how we doing phase 1, phase 2, phase 3 trials? There's a lot of components to that new class of drugs. There's certainly the target biology that matters, that is which antigen density and internalization, the ratio between the antigen and the drug. It's going to matter the heterogeneity in expression of your antigen, and specifically the antigen loss, which may lead to resistance mechanism. Your antibody architecture is going to be very important. Most of them are IgG1, but some are IgG2 or 4, and some have biparatropic existences. So that's going to determine your specificity, but also your immunogenic component, which is certainly very important as you look as the combination of these two drugs working together with checkpoint inhibitors. And there's still a question if it's only toxicity or is there immunogenic, and what is the role of using that immunogenic component and the immune cell engagement. The payload is going to be very important in these drugs as you look at the resistances could happen, different payloads, but there's also some that are looking at immunostimulants, STING and TLR agonists. The linker chemistry is certainly one of the most important. There's some cleavable and non-cleavable components. So if you look at Val-Cit and you look at cathepsin and the pH dependent cleavable sites, but also the non-cleavable components are very important because they require lysosomal integration and degradation, and that's going to determine certainly the ADC toxicity, efficacy, but also its half-life, and certainly what's going to happen on the bystander effect, which is very important in all those drugs, and how to use that. So together, all these components will determine not only the potency, the safety, but also the resistance, intrinsic and acquired. We've seen, over the years, the last 3 years, 2 really large studies that have affected the way we work in bladder cancer and how we're going to treat our patients. One in a metastatic first-line setting. We're looking at the longer-term results, and then now in cisplatin unfit and probably in cisplatin fit. We have heard it before, and how that's going to change the paradigm, how we treat the patients, which drugs we're going to get first, and what is the efficacy. And people look at me and they say always, look, you look very optimistic, but you see the negative news. I always see, why are we not succeeding in all the patients, and what can we do to overcome that resistance? So if you look at it, you have 32% of the patients that have some intrinsic resistance, and over time, over 1 year, even in a metastatic setting, you have 18% further that are going to get some resistance, acquired resistance, and how can we overcome that? Well, if you look at the data that has been shown by Tom Powell's looking at the EV302 and he said, well, can the Nectin-4 expression, just a target expression, give us some insight? And we see, well, all these tumor cells, urothelial carcinoma, seem to have in a metastatic setting, even if it was looked mostly at the primary, a strong Nectin-4 expression. And that Nectin-4 expression, if it's high or low, is not going to determine your resistance. Even in the high expressors, Nectin-4 expressors, you have 50% failure at 1 year, and we need to overcome that. So that is very important. But what is a second way of looking at this is, your Nectin-4 is IQ 23.3. That's an area of CNV that is frequently altered in bladder cancer. You have around 25% of bladder cancers that have this some CNV in that direction. And the group at Erlangen around Marcus Eckstein has looked at it. Maybe it's the amplification that matters. And that looks like if you have the amplification of Nectin-4, you may have 96% of response to EV. That was looked in the metastatic setting and looking at the primary. And if you don't have it, you have 32% overall response. So there is some correlation. There's certainly a strong predictive value or prognostic value, if you want, of the amplification, and that is also correlated certainly to the Nectin-4 expression. So the emerging literature is clear. So you have amplification, higher membrane expression of Nectin-4, and better EV response. However, what we see also this group has shown, as you can see over there, that as the tumors become metastatic, your Nectin-4 amplification decreases. And why is that? So maybe also in a metastatic setting, you may have even less EV response. So looking at how we can do better upon what we have achieved is a little bit understanding the resistance mechanism and how they interact and how they matter in this setting. So I think it's very important as we think about how can we enhance on the backbone of EVP. Can we add FGFR to it? Could we look at PARP inhibitors, which Neeraj will be very happy about, because there's going to be also some role in some of them. So the mechanism of ADC resistance is very versatile and plastic and multifactorial. You have the antigen-related component with the downregulation, heterogeneity, but also some shedding. Your continuous shedding of this Nectin-4 that can serve as decoy and certainly will lead to decrease the efficacy, but also you have some evolutionary resistance mechanism. You have internalization problems, trafficking, your impaired endocytosis would matter, but also lysosomal dysfunction could be affected this. The efflux component is very important in these ADCs, and we're going to look in that and tell you with the ABC family, because they're going to be very different across the different payloads we have. The payload-specific resistance could happen with beta-tubulin alterations and TOP1 alterations, and DNA repair mechanism have been shown very important. As you know, if you have BRCA1, BRCA2 alterations or RAD25 mutations, you may overcome that sensitivity. Tumor microenvironment, as always, we're going to talk about that with TAMs and macrophage, tumor-associated macrophages, and the EMT phenotype. So if you look at that, that's going to be very important as we look in the future and look at cross-resistance, cross-sensitivity across the different type of ADCs we have. So some have different antigens, some have the same payload, and how can we work around that in using the best sequence or the partnership. And very important here again is the linker, and we're going to come back to that. So what have we done? So what have we done in Vienna? In Vienna, over the last 5 years, I sat down and we have taken every single tumor we have in the lab, that we have in the OR, and we have created what we call cell lines. These are patient-derived cell lines. We've created organoids from them. We have 180 of them that exist in functional living now currently, and we have really profiled them genetically. We looked at single-cell expression, we look at mutational profiling, and we also sequence at all possible drugs that are available, rapid throughput sequencing, drug testing, resistance mechanisms, and understand these cell lines. And can we use these cell lines to better understand the ADC sensitivity? So here you can see some of these cell lines, and there's certainly some, like you see the sarcomatid, the VUC38, that is a sarcomatid component. Also in the dishes, there remain sarcomatid spindle cell type, and you look at the other ones, they have this typical morphologic bladder cancer look with cobblestone existence, and they also behave like that. They all grow very well in animal models. We grow them in animals and immunocompetent and immunoresistant animal models, and they're working very well and growing quite well. So looking at the ADC component, we treated all these, a large majority of these cell lines with EV and looked at there was a large heterogeneity in response mechanisms to EV. What we see is the sensitivity is certainly a factor of Nectin-4 expression. On Western blots you can see that, and also looking at the amplification, but it's not everything. Some have high Nectin-4 expression, they still don't respond or become resistant. Some have very high sensitivity. So we looked in the literature and said, okay, is it maybe the molecular subtype or the histological subtype that determines? Certainly there is some data in the literature where you see that some like sarcomatoid, squamous, they will be less Nectin-4 expressing, probably less responsive. The molecular subtypes certainly like neuroendocrine, like the same, we could confirm that, but what we see also that despite these molecular and histological subtypes, there is still not a clear correlation between Nectin-4 and EV sensitivity. So what we did next, we did flow cytometry and sorted the cell lines. Even within a cell line, you find incredible heterogeneity. You find some subcomponents of the same cell line that are high Nectin-4 expressors, some that are very low Nectin-4 expressors, and that will also determine your responsiveness to this EV exposure. Here we took basically cell lines, we incubated them for 24 hours with EV that was radio-labeled, a green fluorescence, and we saw that some of them take up the EV, some even internalize it, and some do not within the endocytic vesicles. So there is a distinct subpopulation heterogeneity within a same cell line that you have from a patient. Now, we then grew, and again with flow cytometry, and grew them in addition, the different subpopulation in one cell line, and looked at them. And even over 2 weeks, you see that their Nectin-4 expression remains or does not remain. Now, there are some of these cell lines that show plasticity, that over time, as you grow them over the weeks, they will balance out the Nectin-4 expressing and non-expressing cells. And so that shows you that actually your cell lines are highly plastic in the environment they are, and they switch molecular expression. That is also correlated with the Nectin-4 overall expression of the cell lines. So how does correlate that to EV sensitivity? Well, it's pretty clear that you look at the one cell line here, it becomes resistant over time, but the subtype, subcell lines that you have, some are completely sensitive already at 900 nanogram per ml, you have IC50, and some subtype of this cell line, subcell line, does not respond at all. Even at 20,000 exposure over 2 days, you don't nanograms per ml. And you have to think about, in a human, 26,000 is approximately what you get with 125 milligrams per kilograms of Cmax, and so that is pretty insensitive cells. The insensitive cells seem to grow faster. Subcells seem to grow faster but migrate less, and both grow very well in animal models. Next, we looked at the EMT, we looked a little bit single cell sequencing on these subcell lines and tried to see, is there a molecular signature that describes this insensitivity and this Nectin-4 non-expression. So this pairwise RNA-seq that you see here in Nectin-4 negative cells, you see a shift that you see in many cancers, and for Ashish, this is going to be sort of a flashback to the time the EMT signature changes that we have seen all across the history, even with standard chemotherapy. So we see a lower epithelial differentiation state, and we believe that is not only something that's happening in the dishes, that is also what is happening in humans. Let's go back to the tissue of the patients. We look at the tissue of the patients. These are not EV-exposed patients prior to EV exposure, and you see that Nectin-4 expression is quite heterogeneous, even that in the same tumor, same tumor location, and that confirms that. So our in vitro observations reflect real tumors. Our hypothesis was here that distinct expression levels are associated with distinct underlying molecular signatures and phenotypes, transcriptional phenotypes that you could see on single-cell transcriptomics. So we went into literature, found around 25 patients where we can download that information and look at that. And what we see, this aggregate data from the 25 patients, is that there is a clear transcription Nectin-4 heterogeneity among malignant cells. Now, translating that back to our cell lines of our patients, we found that by pseudobulk comparison of these high and low volume, lower expressors of Nectin-4, we found that Nectin-4 low cells have really that mesenchymal stemness that we see. So basically, what you have is that, or what that creates is that the hypothesis that there is an intrinsic pool of cells that have low epithelial differentiation, and that is the reservoir, similar as we see in prostate cancer and other cancer, for your insensitivity to the drug you have, and here it's EV, and leads to later recurrences at different time points. This actually is confirmed in one of the cell lines, but there's many we do that as we're waiting for longitudinal data from patients, we see that this EV resistance in sublines actually show strong Nectin-4 downregulation and binding and internalization. As we move to the genetic context of that and trying to understand that, and we look at the parental cell lines and with the Nectin-4 amplicon, and we look at the subcell lines, we see that the resistance is not only due to this amplicon loss or this, because the amplicon is maintained as the cells become over time an acquired resistance. Maybe this Nectin-4 downregulation or can be outgrown by overexpressing, maybe not. We will look at that in a second. But what we see is specifically that it seems a very important component to explain that difference is the resistance to the payload. And that resistance to the payload maybe is very important as well. And we found that and we said, okay, this is maybe a second component in this multifactorial, and let's look at that. So here we did pairwise drug screening of parental and sublines of EV-negative cells and found some cross-resistance to many drugs. And what we see that is in actually the payload resistance happens to the ABCB. This is a drug efflux pump that is overexpressed. So Nectin-4 negative cells have a lot of ABCB1 overexpressive, which also explains why the bystander effect doesn't happen to that, because even if you have some bystander flowing over, these cells will remain resistant. What we also did, we tried to overcome with a specific inhibitor that is tariquidar, which unfortunately cannot be used in patients because it's highly toxic, but in cell line it works very well. Can you, by blocking this drug efflux pump, have a higher toxicity? Yes, that works. You can revert it. So that could be a strategy with a combination drug that be given if we found a specific inhibitor that is effective and non-toxic. So going back to our intratumoral heterogeneity in this systemic therapy naive patients, and we looked at that again and said, what is the component of your ABCB overexpression and the Nectin-4? And we found that EV resistance is certainly part of that MME resistance. I said it before. And what is interesting, sorry, I can't see that very well. What is certainly interesting in this slide, sorry, what you see is that this is also a resistance to other similar drugs that have the same mechanism of payload activity. So what that means is if you're going to use dizitimab vedotin with HER2, it's going to still have some resistance. So you need to change your payload, probably think about, and the ABCB, for example, doesn't work with SN38. As you know, this is from sac-govitecan, the substrate, and that would work very well. Now, another question that arises that is frequent, I think, as we look around the world, you know, EV pembro is quite expensive, it's not available everywhere, and it's, so people are thinking, why am I not going to use GemCis, and if I don't have, use it as second line as a salvage therapy? And we asked that question specifically. And what we found is actually that if you use GemCis as a, you may become resistant to EV pembro. This was our hypothesis to EV specifically. What we have created is, out of the cell lines we had, we created GemCis resistant cell line, and we selected them, and we found some cross-resistance to EV. So basically, if you expose to GEM-CIS, your Nectin-4 expression is going to go down, and even your ABCB1 drug efflux pump is going to be more active, and you can see it on the slides here. Specifically, the internalization is not going to happen as much, so there must be a third factor what this is happening. Looking at RNA sequencing data again across these models, we found consistent again here in GEM-CIS, this EMT signature. You find again that you have this epithelial differentiation that is lost, and therefore you don't have you have a mechanism of drug resistance. Sorry. So looking at human cells, we asked, is that true in human cells as well? Not only in the cells you grow in the dish, is it something that you find in vitro? Is something that you can find in your tissues as well? So we took matched pre and post neoadjuvant therapy, GEM-CIS exposed patients, as well as in an adjuvant setting where we had biopsies of metastatic sites, and we found that GEM-CIS exposed patients have a Nectin-4 downregulation in GEM-CIS in the primary as well as in the metastatic sites. And we also found that they become resistant to EV if treated in the dishes. So I think what we see on this work, and we're just dabbling in it because I'm a clinician and working in the lab on a hobby side with a young PhD, but what we see that there's a lot to be learned. There's some intrinsic Nectin-4 low and high expressors based on the amplification that is part of your acquired and innate resistance. You have subcells, but also the exposure or previous therapy, you may develop a acquired resistance. Taken together, I think that shows you that your ADC resistance is certainly multifactorial. There's intra and intertumoral Nectin-4 heterogeneity and dynamic loss that can happen on therapy, which poses a clinical challenge. As I said, you have 18% within a year in a metastatic setting that become resistant. You have an inherent and induced EMT state drive that drives also the Nectin-4 downregulation and EV sensitivity, insensitivity. You have also an induction an inherent existence, but induction of drug efflux pathways that are very important that we need to overcome, specifically thinking about sequential therapy and how there will be a payload cross-resistance and target down-regulation over time. GEM-CIS certainly is not good to be used. I think this is the conclusion, one of the clinical relevant conclusions. You cannot use GEM-CIS and then have EVP as a sequential concept. That is very important. And as we think in the future, and that's going to be part of the discussion tomorrow as well, we need biomarkers or markers, specifically as we have different payload-driven ADCs and you have bicycles, how we can determine the right therapy for the right tumor at the right time in the right patient and optimize this sequential therapy. In last 2 slides, I will show you what we have done in Austria. So over time, we have now received a small grant, for American perspective, small grant, European big grant, 8 million euros to look at all the patients in a small country, with a midget country of 9 million people. So we're looking at actually 70% of all metastatic patients, as well muscle-invasive patients, being captured in this activity. And we asked that just at the question that Francesco Montorsi has asked, can we forego this life-altering surgery? What is the patient's perspective, and can we overcome EVP resistance and failures? We're going to work on a lot of activities across different disciplines, and that was what I think Andrea was saying early on. It's really interesting. 5 years ago, 10 years ago, bladder cancer, nobody wanted to work with you. There was no money, no interest, no industry, nothing. And now suddenly all the other specialties want to work with you because they find here the most active, interesting thing. For example, one of the activities, we are standardly doing Nectin-4 PET CTs prior to therapy and after therapy. And currently we also doing Nectin-4 lutetium as looking as maybe the Nectin-4 expression is not going down, maybe you can salvage them afterwards. And concepts like this will be tested in this group, as well as a lot of translational research. We're also going to try to work with other groups as well to find what is resistant, what is a response mechanism, how can we use radiomics and AI components to that, as everybody else is doing. We also have a very ambitious trial that I'm not really sure the ethics will allow us. We are in the discussions. And what we want to do is actually, we realize it's impossible, like the Neoblast study, looking at randomizing patients to cystectomy versus non-cystectomy. So we said we're going to do an observational study and to a 2-stage consent trial within cohort. And in that concept, those with a 2-stage consent, only one arm that has been randomized will be offered a bladder sparing approach with the primary endpoint of quality of life, because it's not, I think that what matters to these patients, not only oncological efficacy, which will be probably tested and proven in larger studies that are international. And then another component is looking at those patients that fail EVP. We're going to do high throughput drug sequence testing within 24 hours in the lab and transcriptional expression, and look at in a molecular tumor board and try to find a drug that is an approved drug and allow the patient to get that and see if that would work better than just sequencing alone. This is the lab group that's working. This is our research lab. This is the PhD that is my junior partner, where we spend some time. As you see, we are trying to create some buzz around it and learn it, and obviously the whole clinical trial team and activities at department and research groups. Thank you so much.
Thank you, Sharok. Excellent presentation, and congratulations for all the work that you're doing. It's really, really astonishing. I think we have only 3 minutes for the discussion. We have one from Petros.
Sakar, my friend, always a pleasure. I have to get your slides so I can get smarter. The question for you is, we actually published a paper about a year ago from our research autopsy series. Our grateful patients signed consent when they passed. We did autopsy looking at the primary tumor metastatic sites, and what we saw, interestingly, was TROP2 and Nectin-4 expression, both membranous and cytoplasmic. And the cytoplasmic, to me, was a big question. Is that relevant, biologically, clinical? And I saw you mentioned that membranous expression matters. What are your thoughts on that part? And the one big question is, do you foresee a future where we'll have a biomarker for each ADC as opposed to the current state that we use and to everybody? Thank you.
Thank you so much. So I start maybe with the second one, and honestly, I certainly don't know more than you guys know, and maybe even much less. But I think certainly you're going to look, and you have the first, targeted ADC that was shown, and Andrea talked about it in his discussions. Previously. So I think that's going to be certainly a driver of a decision making, where we hope that the expression will give you a high likelihood of response. That is with Nectin-4 not happening. With HER2, we don't really know. With HER2 negative, we don't know. That the breast cancer literature has shown us that. But certainly that is the hope where this is going to go. But I think this is only a part of the story. As we've seen, it's also really a lot understanding about the cell type and understanding which subpopulation, even in the same cell type, happens, and your payload resistance, which is another. So I think that just the expression of that biomarker will not be sufficient. That is very important, certainly in the early acquired resistance mechanism, which we see, and the intrinsic resistance. So I think also the payload and what happened to the patient before in his natural history, and we heard that before, that if you're going to give your checkpoint inhibitor in a different setting, how that's going to affect your immunogenic activity that the EV is going to create, if you believe that creates some. So there's going to be much more complex decision making. It's not going to be a single biomarker. So, and the second one is really, if you look and you talk to pathologists about the membranous and the cytoplasmic, and there's a lot of opinions. Even if you stain cells, there's so much heterogeneity, and we really don't understand what the reason or the endocytic component of these vesicles, or what does that mean. We really don't know. And if that matters at all in where that drug is going to get into the cell. That is the question. So it may be present, is highly heterogeneous, but does it matter in your drug efficacy? That is a question we don't really know. But what is interesting, if you look at all these tissues, the most expressed one is TROP2. Nectin-4 is not that strongly affected on the membrane. So TROP2 is the main expressed cell. So we need to probably think about that one, how we can get that better, despite a negative trial, see how we can get more of that.
Sharok, you have been so inspiring to me. and you are so a role model in building up a group, a department, a strategy, a vision. And based on this, I have more a strategic question to you. So do you think that, based on the developments that we have discussed, and we are discussing today, that are multidisciplinary developments, do you think that there could be a possibility to build up an integrated department? So, in other words, what are your hints or your suggestion on how to build or integrate the piece of clinical trials into this model? So the oncologists with their clinical trials into this model, clinical research and translational research and surgery. What is your suggestion in a few words?
Oh, this is a very complex question, and I really don't know the answer to that. I mean, each environment has own culture, own settings, but I certainly believe the way we look at medicine that's based on 1800, 1900 concept of fragmented, organ-specific concepts is certainly not the way to do the future. Now, in our department, and Alberto was there, Marco was there, we have changed that, and that is, I think, specific to Austria. When I came from the United States, I had no clue, or I had a little bit because I was at Memorial and had some exposure to systemic therapy and understanding clinical trials, which is the DNA of medical oncologists, and we as surgeons have a little bit, we're asking those questions as individuals, but it's not part of our training. Certainly some translational research is part here and there, part of the training. And ideally, when I came in Vienna, we restructured our department because, systemic therapy was also done in the Department of Urology, not at a high level. One has to be very realistic about that. And so restructure the department to change, and there you have to start by the training you give the people and the people you hire. So in our department, we have internal medicine doctor, we have nephrologists that help us with the side effect management, cardiologists, we have a medical oncologist, Manuela Schmiedinger is in our department. So they work all together around the team. One of the benefits is we don't earn money. So there's no incentive of fragmenting the care of the patients. Now, I cannot get, I have even a radiation oncologist working in the department. So he will say, similar, so we're recreating what we have in a cancer center instead of the patients going back and forth. The biggest challenge in that is how you're going to redefine the training of the urologists of the future, or even of the other specialties, because you want them to have that broad experience of understanding incontinence as well, because that's going to also matter to the patient at hand, but yet not very early on have this, I would say, differentiation in subspecialties. Not having 6 years of training, but having maybe 3 years of basic urologists, and then training in different areas as they want to come along. So you're redefining what the urologists of the future will be, and the same is going to happen in a medical oncology and other specialties. Specific training classes and so on. Now, how to integrate the translational research, that is the most difficult because it's very cost heavy, absolutely necessary, and it's going to be the driver of progress, right? So for example, now we found your drug efflux pump inhibition, developing drugs that can deliver at the same time binding and developing that drug efflux pump inhibition, as well as it releases your EV, your payload, MMAE. So that could be a way of overcoming your resistance, and that's can only happen in lab, and needs to happen at academic institutions. So that discussion needs to go back and forth. It's very cost heavy. Research is not supported really. Translational research, we don't spend time. You have your clinical trials team that needs to talk to your translational researchers. They need to meet. The language needs to happen. It's quite challenging. I don't know what the answer is, but this is certainly the only way in the future of being at the driver's seat of developing the future therapeutic modalities.
Well, you made a very good point. That could be part of the solution to me, starting from the university, from the education. The university may be instrumental in narrowing the gap between clinical and translational research, urologists, oncologists, and radiation oncologists. So education first. Good point. Thank you.
Yeah, and one thing that we realized, we needed chemists. As you're going to do it. So, I studied 2 years chemistry before I did medicine, but I couldn't understand a single word what they were saying. So you need now chemists, you need other specialists. So you need a bigger infrastructure and partner with people exterior that come and now are attracted to working with you because you're getting grants, you're working, and that is happening now, thanks God. Thank you so much. Thank you.
So thank you for attending the session. I think now we have a 15-minute break before the next session. Thank you very much.
went together. In our prime we were birds of a feather, different kind. We were living through the pain. You were never once so late. Cut the cord that kept us connected, blacking out the mirror where your light once reflected. All of the love from up above, we used to feel like a glove. I still think about the you that only exists in my
you want. Don't give it up. Tell me what you want. Don't give it up.
With the other session, which is a tremendously interesting session. You cannot miss it. You cannot miss it. Maurizio, you cannot miss it. Please. Roberta Lacava is seated as well. Joep is drinking, so he's happy. We have lost Petros for sure, is lost out there. We have lost Phil, Ashish. Phil, we have you taken your radiosensitizer? We have already. Please take a bit of your radiosensitizer, you know, so that you can refresh, and Jason will treat you with special radiotherapy in certain areas that you may need. Down there somewhere. So I think we can start. So I have a pleasure to co-chair this session with Martina Sollini from the Nuclear Medicine Department. You know already her, she is part already of our retreat. She is a piece of the puzzle of our retreat. So we introduce the next session, which is focusing on the research project, as we usually do each year, starting first from the industrial partnership, the academia and pharma, academia and industry collaboration. We have a long track record of collaboration with the industry. And first, we start from Foundation Medicine, the one and only Jeffrey Ross, who is part of the core business team of our retreat, one of the founders of the retreat, you know. You know pretty well him, doesn't need any introduction. Jeffrey, this year, will guide you again through an update on the NGS possibilities, potentials, and opportunities for patients with geocancers. So without spending further words, Jeff, the floor is yours.
Thank you very much, Andrea. Once again, a pleasure and an honor to be here at the retreat this year. And if I could figure a way, I certainly would like to come back in March for the Olympics, which is going to be awfully exciting, I know, here and in Cortina. And I'm also wishing the national team better luck this coming World Cup than the last time we had World Cup here when we weren't able to see your team. But I know they will be back for the next one. So here we go. My presentation today is on the liquid biopsy, but focused on copy number calling, gains and losses. Here are my disclosures. So my outline is to talk about copy number calling, meaning amplifications and homozygous deletions, the technical issues, the big impact of the so-called tumor fraction in the liquid biopsy interpretation, the key amplifications of ERBB2 and MET in GU malignancies detected by liquid biopsies, and then the homozygous deletions of BRCA2 in prostate cancer and of MTAP in urothelial bladder cancer. So real quickly introduction, I mean, liquid biopsies have now been available for a number of years, and they certainly have advantages and disadvantages when compared to tissue-based next-generation sequencing for searching for cancer targets. I'm not talking about molecular residual disease or tumor monitoring, just using liquid biopsies for diagnostic purposes to define potential new routes of therapy. So the solid biopsy is, we of course know we extract the DNA from formalin-fixed, paraffin-embedded tissues, and we either can use the primary tumor, maybe a resection or a biopsy, or a subsequent metastasis biopsy. This will add time, cost, and some risk to the patient. The liquid biopsy advantage, of course, is it's a blood test, so it's a phlebotomy sample, and one of its great advantages, of course, is that the ordering oncologist does not have to deal with the pathology department in order to obtain a result, because the sample can be obtained directly from the patient without asking what's the best block, get a pathologist to review the best sample to use. On the other hand, the liquid biopsy has challenges because if it's ordered on the wrong patient at the wrong time, it can yield an uninformed result, a not useful result, and waste time and cost. So these are both very, very important factors when we start thinking about what should we do first, tissue or liquid, depending on the clinical status of the patient. And I like to say, without going through this chart very detailed, to go to the next one and say, it's not tissue first, it's not liquid first, it's the patient first. And an individual patient at an individual stage of their disease may be best evaluated by a liquid biopsy, or a liquid biopsy must very carefully be avoided so that a negative result is not obtained, and either going back to the primary tumor or obtaining a metastasis biopsy is the way to go forward. And that's based on the type of tumor, high shedders versus low shedders, the clinical stage, pathologic stage, sites of metastasis and ease of getting a metastasis biopsy, the treatment history of the patient, especially when the goal is to uncover resistance mechanisms, which may be very critical for their next therapy selection, and finally to use other guidelines like CEA and HCG and also PSA, which is a very good predictor of a successful liquid biopsy in a prostate cancer patient. We've published that if the PSA is below 5 nanograms per deciliter, you shouldn't order a liquid biopsy because most of those will not yield informative results in prostate cancer patients. So let's go on here and talk about the tumor fraction real quickly. This is a measurement essentially of aneuploidy. It does also include the presence of certain tumor drivers and certain SNPs that are included to determine it. The cutoff that's generally used is 1%, meaning how much of circulating DNA is derived from tumor cells and how much from benign cells, including clonal hematopoiesis. When the tumor fraction, that percent, goes up, the information becomes more reliable and useful. Unfortunately, as the tumor fraction goes up, the prognosis goes in the opposite direction. So getting a high tumor fraction may be useful in getting informative therapy targets. On the other hand, it will also inform that the patient's disease has progressed significantly. High shedders and low shedders. And when we look at this chart with small cell lung cancer on the far left as what's considered the top shedder of ctDNA, and then others to the right, like pancreatic ductal, we can put the three important GU cancers and see that urothelial bladder is in position 4 there. It's a pretty significant shedder of ctDNA and often yields a useful liquid biopsy. That prostate cancer is somewhat more in the middle, and again, if you use PSA level and as well as staging and imaging, you can pretty well avoid uninformative liquid biopsies for prostate cancer patients. But unfortunately, to the far right, we see renal cell carcinoma, RCC, is a low shedder and not as useful if especially you order it in an early stage patient where you may waste time and the patient's financial resources to get an uninformative result. So let's talk about the main topic, which is copy number changes, both increase, amplification, and decrease, homozygous deletions. And I want to talk about, for amplification, 2, ERBB2 and MET. For ERBB2, the main focus in GU cancer is bladder cancer, urothelial. We rarely see amplification or activating mutations in prostate cancer, and we almost never see them in renal cell carcinoma. But for urothelial bladder cancer, we've got really more than one potentially important change in the ERBB2 gene. Activating mutations, and we've talked often about the presence of the extracellular domain mutations in the micropapillary variant of urothelial carcinoma particularly, and we also see kinase domain mutations in all different types of urothelial carcinomas. But this focus on the liquid biopsy isn't the detection of those sequence mutations, which liquid biopsies can easily do. It's the detection of amplification. That's very dependent on the tumor fraction. If the tumor fraction is under 1%, there's a very strong case that a patient whose bladder cancer is ERBB2 amplified will be missed on a liquid biopsy. It just won't be detected, and it'll be a false negative result for that. So always careful when using liquid for copy number that the tumor fraction needs to be at least 1%, and even better, as we'll see, higher than that, even up to 5% and higher, to be sensitive to copy number gains. It's even more critical for copy number losses, but for now we're talking only about the gains. But you cannot use a liquid biopsy or tissue either to very accurately predict the lower levels of a potential IHC stain. If the liquid biopsy does report copy numbers in the double digits, 10 or higher, you probably can be pretty sure if you stained that tumor, it will be 3+ on IHC staining, and thus that bladder cancer will be on label in the US for trastuzumab deruxtecan, which has a pan-cancer approval at IHC 3+ and better. But you can't accurately predict 2+, 1+, and low and ultra low HER2 staining by the copy number, because once the copy number starts to drop below 6 and down to 5 and 4, you're just not sure what the staining would show. You have to do the IHC staining in order to be able to decide whether the patient does or does not have any ERBB2 alteration. Now let's talk about MET. This is a very, very important genitourinary cancer target because we know it has many now drugs approved in lung cancer. There are now 4 anti-MET drugs approved for lung cancers in different clinical settings. But in urothelial bladder cancer, we're just starting to understand the possibilities of targeting MET. But in renal cell carcinoma, we've learned that MET amplification or a copy number game, or maybe via a whole chromosome 7 arm gain, can be a target for papillary variant of RCC. And in talking about that, we had some very interesting presentation, and Monty is here. His team joined with us from City of Hope to talk about the gain of chromosome 7 and copy number gains or amplification of MET in papillary RCC, and I'm going to get to that in a second. Here's the quick list of those new drugs that target MET amplification in non-small cell lung cancer, which of course does also include an ADC, the telisotuzumab, which is not a naked antibody but an actual ADC. The adamantamab is a bispecific antibody that combines anti-EGFR with anti-MET, and that's designed for lung cancers that are EGFR driven, who've become resistant to the TKI, mostly osimertinib, and now has a MET amplification resistance biomarker that now a specific approved MET drug is designed to target. This started it all for me, and it goes way back when we founded Foundation Medicine in 2009, started testing patients in late 2010, 2011, and very early in 2013, through a relationship I had with a medical oncologist from way back in his general medicine training, we got sent a patient who was a young woman with both brain and abdominal cancer. Epithelial, not likely lung, TTF1 negative, and no thoracic imaging. And she was able to undergo a frontal lobe resection by the neurosurgeon, but unfortunately had a very large abdominal mass. We did the sequencing, one of the early patients, as a CUP, carcinoma of unknown primary, and it turned out to have 16 copies of the MET gene. There were no anti-MET drugs approved at that time. The MET exon 14 skipping mutation had not yet been reported in lung cancer by us, and we only knew that crizotinib, the anti-ALK fusion drug approved in lung cancer, had originally been developed by Pfizer as a MET inhibitor. And we went to insurance and said, can we try this on this young woman with 2 young children at home? And they said 90 days. You can have a supply of 90 days of crizotinib, off target. I mean, on target, maybe if you consider the early research, but truthfully, as on the label, it was both off target and off indication. And she went off on a 90-day cruise with her family, thinking that this would be her last chance to be with her children. And all I can tell you is when she came home, her oncologist immediately called me and she said, how do I get some more of those pills? And that's 2013, and she's still alive on continuing anti-MET targeted therapy. So MET is a target, and especially when copy number is very high. When it goes into double digits, this is the driver, and this is very targetable. Here's the data we just presented in Berlin a few weeks ago. Monty's fellow, Miguel Zuckerman, did the presentation. It was an oral presentation on MET, copy number increase in papillary RCC. And it's a curious story. We can't go into great details because you also know that MET germline mutations are an associated predisposition for the development of papillary RCC. But in advanced samples, like we see at Foundation Medicine, where they're metastatic setting when they're sent in for sequencing, MET amplification, meaning 6 copies or greater, is not that frequent. But when we look at just chromosomal 7 arm gain, where the MET gene is located, we do see that very frequently. So I think a lot needs to be decided about when you can target MET in papillary RCC. Now let's switch quickly over to homozygous deletion detection, and this is one of, if not the most challenging genomic alteration we search for with liquid biopsies. Remember that copy number change is not like base substitutions or short indels or fusions and rearrangements. It's not looking for a sequence abnormality. The actual sequence of the gene is wild type. It's normal, it's just too much of it. And the only way we can detect that is by doing some kind of comparison. How do we find the base to compare the tumor DNA? Well, one great way is to look for aneuploidy. You just say all the DNA we've extracted that has abnormal copy numbers of any genes is on the patient's tumor side, and all the diploid DNA is on the patient's white cells and who knows what else leaked into the blood, and say, well, how much of this gene, in this case we're going to talk about BRCA2 in prostate and MTAP in bladder, is lost in our what we believe is the tumoral DNA versus the normal. It's a comparison or a ratio, and if you don't have enough DNA, you just can't do it. You can't do it accurately, and you shouldn't report it. And we don't want to report probably copy number loss with tumor fraction below 1% as being a negative, because we don't know it's a negative. We never had enough DNA to look for it in the first place. Instead, we want to report it as we probably could have missed copy number losses because our tumor fraction in our liquid sample is too low. So let's talk about some of those. They're very, very difficult, as I mentioned, to find because it's a comparison. When the tumor fraction gets up to be very high, it's like having a metastasis biopsy. You have so much DNA, you have no trouble calculating the copy number of your target gene. But when it's low, it's really very difficult. And no algorithm, no computational biology program can make up for that. You can't guess what you think the loss is. If it's not measurable, you can't report it. We've worked on this for a long, long time. When we launched the Foundation One Liquid CD, we had no calls of homozygous deletion. We just stayed away from it. We felt it was too difficult, and we didn't want to mislead anyone who ordered the test. But with a lot of work on our copy number calling, we're now able to start to call certain genes. Just a subset, BRCA2 is one of the premier ones we do call because of its critical role in management of prostate cancer with PARP inhibitors. The second one that came out now is MTAP, and I'm going to spend a few more minutes with MTAP and my talk will be over. So here you can see top versus bottom how we've cleaned up and made the copy number plot that much more easily interpretable. So as you look at the tumor fraction impact, on this little set of curves, you notice on the very top is base substitution, and you pretty much can calculate all of them with any amount of DNA because they're very easy to pick up, the base subs. The short insertions and deletions, like the exon 19 deletion in non-small cell lung cancer and EGFR, are much harder to find, but you still can readily find them. Fusions, not as easy as base substitutions, but not too bad. But as you keep going down, MSI high, tumor mutational burden, you get down to amplification, which is a little easier to call, and then way at the bottom is gene loss, the hardest to call on a liquid biopsy. So here is this patient that really kind of started it all because we had a very rudimentary liquid biopsy at the time, and it really started with a metastasis biopsy. But his PSA was over 1,000, metastases just about everywhere, all the bones, lung, liver, and doing poorly. When we sequenced him, we found out he had a BRCA2 homozygous deletion, and we could see it on the liquid as well as on the tissue for this man. He went under PARP inhibitor treatment, had 1,000 PSA crash down to undetectable over a period of 6 months, and disappearance, as you can see in some of the imaging, of all the solid metastases and massive changes in the bone lesions. And he lived more than 6 years with prostate cancer that advanced. And that's when we knew that BRCA2 loss or homozygous deletion is not the same as BRCA2 inactivating base substitution. Those, unfortunately, the base substitutions over time will undergo further mutation under the stress of the PARP inhibitors and develop the so-called BRCA reversion mutations. And they make a new BRCA protein, not the perfect wild type, but close enough to start functioning, and the homologous repair, the MMR is lost, and suddenly these tumors are no longer PARP inhibitor sensitive. But with BRCA2 homozygous deletion, there is no BRCA2 gene at all. So there's no ability to transform into the reversion mutations and become PARP resistant. So they stay PARP sensitive for months and years. And that's why it's so critical we find these men. I've estimated for castrate-resistant prostate cancer, 3% of men have BRCA2 homozygous deletions, of which only a small portion ever know that during the course of the disease. They don't get next-generation sequencing, the BRCA2 loss is not detected, and the ability of PARP inhibitors not only to control their disease, but maybe to replace some of the other therapies that are ineffective that they're receiving, both hormonal therapies and chemotherapies. Prolonged response to the PARP inhibitors with BRCA2 loss we've published in multiple different settings and from the real world so-called Flatiron database. I think this is well established now. We must look forward. 3% of hundreds of thousands of men alive with metastatic prostate cancer is a lot of men. None of them should be unknown to their doctors to have this very targetable alteration. But for liquid biopsies, we have to have the tumor fraction elevated in order to be able to detect it. So if you use a liquid biopsy to try to find BRCA2 loss and your tumor fraction comes out at 1% or 2% and it's not there, you can't assume it's not there. Not enough DNA extracted to be certain that we didn't miss it. And then lastly, I'll finish talking about MTAP, an exciting, evolving story that we're working here together with Andrea and the team, you know, at San Rafael. MTAP loss, given recent efficacy data, may become one of, if not the most prevalent alteration in solid tumors that we've ever tried to take advantage of. Remember, MTAP itself is not a target. MTAP is a predictor of vulnerability of an MTAP depleted or deleted tumor to the impact of either a PRMT5 or an MAT2A inhibitor to cause synthetic lethality, to have the cell, because of its deranged metabolism, create metabolites that are lethal. They can live okay with an MTAP deletion, but when you add the PRMT5 inhibitor or the MAT2A inhibitor, you drive up the metabolite levels way higher, and then the cell dies from its own synthesis. And I put a little chart there for you. So what about this? It's correlation. What's the best test for MTAP? Is it next-generation sequencing or immunohistochemistry? And the answer is they're complementary, and in most settings, like you see here with these bar cards, they're very, very, very much correlate with each other. But MTAP is an 8-exon gene, and when you look at the array of numbers of exons lost in an MTAP-deleted tumor, they're not always all 8. But 7 of 8 or 8 of 8 are well over high 80s, maybe low 90%. But then in that final 10%, you can have 3 exons lost, 4 exons lost, 5 exons lost. But the only one that probably matters is 1 exon loss, exon 8. Those are probably MTAP functioning, meaning the NGS calls it MTAP loss, the IHC still stains the protein, and the patient probably is not a likely responder to a PRMT5 or an MAT2A inhibitor. So we now just are dealing with that last 0.5%, the single exon loss. We can detect it by NGS, and that's where you'll get the discordance, where the stain will be there, but the NGS test says deletion. It's not a huge problem since way over in the high 90%, there's enough exons lost for the protein to disappear and the cell to be vulnerable to the PRMT5 or the MAT2A inhibitors. Here's just a quick chart that shows the high concordance of IHC and NGS. Right now, the drugs, and there are many companies, as you probably know, have PRMT5 and MAT2A inhibitors. Most are doing NGS, and many are doing NGS and IHC. What will be the companion diagnostic, assuming these drugs get approved? And we just saw one set from Tango Therapeutics move into phase 3, showing efficacy in phase 1 and 2A, both as single agent and in combination with the new RAS inhibitors from Revolution Medicine. I think most feel there's a good chance these drugs will make it into a registration trial and an approval. Probably the NGS will be the better test because it can give you so much more information than just the MTAP status. By the way, in the work we've done here, especially in bladder cancer, we can say that the other biomarkers like FGFR3 are not reduced by MTAP loss. So you will always have targeted therapy options as well as targeting MTAP with the PRMT5 or MAT2A inhibitors. And now we're also starting to learn the impact of MTAP loss on responsiveness to immunotherapy-based regimens. So a lot still to do, but it's something we can detect by liquid biopsy, but only when the tumor fraction is elevated enough that we have enough DNA to make a copy number call. And I think this brings me to my end, except wanted to just show, Chiara is going to present this. We hope, we haven't heard from ASCO GU yet on our abstracts, but we hope we'll present this in San Francisco in February, showing that as the tumor fraction increases, the ability to call homozygous deletion of MTAP increases to start to be approximately as sensitive as it is when we have either the primary tumor or a metastasis tissue biopsy. So hopefully this is a chart made from something not accepted yet, but we're hoping that it will be. And my conclusions, liquid biopsy rapidly growing. It's very convenient and easy to use. Tumor fraction is critical for making a rational assessment of what the liquid biopsy shows. Remembering low tumor fraction means you can't rely on the liquid biopsy results because alterations can be missed, especially copy number gains and losses. So they're very difficult and almost impossible to detect when tumor fraction is below 1%. But important copy numbers are impacting. I apologize to Niraj that I didn't put P10 homozygous deletion calling and prostate cancer with the impact on capivasertib and other drugs like that. I almost tried to do it while he was talking this morning, but I decided at best I'll just save that for another time. But for BRCA2 in prostate and for MTAP in bladder, as well as calling copy number gains in liquid biopsies, I think this is going to be very useful going forward as long as we know how to interpret the results. Thank you very much.
Thank you, Jeff. Yeah, let's leave the discussion at the end. I am just prior to send the word to Martina. I am a big fan of MTAP loss. In our platform, in neoadjuvant platform, Pure1, Sure, combo, we are around 25% positivities of MTAP losses in MIBC. So it definitely it is a target, provided that PRMT5 inhibitors seem to be more stabilizers than providing partial or complete responses. So maybe they could be good for maintenance therapies or combination therapies and so. But it's exciting. Please, Martina.
Thank you, and it's my pleasure to introduce Job de Jong from Rotterdam, who will give this talk about RNA expression results in bladder cancer.
Thank you very much. So I'm thrilled to be here. I want to thank Dr. Necki and the full organizing committee at the San Raffaele Institute for having all you thought leaders in one room. And it's a pleasure to be discussing how we could potentially leverage transcriptome-wide expression data for clinical decision-making in bladder cancer. And I'm based in the Netherlands at the Erasmus MC Cancer Institute, but my disclosure is that I'm discussing much of the Decipher bladder data. So I think it's important to realize that as a field we've come quite far in using gene expression data to characterize the molecular subtypes of bladder cancer. And I also want to state that there are many ongoing groups that have been proposing different subclassifications, and I don't think that there's not one that's right, but we can use all of them in different contexts. And the first one that actually involved Decipher bladder was a publication led by Peter Black, and basically they showed that the distinction between luminal and 3 of the non-luminal subtypes could be used to assess prognosis in the radical cystectomy only setting. So I think in the meeting it's good we highlight there's a lot of emerging therapeutic options as neoadjuvant systemic therapy, but there's still a lot of undertreatment. So this is in a radical cystectomy only setting, showing that the luminal subtype has favorable prognostics after surgery only. Then basically the Decipher bladder came to life because they wanted to make like molecular subtyping accessible for clinicians, and they're the only commercially available test, at least in the US, and they make the distinction between luminal and non-luminal subtypes. And on the non-luminal side we have like different ramifications potentially for different treatment decisions, which I'll be highlighting in the next few slides. So after the first publication showing luminals have better prognosis after radical cystectomy only, we wanted to look at pathological upstaging as well. So when we think the tumors on the muscle invasive, but also on the T1 non-muscle invasive bladder cancer side are organ confined, radical cystectomy could be a salvaging therapeutic option, but we do know that in 30 to 50% patients are actually upstage at radical cystectomy. And I think that's important to highlight because that actually represents a missed opportunity to apply neoadjuvant systemic therapy. And I think it's also important to mention that in the first neoadjuvant chemotherapy publication by the Grossman group in the New England Journal of Medicine, the benefit for neoadjuvant chemotherapy was actually most in the T3 and T4A subset of patients in that publication. So I think once you could know when a patient is more likely to be upstaged, you could prioritize them for neoadjuvant systemic therapy. And I think that's especially important since we're, like I said before, undertreating a lot of the patients, especially in Europe. Like we did a trial in the Netherlands where we used circulating tumor cells to prioritize patients for chemo, and still like only a minority of those got referred to medical oncology. And the good news, which is also highlighted by the previous talks, is that we will be having more options on the neoadjuvant side of bladder cancer. And I think that highlights the unmet need of like molecular biomarkers for precision cancer therapeutics. So this is again to highlight that even though it's standard of care, neoadjuvant chemotherapy has been underutilized, and I think the promising results from the EV-Pembro side are exciting, but there's still always the concern of toxicity to be considering. And basically what we wanted to do is compare the luminal, non-luminal distinction also in the treated and untreated setting. So again, this is not a randomized trial, but it's a propensity score matched analysis where you can see that the all-comer benefit in the population was 7% by neoadjuvant chemotherapy, but the benefit was mainly observed in the non-luminal subtypes. So these are like 4 studies that are stressing the importance of molecular subtyping at the diagnostic TURBT tissue. So many thanks to the San Raffaele group who have been phenomenal in conducting neoadjuvant trials, either with the combination of chemotherapy with immune therapy, but also immune therapy alone. And we were able to run the Decipher bladder transcriptome-wide assay for the PURE-1 trial, which was led by Dr. Necki. And we saw that the one ramification of the non-luminal subtype, namely the Claudin-Low subtype, had like way favorable outcomes over the other subtype in the neoadjuvant pembrolizumab plus cystectomy setting. And then secondly, Dr. Gupta, who's also in the audience, did the BLAST-1 trial in the US, where she combined nivolumab with chemotherapy also in the neoadjuvant setting. And there we observed that the luminals had the lowest rates of pathological complete response. The non-luminals did have higher rates of pathological complete response, with exceptionally the Claudin-Low tumor subtype. And then, led by Dr. Mercinelli and Dr. Necki as well, the NeurCombo trial also evaluated nivolumab together with a different type of chemotherapy. And there, the luminals also showed lower complete pathological response. And I think it basically also highlights the importance for subtyping in the future bladder sparing trial to look at the complete pathological response outcomes. So this is to summarize the transcript on why this gene expression data was involved in 3 of the phase 2 chemotherapy studies. And I think also particularly interesting with the 3 systemic immune therapy trials being reported out, as Dr. Kamat highlighted at ESMO, is that the Cypher bladder was also analyzed in the non-muscle invasive bladder cancer setting. So this was one of the slides that I just showed you previously. And when you look at the charts in the patients that got clinically non-muscle invasive bladder cancer undergoing radical cystectomy, there was a significant increase in patients that were actually upstaged to muscle invasive disease by being non-luminal. So this also highlights that at the diagnostic part we do better, and of course we will be having MRI and ctDNA, but the subtyping comes in handy to also like identify the biologic profile of the tumor and potentially susceptibility to any of the neoadjuvant therapeutics. Then, because this is like a heavily pre-treated setting of non-muscle invasive bladder cancer patients because they got radical cystectomy, which is generally when they are BCG refractory or unresponsive, we also wanted to look at outcomes for non-muscle invasive bladder cancer in the full treatment spectrum. So we got in touch with the Bladder Cancer Prognosis Program in the United Kingdom, and we analyzed the high-risk non-muscle invasive bladder cancer patients in terms of overall survival, because this was a proper endpoint, because this was a population registry. And then we observed that the non-luminal subtype was also significantly associated with overall survival outcomes. And even when we applied the novel 2024 guidelines for determining very high-risk non-muscle invasive bladder cancer, the overall survival endpoint was still significantly associated with baseline subtyping. And I think this is particularly important because the very high-risk group, according to the EAU guidelines, state that you can actually consider escalating therapy based on a radical cystectomy. And potentially the molecular subtyping could come in handy as like an additional decision data point to be considered with the patient preference and the physician expertise, of course. So we also wanted to look at the endpoint of clinical progression, which was either defined as progression to MIBC, going over to radiotherapy or cystectomy for BCG refractory disease, metastasis on imaging, or bladder cancer-related deaths. And even though the progression rates to muscle invasive bladder cancer were low, considering these 4 points as an endpoint, the non-luminal subtype was significantly associated with clinical PFS. And then, interestingly, because the Cypher bladder is Medicare covered from T1 to T4A disease in the US, our collaborators at Rutgers Institute in New Jersey decided to run the Decipher bladder assay on their patients that did not undergo neoadjuvant chemotherapy or EV-pembro in the future. And then you can see that from these 6s, which have been submitted to the AUA as a case report, the 2 luminal cases did not show non-organ confined disease at the radical cystectomy specimen, and one of the luminal T2 cases actually got downstage to being PT1 without neoadjuvant systemic therapy. And although it's only a case series, I think it's promising to show that the literature research evidence could potentially be translated to real-time clinical information and therefore could come in handy as additional information to patient healthcare. And this is PI'd by Dr. Necki as well, which has been discussed at ASCO. But even in the bladder sparing fashion, we observed that being luminal at baseline showed better complete clinical response after neoadjuvant sacituzumab together with pembro. And then the question arises, does this in part be explained by the luminals being a lower pathologic stage, so more easily having a clinical complete response? But I think importantly, the luminals show more of the target proteins that are also susceptible to SG. So I think it's a good combination showing the potential importance of molecular subtyping also in the bladder sparing space. This is a slide to highlight that we're involved in many ongoing studies and we welcome collaborations on all aspects of bladder cancer care. And just to highlight that we're awaiting some of the important results also from the Gusto trial, where, for example, the luminal class is skipping neoadjuvant chemotherapy, and Lumberneck, based at Rutgers University, for which we did the pilot study, they're evaluating also omitting chemotherapy in the neoadjuvant setting, based on the luminal subtype as well. And then this one has just previously been mentioned as well. Veracyte will be offering like a ctDNA assay together with their transcriptome-based molecular subtype assay, and they will be combined in future trials where, for example, Neoblast assesses like ctDNA positivity or negativity to determine like a complete clinical response, and then they go over to randomization to either active surveillance or definitive local treatment. And I'm highlighting this because it's my future wish to combine like ctDNA together with the identity of the tumor at the transcriptome level for future clinical decision making, and to actually unravel the potential of these different molecular assays. We need all of you to integrate this and see where the clinical decision or actionability can be made. This is the Decipher Grid for bladder, which is more famous for prostate, but Grid basically offers the potential for translating literature signatures to any of you desire, to translate those onto the Decipher data and see if there are like clinically association possible with the research findings. And the reason why it's interesting is because it's like 43,000 genes per patient. So any of the signatures you guys have been interested in on the research side, we could potentially evaluate in the clinical setting. And again, it's so far the only commercially available test as well in the US. I'd like to thank you very much, and I'll be, of course, happy to answer any of the questions.
Thank you, Joab. Illuminating. Let's skip the discussion at the end, yes. Okay? If there is any question at the end, we will collect. So let's move finally to the latest updates on MRD testing in GU cancers. Who better than Andrea Cruz, one of the new international medical directors of Natera, to speak about the developments in ctDNA in GU cancer. So please, Andrea. It's a pleasure to have you as a new part of the retreat.
Thank you, Professor Necchi, for the kind invitation to be here and for your kind presentation. Congratulations also on the organization for this great event. It's a pleasure to be here for the first time, delivering the latest updates on molecular residual disease testing in GU cancer, focusing mostly on bladder cancer. This is my conflict of interest currently. So it's a pretty exciting era for circulating tumoral DNA, as most of you probably are aware. The concept of molecular residual disease and its eventual application on clinical practice on the near short term future or right now. And ctDNA can be described as a highly specific and dynamic biomarker. And it gives us the possibility to, in a dynamic fashion, to quantify the burden of the disease in real time. And this can have multiple applications on clinical practice in the continuum of care of the disease. As you can see, not only for early detection and also for diagnostic, which is not the matter of today's presentation, we are focusing more on the neoadjuvant setting and especially on the adjuvant setting, but the concept of molecular residual disease can have utility on all the continuum of care. And by the levels of ctDNA we can track through the assay, we can affirm the burden of the disease and make decisions out of it. And MRD is the concept of micrometastatic disease, which is the big problem that as oncologists deal in clinical practice is the images are negative, the patient seems with no evidence of disease, but then the cancer recurs. So it's the possibility of timely track this minimal residual disease, and this will eventually lead to treatment decisions and to better outcomes of the patient. Signatera is a tumor-informed, personalized approach. So it uses a sample of the tissue on the first testing, and then blood testing for the subsequent testing. And this is the particularity of the assay. It's being tumor-informed, personalized for the specific cancer of that specific patient. First, whole exome sequencing is performed on the tumor and normal blood match, and then a multiplex customized PCR assay is designed based on the 16 clonal mutations found on the tumor, the most prevalent through computer models. So the most important clonal mutations are tracked subsequently on the blood. This is our complete portfolio currently. Obviously, in Europe, we are focusing on the whole exome sequencing, but we have other tools that will eventually be available in a near-term future, like the genome, the Signatera run on UTDNA, extremely important for bladder preservation strategies on ongoing trials, and also the tissue-free option, still only validated for CRC, but also complementing the whole exome sequencing assay. MIBC. So currently neoadjuvant response monitoring, adjuvant treatment decision, surveillance, and also in metastatic setting IO therapy monitoring. Let's focus on the adjuvant setting because this is where the majority of the news and the updates and potential clinical applicability comes right now. We started in the observational data with Aarhus University on Denmark. So this is our major foundational data with ctDNA, with Signatera on bladder cancer, an observational cohort of 68 patients with multiple time points of collection of for the assay. And a clear prognostic sign was revealed in whatever time point of the ctDNA testing. So even if it's on the baseline, post-neoadjuvant treatment, or longitudinal testing during surveillance, the signal is pretty clear, and the hazard ratios are the ones you can see. So prognostic effect on this first trial clearly associated with better outcomes on the negative patients. And this goes for DFS and overall survival. From this, investigation continued. The first phase 3 trial that Signatera ran, a retrospective analysis, was run on a retrospective fashion in IMvigor10, which you all know didn't meet its primary endpoint for atezolizumab adjuvant treatment, but the pre-specified ctDNA analysis, this just to show you that the biomarker eligible population was very similar to the intent to treat population in terms of baseline clinical features, baseline ctDNA status, and the similar results, the similar curves for DFS and OS. And the retrospective analysis showed that Signatera not just is prognostic of patient outcomes, but also predictive of treatment effect. In this case, ctDNA positive and only the positive patients derived benefit from atezolizumab treatment, both on DFS and overall survival. And this is the confirmation of those curves in an extended follow-up. And from a trial, a phase 3 trial that didn't meet its primary endpoint, but the retrospective analysis showed this predictive benefit with testing of ctDNA, the stage was set to start looking for this prospectively in the first ctDNA-guided randomized phase 3 trial. That basically, as the population we all know, so residual disease post-cystectomy, high-risk disease, no evidence of cancer on imaging, and the patients, only the positive ones were randomized. And this trial has a particularity on the design that it's not a single time point testing after a cystectomy. So the patients were tested for a period of 1 year, every 6 weeks for ctDNA, every 12 weeks for imaging, and they could be randomized if they turned to be positive during this year of surveillance post-cystectomy. So it's almost like a delayed adjuvant decision, and this has multiple implications on clinical practice, so there's no need to decision right with a single time point. Of course, if the patients are positive at the first time point, they could be randomized, but it's a very interesting design in terms of delayed adjuvant decision, almost a treat on molecular recurrence decision, which is a new concept that MRD provides us. So if the patients were randomized, could be randomized to atezolizumab and placebo, and the negative patients were kept on observation. Oh, sorry. Interesting to see in the consort diagram that by the time the patients were tested for ctDNA, 72 patients were already metastatic. And here's also the value of ctDNA testing. A positive patient that eventually could be included on a standard adjuvant treatment with immunotherapy. The testing provides the tools to, okay, let's see this patient, probably there's a metastatic setting here, and the fact is in 379 patients which were positive, 72 were excluded for the randomization because they were already metastatic on imaging. Sorry. Also to highlight the fact that 60% of patients approximately were positive on the first testing. And this is important because it's a serial testing every 6 weeks. It's important to consider how is this feasible on clinical practice, testing patients every 6 weeks for 1 year. So the fact that 60% of patients were already positive at the first testing is of utmost importance. And also 17 got positive less than 5 months approximately. And also important to highlight that the negative patients were better prognostic patients, let's say, so smaller tumors, node negative disease comparing to the positive patients, and that makes sense. So this is the first readout of IMvigor 11 negative arm last year, and then this year presented at ESMO by Professor Pauls. So we can see that on the positive ctDNA patients, there was a clear benefit with a hazard ratio of 0.64 for atezolizumab comparing to placebo. So ctDNA-guided treatment doubled the DFS on the positive patients. And also, similar trends, similar confirmation, statistically significant on OS, hazard ratio 0.59. So an improvement of 41% on the overall survival. This is quite impactful in clinical practice. All the subgroups showed similar consistent benefit on the positive patients benefiting from atezolizumab. And here we can see that the timing, the issue I was referring, the timing does not interfere with the results, with the outcomes. So hazard ratio 0.62, 0.66, irrespectively of the positivity at an initial testing or a subsequent testing, okay? So pretty consistent, the results, even if the ctDNA comes positive much later during the course of the 1 year surveillance. And same importance, the negative arm. This obviously can lead to a lot of discussion that is already being held everywhere, I would say. The value of the negative, can we just observe the negative patients? The curves obviously are very exciting. Without any kind of treatment, overall survival after 2 years of 97%. I would mention again that this is serial testing for 1 year. Patients were not tested after 1 year. So eventually, these numbers could be even improved if we kept testing those patients. But the outcomes are exceptional even without adjuvant treatment. Not just the IMvigor 11 data, but also we need to reinforce this data because we know that atezolizumab is not a standard of care, at least in Europe. And it's also obviously important to have more and more data supporting the MRD-guided approach. And we also saw at ESMO that the retrospective analysis of Checkmate 274, that you probably all of you are aware, testing nivolumab versus placebo, on the adjuvant setting the 5-year follow-up was presented, confirming, of course, the outcomes we already knew and gave approval to this regimen. But now we have the information. Of course, it's retrospective. It's not an IMvigor-like randomized data, but it's a retrospective analysis of a big and important phase 3 trial with a standard of care already approved treatment. And 133 patients were performed the ctDNA analysis and an MRD detection of 40%. MRD detection meaning patients who are positive on the assay. And as you can see, DFS and OS with other ratios also very promising, and also showing the predictive nature of nivolumab. Not just prognostic, but the predictive nature with similar curves for positive patients as we saw on IMvigor. So this reinforces the possibility of using the testing not just as, let's say, a CDX for atezolizumab, but also as a proof of concept for adjuvant IO. Also, retrospective analysis on Niagara trial, which you all know and was already presented, and the similar trends. So the retrospective analysis with Signatera, ctDNA status at baseline was prognostic for event-free survival. Also, as expected, more clearance, meaning turning positive to negative after treatment, more clearance rates on the durvalumab arm. And this was also prognostic for event-free survival. And also, the detection was highly, so positive patient, at a very low probability of achieving a pathologic complete response. And again, post-cystectomy, very good outcomes if a patient is negative. So with all this, how can we fit all this information in the current perioperative paradigm of treatment? It's a good question. We don't have answers for it right now, at least in terms of we should do this or that, neoadjuvant or adjuvant, but we can try to integrate this that we already have on the adjuvant setting and try to translate this for perioperative setting. And this was a schema brought by Alex Wyatt on ESMO, addressing precisely this. So we have now, obviously not in all countries, but we have a lot of options, not just standard of care neoadjuvant chemotherapy, but we have now adjuvant options, one of them ctDNA guided possibly, and you also have the perioperative setting. And how to fit this? Again, we only have the retrospective analysis, more trials are ongoing, but conceptually, we can think in the future of how to deal with a high ctDNA testing and a low ctDNA testing at baseline, during and after neoadjuvant treatment, so possibility of intensification if high ctDNA or no clearance during neoadjuvant treatment, if low ctDNA eventually de-escalate or bladder sparing strategies. Adjuvant setting, start treatment on positives, we know that, of course, but eventually intensify treatment because the curves are better for atezolizumab, but they are not what we want it to be for patients. We want higher and better outcomes. So eventually intensifying those patients. And for the negative patients, and this will be addressed in modern trial, a randomization on this arm that we don't have with IMvigor. So a lot of information and potential clinical applicability can be assessed by ctDNA testing in this new era of treatment. Also, the role of UTDNA, Professor Necki presented it in ESMO, already discussed today, but just to highlight again, the use of the intravesical therapy, TAR-200, plus sertralimab versus sertralimab, and that the fact also UTDNA can be very helpful. And we see that there's a strong association with pathologic complete response. So 81% of pathologic complete responders after treatment were UTDNA negative after treatment. So there's a complementation between the two testing. With UTDNA, we can have a better local assessment for decisions, but also complementing with ctDNA may gives us a bigger picture idea of the systemic scenario or micrometastatic disease that UTDNA is not so capable because we want to highlight the local response. So the complement of the two, perhaps it's the way to go for this new era of neoadjuvant, perioperative, and eventually bladder sparing setting. Obviously, we want to keep this growing. We want to keep this more accessible to patients. We want to expand our evidence. I would focus the modern trial because it will address the question on the negative patients that will be randomized for nivolumab or observation, and we will have that question answered either way with that trial, hopefully. And we also have the bladder sparing ongoing trials. That is a big focus of ctDNA testing, and will also give us some answers in the future. Just to update you on the modern trial design, so as I told you, intensification on the positive patients. Is it nivolumab alone not inferior to intensification? Let's see that. And also in the negative arm, IMvigor didn't do this way, so IMvigor observed those patients with very good outcomes. But here we will randomizely have the results for nivolumab versus surveillance. So this is going to be a very impactful trial when the results are read out. Just for summary, 2019, the first observational data, and we are now seeing how to fit these very important data results into clinical practice. And is it prime time already for adjuvant treatment decisions? Is it a proof of concept for the current standard of care approved adjuvant immunotherapy? How do we translate this data on the perioperative setting? Thank you very much for your time.
Thank you, Andrea. So you touched the most important point to me for current research on ctDNA, utDNA. So let's start a brief discussion point on these three talks. So 5 minutes for the most burning points and questions and comments. You know, for sure, most of the discussion point that we did with your talk, Andrea, will be also covered tomorrow. More in depth with the focus meeting on liquid biomarkers. We'll hear also directly from Galsky the updates from Modern and other folks from the IBCG and GSRGT. The aim basically is to try to see if we can implement the definition that we did last year of clinical complete response. We resulted last year in the definition of clinical CR as negative imaging, negative biopsy, RT-RBT, negative cytology, and nothing more. So leaving the biomarker part still as experimental. So maybe today we are there is a one opportunity. We are in the prime time for ctDNA use incorporation into real world ctDNA CR definition. But for sure, I look at Marco and other colleagues from the Italian and European part. We are very much eager to get this test for routine practice. You know, they are so far from reality in extra US countries. So this is another point that we'll touch. They will be touched with the EMA guys and IFA guys tomorrow. So Petros, you have a question, please.
Grazie, Andrea. A great discussion. Andrea, the question is for you, my friend. Great presentation. We'll discuss some data tomorrow at the symposium. My question is specifically for patients who may go for bladder preservation. In the context of radiation therapy. You mentioned the Archer trial, and I know Jason and me just discussed about it. Can you talk a little bit more about other trials where ctDNA may inform decisions about radiation therapy? I know the SWOG and RG-1806 trial, we're generating data. Anything else in that landscape of radiation? Thank you so much.
Thank you for your question. We have data, I didn't show for the sake of time, but we have data on 3-modality treatment on the preservation setting, and the signal is there. Okay, so we show the prognostic effect on the 3-modality treatment strategy, and we know that the negative patients have better outcomes. Of course, this is observational data, nothing randomized. We will have Archer in the future to address in a different way this question, but the data and the signal is there. So let's see what the future brings us, but for now we cannot obviously advocate for that, but the signals are good.
So yeah, for Jeff, brilliant talk as always, so much to learn. So, I've heard from a lot of molecular pathologists who are really good friends. One of them is my wife. They always tell, personal quote, Foundation Medicine has one of the most robust platforms for these sequencing. But we are approached by a lot of companies to use their test. And everybody claims that they have the best test for everything. What question we should be asking them? Specifically, like why should I be using your test, especially with the liquid biopsy, liquid NGS testing?
My answer would be because he's a friend of the retreat, so you have to use this test, but this is not a scientific answer.
Can I go ahead and answer? Niraj, obviously the best would be which test leads to the longest disease-free and overall survival of the patients tested. Meaning the outcome is in months of quality of life of the patient whose tissue was tested, because missing something critical can lead to loss of a chance for longer survival with no question. And the data exists and it can be obtained, but there's this industry concern about the competition, and what kind of things you can say and you can't say, and then the lawsuits that occur when you claim superiority with data that will be contested, both in the public domain and in the legal domain. So, but really the ultimate comparison has to be patient outcome. What else can be better than that? We have started to look at it, there's no question. We just got an approval of a paper coming out, just comparing not companies, but the hybrid capture, the Illumina platform versus the proton comparative study from life sciences, with significant differences. Now, that's not survival, that's just finding this, finding that, and you have to infer, well, if you'd have known that, you'd have treated the patient differently. But the Flatiron database is kind of resisting doing that. They have contracts with everybody, and they don't necessarily want their different companies competing with each other in a way that could fall on them. But from me to you, it's patient outcome. It's the only way to tell the best test or the better test versus another.
Phil.
That sort of takes me on conceptually, I think, something critical. And this always comes up every single year. We have NCCN annual meetings and we look at the biomarker space. So I think the meeting being set up tomorrow is critical. And I think, obviously we're looking at what's going on in the ctDNA space very carefully. And I'm glad the prospective validation studies are happening. But to Jeff's point, I think a lot of the questions now that come up is, how do you make this actionable? When do you intervene? When is it the right time to sequence with local therapy, systemic therapy, combination therapies? How do you use that data? Obviously, AI may help us sort of synthesize a lot of this information and to put in the radiomics and other aspects to really look at our patients in a much more three-dimensional space. But it is no question, I'm glad to see these studies are integrating the ctDNA component, because we need that study, because clinicians are, as we all know, are using this anecdotally in clinical practice, but I don't think we necessarily have the tools to understand exactly how we use it and when we use it appropriately.
Yeah, I agree. We'll discuss tomorrow. There will be a particular statement that we put in the poll in the IVCG Fox with regards to the serial testing versus single-time testing. It would be interesting to see and discuss around this, yeah. Prior to you, Maurizio, I have a question to you as urologist. When dealing with the UTDNA, do you think that the UTDNA data are ready for prime time as compared to other tools that you have in use currently in daily practice, for example, Eurovision and other tools? Do you think that we need at a certain point a kind of comparison with the existing tools? Or UTDNA are good enough, are good shape enough to be used as a way of selecting patients? What do you think regarding the existing test?
Yeah, I was just making a question about T1I grade with ctDNA, because for us it's very important in order to know what gonna be happen in a patient with BCG or not. I mean, it's a kind of test. But coming back to your question, I really think we should compare, because Eurovision or other techniques are very important, but I think are very important in order to get CIS, in order to stratify patient for a progressive disease or not. So I think.
So do you think that they could perform the same, similar to the UTDNA test?
We need trials.
Yes,
of course.
Francesco?
Still missing a comparison with UTDNA, because with the RNA-based biomarkers we have a lot of trials now. Also, we start with randomized trial in order to stratify patients and to skip follow-up. But I think we have less data for UTDNA, so probably I think we need a comparison also to select, to be able to select in which setting we could use a different biomarker.
Maurizio, please.
I have a question for you. Nice presentation. I mean, I was very interested, I said before, in a set of patients, T1 high grade, for instance, with CIS or not, and do you have experience with your ctDNA before and after?
Thank you for the question. We have short data on non-muscle invasive bladder cancer, and the data we have only proves that we can prompt earlier imaging and eventually go for an earlier cystectomy. So patients who were positive, they were tested, and they went to cystectomy. So it's very short data, observational, a few amount of patients. So it's not yet randomized or big enough to jump into prognostic or predictive conclusions, but for prompting earlier imaging for cystectomy.
Because the very first test, the very first protocol was used in Rome many years ago. They used ctDNA in this kind of patients, and they show what you said before. So, but it was not randomized trial, it was just few patients.
Thank you again to all the speakers, and it's now the time to move to the next part of this section on the overview of the ongoing academic partnership. And it's my pleasure to invite Dr. Giorgio Brembilla, who will give an overview on machine learning tools applied to bladder MRI. Please, Giorgio, the podium is yours.
This guy has read the highest number of bladder MRI scans in the world, I think. I cannot count the number of MRI for bladder that we are asking on a weekly basis. So please, I'm sorry.
This is thanks to you and your team, of course. So thank you very much for giving me the opportunity and also being here, and thank you for the introduction. So I'm going to do a quick overview of machine learning tools. Sorry, I'm taking the time, otherwise I will go late. Okay. So this is pretty radiological stuff, so I will try to keep it as easy as interesting as possible for an audience that probably is not so familiar with it. So let's start from the beginning. Radiology is now based on a qualitative evaluation, qualitative interpretation of images made by clinicians or radiologists. But of course we have subjectivity, so we can interpret things in different ways so that we have inter-observer variability, and we depend on training and experience. I had the luck to work with them, so I've been exposed to a lot of bladder MRI in the neoadjuvant setting, but for other people it's completely different, so it's very difficult to interpret. So we have to think at medical images not only as a clinical information, but they're actually data. So they are mineable data that can be used to extract quantitative data and a lot of data. So we are turning images into big data. And if we talk about big data, of course we talk about AI, and also in terms of imaging, also about radiomics. So a little bit of definition. So when we talk about radiomics, it's the high throughput image analysis to extract quantitative features from images. like morphological features, that it's easy to understand, statistical features, so we have like histograms of pixel intensities within a lesion, for example, or textural, so not only the intensity or the overall intensity, but for example, the relative intensity of different pixels, so we have a real texture. And these are mainly missed by the human eye because we do a qualitative evaluation. And this is a quantitative evaluation that can be turned into imaging biomarkers. And when we talk about AI, it's a big term. It's an umbrella term that relates to any computer method that perform tasks that are normally require human intelligence. When we talk about AI in radiology, we should not expect like a super intelligence of something that sees something that cannot be seen. It's just an algorithm, okay? It's a software, it's an algorithm that in this specific setting is machine learning, deep learning, convolutional neural network. It's increasing level of complexity of the model, but basically they can learn. And how do they learn? We expose the algorithm to images with the right answer, and then they start realizing what is right, what is the right answer and what is the wrong answer. For example, we want them to detect bladder cancer. We show the algorithm 1,000 MRIs of bladder cancer, and eventually they will learn how to interpret what is bladder cancer and what is not. And at the end of the day, they are more efficient compared to the old type of algorithm, non-AI algorithm, in which we gave instruction and that's it. And the journey to develop an AI model, it's pretty long. I mean, we start from the AI champion, so people needing it. We are the people that might need the AI system. And of course, we need to identify a clinical question, a clinical problem that needs to be addressed. Then we start gathering data from different centers, and then we extract the data. We annotate the data so we can contour the lesion. We just can say the lesion is here. It depends also on the algorithm, because there are some algorithms that are so-called supervised, so they need us to tell them what is wrong, what is cancer, for example, and there are other algorithms that are non-supervised. We just show them the images and say there's a cancer somewhere, and they will learn eventually what is cancer, what is not. They are more robust, but they need a lot more data to be trained. And then there is the model testing and training, and this is very important because most of the papers you will read, you will see AI tools that perform really well. But you need to realize that one thing is training and testing, and one thing is validating. So training and testing is the first step. We show the algorithm images, as many images as we can, so that the algorithm will learn. And eventually it will arrive to a certain level of accuracy. Sometimes it's even 100%. It's not a good sign. Probably it's overfitting. But this is just training. It's like taking someone from the street, showing them images of 100 patients. If we show them, even if they are not doctors, if we show them 100 images for 100 times, eventually they will learn what is cancer or not. But if we show them another setting, another type of images, they will drop their performance. And the same is for AI. One thing is the model training and testing, and then we can fine-tuning. The other thing is validating. An AI model is good only if it's good in the validation setting, okay? And where are we now? So let's start from the beginning. What is the problem? Here, we are not talking about bladder MRI in general, but just a bladder MRI in the setting of the neoadjuvant setting, okay? So we have a renewed interest in imaging because you were talking about bladder sparing strategy and the fact that the most important thing is to have a reliable tool to non-invasively detect who is the complete responder, who can maintain their bladder, okay? And the conventional imaging, CT imaging, cystoscopy, and TURB have proven not to be so good at this. So MRI was explored, and Professor Necchi is a pioneer of this because already in 2019, at the Istituto Tumori, together with San Raffaele, they did this beautiful paper in which they showed that actually the best tool to determine who responded to neoadjuvant therapies is MR. And it's really, really, really good to determine if there is a residual muscle-invasive cancer. It's not perfect when it comes to residual small foci of tumors, because we have most of the times a lot of architectural distortion from TURBT, and so sometimes we are not able to say that a focal area of signal change is inflammation or is a residual tumor. So there is an area of improvement here, at least for the complete responders prediction. And also, it's very, at least now, we don't have a standardized way to evaluate these images. So if we do it in our center, we have seen a lot, we are pretty good, but it might not be true in other centers. So we also need a standardization and more reproducible interpretation. And this is an example of what we see normally. In the top row is treatment. We see that there is this area of thickening of the bladder wall because it's where the patient underwent the TURBT, and it's almost all inflammatory and fibrotic scare, but here you have this focal area of signal change that represent a residual tumor in the muscle-invasive tumor after TURB. The patient underwent neoadjuvant immunotherapy with pembrolizumab, and after the treatment, you see here, you still have the thickening related to the TURB, but within the wall, you can't see any lesion, and this was a complete responder. However, as I said, sometimes it might look like this, but have small foci of residual superficial tumor that we are not able to see. So there is some space of improvement. There have been already some studies investigating radiomics models in bladder MRI, but mostly to differentiate the grade, the muscular invasion, to characterize heterogeneity and other stuff. One was to predict actually the chemotherapy response, but as I said, none was validated. And in general terms, this is the big issue with radiomics. With radiomics, we build beautiful models that perform like crazy, but then if we apply them in another setting, they don't perform well at all. So we have a lot of literature on radiomics so far, but no radiomic model so far has been validated externally, is being used, okay? AI is a little bit better in this, and we have already some studies that investigated AI for bladder MR, but most of them are for segmentation, classification, so like the position of just the position of the tumor, this investigate the risk of survival, predict the muscle invasion, or it's denoising, it's to make the images look better, actually, okay? So again, none were externally validated. There are no in the neoadjuvant setting, and none are right now of clinical use. That's why we partnered with the Memorial Sloan Kettering in New York to investigate if we are able, with what we have, with the images we have, to develop an AI model that could help us identify who are the complete responders. And what we did so far is that, again, we partnered with Memorial Sloan Kettering with the team of Amita Dev and Professor Lawrence Schwartz. And basically, we provided the images and the annotation. So we had the images, we contoured the lesion where there was a lesion, and we sent them the data. And they actually analyzed the data and created the model. So the results I'm going to show to you is something that they did at the Memorial Sloan Kettering with us. this was the pure, initially we started with the pure 01 cohort, so it was 112 patients with a complete response rate of around 38%, and basically most of them had pure urothelial carcinoma. What we did again is that we provided the images, and then for each image we said, okay, there is a cancer here, so we contoured the cancer. And we did it on this is a multiparametric MRI of the bladder. We have multiple sequences that we can use, and mainly we use the T2 weighted, the DWI, so diffusion weighted, and DCE, so and dynamic contrast enhanced sequences. So we're segmenting and we annotated the lesion, and then they were the quantitative features were extracted in two ways. One was radiomics, so the radiomics features were extracted mainly from the T2 weighted images, and also we used a deep learning algorithm that automatically extracted the features. So this is another downside of AI. Sometimes they are non-explainable, they're like black boxes, so it's going to extract features that we don't know. But eventually it will extract the deep features, and also we created some quantitative data, for example, from the DWI and from the contrast enhanced sequences, and we developed algorithms from all of them and combining them all together to have a final AI model to train and test. And what we saw, to make a long story short, is that the first thing to notice is that, of course, as expected, we had the best results from post-neoadjuvant images. So we had some predictive ability also from pre-treatment scans, and also comparing the pre-treatment scans to the post-treatment scans, but the most informative were, of course, the post-treatment scans. And the radiomics model performed better, and it has 0.86 of AUC for complete response. And the deep learning model had 0.78. You might think that the deep learning model are worse than radiomics, but as I said, the more complex the model is, the more likely it is that it needs more images. And around 100 patients, it's not a lot for AI. For example, there are some commercial, there was an academic study for prostate for algorithm of AI for prostate MR interpretation, and they were trained with 10,000 scans, okay? Here we are talking about 100 scans. So probably we still have a lot of room for improvement in terms of number, even though it's difficult to have a patient. I mean, we scan how many patients do we have? 50 patients per year, around 50 patients per year. I mean, 50 patients, we do it in less than 1 week if we talk about prostate MR. So it's a different story, but we will get there. And of course, for downstaging, so essentially for detecting residual muscle invasive disease, the performance was even better, 0.92 of AUC and 0.84 for deep features. And these numbers compare pretty favorably with what we saw with humans. So this is a paper that we published last year, in which we saw that the AUC for any residual disease was 0.76 to 0.83 for complete response, and up to 0.97 for muscle invasive bladder cancer. So for a starting point, it's still a little bit inferior to humans, to us, but it's a very good starting point at least. So the main limitation of our studies so far is that the sample size is still small, and we are trying to increase the number of patients that have been trained and tested. There is no external validation. We are not talking today about a model that we can give anybody here to use on their MRI scanner. We are just in the infancy of this type of AI algorithm, and of course this was a supervised model, so it depended on how we segmented the lesion. So it might be dependent also on humans eventually, even if it's an AI algorithm. So to conclude, we now know that to date, MRI probably is the best tool to assess tumor response to neoadjuvant treatment, and probably in the future it will be paired with non-imaging studies, for example, circulating or urine DNA. Okay. But we have still a lot of room for improvement, and AI for sure will help us improving our performance and our reproducibility. But again, we are just at the beginning. We will need a lot more data, a lot more complex model, so large multi-center study with a lot of patients are needed before we could have a reliable AI algorithm. But at least this AI miracle, it's probably the first step that we see towards this goal. That will take a lot of work, many years, but eventually I hope we will get there very soon. So thank you very much.
Outstanding lecture. Outstanding lecture. So if there is any burning question, Maurizio, please. Very quick because we have to move forward.
First question is, how many cases you think are needed in order to classify a center, an expert center, with your technique?
Good question.
Like MRI for prostate cancer, for instance, 250, 300.
I mean, based on our experience, I think that if you want to start to do it, you should review at least 50 cases with histology. Okay. At least to start. If you want to be good, at least 100.
So I have had two burning questions. The first question is, what is the rate of virus 3 in your experience?
The rate of virus 3, it's not very high, but here it's completely different than Pirates 3.
I know.
We are talking about two different stories.
It's a gray...
Yeah, Pirates 3, it's like, I don't know if there is cancer or not. In theory, virus 3, it's different. It's something that you say, I don't know if it's muscle invasive or not, but in 40% of the cases, it's muscle invasive. But viruses were developed for the initial staging. So when you have the lesion, the problem here is that after TURB, you don't know if you have the lesion. So sometimes you are like in Pirates 3 situation. You see a lot of inflammation, but you don't know if there is also some cancer there. So we should completely rethink the way we interpret bladder MRI and tailor this to the setting. We have like 15% of virus 3 around.
Okay, so last question. No more RTUR?
No. I mean, as I showed you, I mean, for the neoadjuvant setting, I mean, it depends on what
your goal should be no more RTUR.
We don't have enough data.
Not yet.
Not yet. We should design study, but
Shilpa.
Yeah, thank you. This is great work, and Andrea, thanks to your vision that back 6 years ago you're already doing this. In the US, this is vastly underutilized modality. Like, we're not doing MRIs for bladder cancer. It's really hard to have, even for standard of care imaging, there's like not enough workforce, I would say, like we are lagging behind. So how do you see this becoming more applicable, not just in your institution, but
Shilpa,
there's a lot of effort.
I'm very happy to hear this. At least one thing is much harder in the United States than here. So I'm very happy. Please invest on MRI.
Yeah. Things are more difficult in the US for the imaging. Not for you as an oncologist, but for imaging, it's easier to be a radiologist in Europe. And this is a very good question. I think that we need two things. One is to produce data that say that this actually works. And then to really to standardize the way that we interpret it, because again, we now know how to interpret it, but we should communicate this to the bigger audience. And then the third thing that is the most important one is up to you, is to define the necessity of doing this. I mean, if you clearly find a suitable spot for MRI to be performed, for example, in the neoadjuvant setting, and you as an oncologist and urologist say, we should do MRI here, that is when people start doing actually. Before that, we are only few centers for research, because we do it mainly on research as well, will do it.
What about the reproducibility of the readings? Because here only you are reading these, or you have a team dedicated to this, but you know, I can foresee that the challenges of a different radiologist reading and...
Yeah, I mean, this is another good observation. I mean, we have a pretty good reproducibility, but again, we are working together, we do things in the same way, so it's easier to have a good... We don't have a data to say what is the real agreement in different centers. That's why we need to update the VIRAT's recommendation and tailor this for the post-TURBT setting. Because I can tell you it's not that difficult. It looks difficult if you don't know how to do it, but eventually when you know how to do it, it's not that difficult.
Giorgio, we usually are the first to criticize our own work, to be skeptical of our own, the work that we generate, as it should be. So my question to you is that if you look at the Sunrise 4 biomarker data that provided the evidence that 80% of the patients who had the complete TURBT baseline judged by the local investigator had the UTDNA positive test. So 80% of the complete TURBT had resulted in having a UTDNA positive test. Based on this level of sensitivity of the test, do you think that we actually need any kind of imaging? Provided that we have to exclude extravesical disease and so, but provided that we have excluded extravesical disease, do you think that we need something more as compared to biomarker only?
Yeah, I mean, I think so, because first of all, when you have positive urinary biomarker, you can know if it's just a small foci of tumor or if it's a huge muscle invasive tumor. So the morphological aspect, it's very important to you, and also to guide the TURBT. We're starting to see a lot of cases in which with cystoscopy, they didn't even see the lesion because the lesion was completely within the bladder wall. So I think that, in my opinion, the best performer will be the combination of the two, so that with the urinary biomarker we will reduce the false negative of MR. But at least we have seen in many other settings, and probably we should investigate this as well, the visibility at MR at imaging is a powerful biomarker that can stratify patients. If you use our urinary, probably you're a little bit too sensitive.
Last question, Marco.
Just to continue the discussion about this topic, because we discussed with Giorgio many times about this. That's also sometimes when you do the RT-RBT after neoadjuvant, it's very important to be guided by the MRI, because you know exactly if there is a suspicious area, then you are not able to see that in the cystoscopy or during the TURBT. And also, so maybe biomarker, of course, had something else, but also since TURBT is still needed, it is also very important to have someone like Giorgio suggesting, okay, pay attention in that specific area, and maybe it's not visible during the cystoscopy or during the TURBT.
Thank you. So I think that we have to move to the final. Thank you, Giorgio. To the final presentation for this morning. Antonio, it's your time. Are you ready? Yeah. Please set your tie. Okay. So Antonio will provide you with an overview of the ongoing partnership with Trinetics and jump into the real-world data, real-world evidence, look at big data, analyzing big data from real-world clinical practice. So what is going on, Antonio, please?
And so, good morning, everyone. I'm glad to be here. And in this section, I will focus on real-world treatment and the real-world data and the importance of real-world data in genitourinary cancers and our ongoing partnership with a real-world platform which is called Trinetics. So this is our agenda. We will start by answering questions such as while real-world evidence is important in oncology and in genitourinary cancer, then we will go to the collaboration with this platform and our work with the platform, and then we will go to the conclusion. So we know that randomized controlled clinical trials provides the highest level of evidence for treatment, but we know also that clinical trials are different from real life. This because they often exclude elderly or frail patients, patients with comorbidities, but also rare histologies, and in most of cases, non-standard dosing or sequencing are not considered. And so real-world evidence is important because it complements randomized clinical trials, because it describes effectiveness and treatment patterns in unselected everyday clinical practice. And in this way, with the real-world evidence, we have insights into treatment sequencing and outcomes beyond clinical trials, safety and tolerability in different populations, but also adherence and healthcare research utilization. And so we can compare clinical practice with evidence-based standards. This is a table in which there is a comparison between randomized clinical trial data and the real-world data. And we can see that they differ for purpose, efficacy versus effectiveness, focus, investigator-centric versus patient-centric, and patients included versus non-included as per strict criteria. And so in the last few years, we saw important changes in the therapeutic landscape of genitourinary tumors. In particular, we have new treatments, new immunotherapies, antibody-drug conjugates for urothelial carcinoma, targeted therapies. We have multiple treatment options in the same setting, but limited head-to-head comparisons. And we have more patients eligible for systemic treatments. For example, patients with renal cell carcinoma who can undergo to an adjuvant immunotherapy. All these advances are outstanding, but raise questions that randomized clinical trials cannot always answer. For example, which IO-TKI combo show best outcomes in renal cell carcinoma? Or which RP is more effective or safer in prostate cancer? If immunotherapy re-challenge is effective and safe in patients with genitourinary tumors? And finally, if young patients with a genitourinary tumor have a different cancer from older patients. And real-world evidence could help answer these questions. But when we use traditional multi-center research, we have to face some challenges. One of the most important problems is related to complex logistics, because it is complex to manage multiple sites, to obtain ethical approvals, etc. We have problems related to high costs and slow timelines. Recruitment often takes a long time. We have reduced the population diversity and problems related to data fragmentation. Finally, we have regulatory and legal barriers which limit a lot data sharing. And finally, we have problems, challenges related to complex data interpretation. In fact, in most of cases, we need for statistical expertise and advanced softwares to perform our analysis. And so these barriers make large-scale real-world evidence challenging, and in the same time highlight the value of federated privacy-compliant platforms. This because these platforms are characterized by specific and important key strengths. First of all, centralized infrastructure, which solves the problems related to complex logistics. We have a continuous data capture with this platform, and in this way we can reduce the slow timelines. We can address the reduced population diversity with broad data networks. Integrated pipelines eliminates data fragmentation, and in general, integrated tools reduce complex data interpretation. And in San Raffaele Hospital, we have a collaboration with a real-world platform, Trinetics, which is a real-world platform which supports clinical and translational research. With the Trinetics, we have the possibility to access to data from more than 300 million of patients worldwide. More than 200 healthcare institutions are involved in the platform. And the platform collects and harmonizes real-world clinical data, and in this way it ensures consistency and interoperability. In the platform we have a query builder in which we can select the cohort that we want to study, and then we have another section in which we can conduct retrospective studies, and so we can analyze outcomes and treatment patterns, etc. And now an update on the work that we conducted over the past year with the platform. And the story started at ASCO GU 2024 when Brigida presented a work on outcomes of immune checkpoint inhibitor rechallenge in advanced urothelial carcinoma. We know the importance of immunotherapy in urothelial carcinoma, but we don't have a lot of data about immunotherapy rechallenge. And for this reason, we selected a cohort of 292 patients who received at least 2 immunotherapies. And after a median follow-up of 21.7 months, we found that median OS for immunotherapy rechallenge was 20.5 months, and the median progression-free survival was 10.3 months. We found that previous use of an immunotherapy in a non-metastatic setting was associated with a longer median overall survival than both lines given in the same setting. We found also that among patients who received a previous immunotherapy in a metastatic setting, a cutoff of 12 months for immunotherapy rechallenge was associated with a longer overall survival. And finally, the longest duration of rechallenge treatment was achieved when an anti-PD-1 was given after an anti-PD-L1. The study was published 3 days ago at ESMO Open. Starting from these interesting results, we performed a similar study in renal cell carcinoma. Here we have some data about immunotherapy rechallenge in clear cell carcinoma, but in this case we focused our attention on the time of immunotherapy rechallenge. We selected a cohort of 288 patients who received at least 2 immunotherapies, and we found that after a median follow-up of 19.3 months, median overall survival was 33.2 months, and median PFS was 8.54 months. patients who received the second immunotherapy after at least 6 months from the previous one had a better overall survival and progression-free survival. And the propensity score matching confirmed the OS benefit, that the OS benefit was independent of covariates. And finally, going to the prostate cancer, at ESMO 2025, we presented another study on metastatic castration-resistant prostate cancer. We compared the patients who received the RP-based triple and double therapy. No difference for overall survival in the overall populations between the two strategies were seen, but multivariate Cox regression analysis showed that in synchronous patients, darolutamide was associated with a better overall survival. And visceral metastases were associated with a worse overall survival, while in metachronous patients, darolutamide again was associated with a better overall survival, and visceral metastases and docetaxel were associated with a worse overall survival. And finally, after propensity score matching, we found that triplets performed better than doublets in synchronous patients, while on the contrary, doublets performed better than triplets in metachronous one. We have several ongoing projects with the platform. The first is in collaboration with the Global Society of Rare Genitourinary Tumors, in which we are evaluating the impact of age on outcomes in metastatic non-clear cell renal cell carcinoma. In another work, we are evaluating the real-world survival improvements in metastatic urothelial carcinoma, focusing our attention on 3 key therapeutic eras: chemotherapy era, immunotherapy era, and ADC1. And finally, in another work, Valentina is evaluating the sequencing of erdafitinib and erfortumab in metastatic urothelial carcinoma. Although these impressive results, in my opinion, traditional retrospective research is not dead. This because traditional retrospective research is characterized by key strengths that are very important when we perform a real-world study. For example, the possibility to access to full clinical charts, pathology reports, imaging, and molecular data, a clinical validation of the data, a contextual interpretation because local investigators understand the treatment pathways, diagnostic practices, etc., and the inclusion of non-structured data, for example, narrative notes, histology details, biomarkers, etc. And so, in my opinion, traditional retrospective research and large federated platforms can play a complementary role. The first, providing the depth and contextual understanding. The second, offering breadth and scalability. And so, in conclusion, real-world evidence bridges the gap between controlled clinical trials and everyday oncology practice. Federated platforms accelerate research and hypothesis generation, but in the same time, traditional retrospective studies provide contextual understanding of the data. And together, these complementary approaches strengthen the credibility, extensibility, and the clinical relevance of real-world oncology research. And thank you for your attention.
Thank you, Antonio.
You are perfectly on time. If there is, Ashish, please, any question?
I just have one comment to make in addition to all the excellent points that you made. When you do real-world analyses or even retrospective data, one of the criticisms we hear from people is that it's a biased patient population. You cannot control for the clinician variables. I think that's a humbug criticism because in medicine, we actually want clinicians to use their judgment. We want it to be a little bit of the art of medicine, and we want to capture that inherent bias that goes on when we sit with a patient in front of us, and we can't have a tangible, measurable item that we look at, but we select patients, right? So I think that's another advantage of the kind of work that you're doing, so congratulations.
Yes, thank you.
Antonio, I'm particularly interested to the urothelial cancer data. Do you think that, based on your analysis, we can still consider 1 year as a cut point from end of prior immune therapy to disease progression and relapse as a way of selecting patients that are well suited or more suited to respond to re-challenge immune therapy?
Probably yes, but we need, in my opinion, prospective studies to affirm this hypothesis.
Well, but in real world, would you use for a patient,
yes,
for example, relapsing up 1 year or 14 months after adjuvant nivolumab, would you use again EV-pembro, for example, immune therapy?
Yes. In other tumor types, this time point is considered as a good time point to try again the immunotherapy. For example, there are some studies in melanoma in which immunotherapy re-challenge after a time point of 12 months is considered a good time point. But
and did you see the same? Did you see the same in your in the Trinetics for RCC?
A different time point for RCC.
Which time point?
We found 6 months.
So shorter.
Shorter, strange, but it was shorter.
Giuseppe.
Compliments, Antonio, very clear presentation, and congratulations for the idea to develop this model of good cooperation in an international platform. My question is about quality of life. Normally excluded from randomized clinical trial, do you consider we may try to collect more data about the quality of life in this type of project? And the second point is about prospective also data or only retrospective data you will collect in this type of platform? Thank you.
Thank you. I will start with the second question, only retrospective data. So we don't have the possibility to analyze prospective data. For the first question, in my opinion, quality of life is very important, but in the platform we don't have the possibility to deeply study the quality of life of patients. And also for this reason, in my opinion, traditional retrospective research, when we focus our attention on these topics, is important.
Antonio, I think congratulations, and I think, you know, many of us who focus in the rare disease space think this is a very tactical but a very thoughtful way of doing this. To the point Ashish brought, good quality retrospective data for many rare cancers is the ultimately only way we're going to really understand the disease and do the studies and not wait 10 or 15 years for these trials to sort of not happen. So I think it probably provides a stepping stone to identifying thoughtful clinical questions to drive prospective tactical studies. So as you are doing studies in non-clear, for example, in young patients, you may identify some very unique, specific characterization that could be sort of explored in a very thoughtful but smaller pilot-type prospective studies.
Okay.
Can I ask a question? This was really amazing work, and congratulations to you and Dr. Necki for his mentorship. I was intrigued by the data in the kidney cancer. You showed that re-challenge with immunotherapy improved survival, but we have seen 2 prospective phase 3 trials, one led by actually Dr. Pal here, CONTACT-02 and KINEVO-2, which has swayed us away from re-challenging immunotherapy in kidney cancer. So I would love to hear, like, when we have prospective trial evidence and such robust retrospective data, like, how do we make decisions in clinic?
Yes, in my opinion, the time of immunotherapy re-challenge could be an important topic, an important topic in the prospective studies, in the two prospective studies. The investigators didn't focus the attention on the time of each re-challenge, of immunotherapy re-challenge. And we don't have any studies with, on these prospective studies, any analysis focused on the time of immunotherapy re-challenge. So it could be interesting to see if in these prospective studies the time matters like in our retrospective research.
And just
Yeah, Antonio,
just one short interruption, my friend. Just on that important topic, congratulations, Antonio. There are two relevant data points coming up. One is a retrospective, actually, it's a survey across oncologists in the US. It's a paper in under review, and we ask oncologists, what's your kind of arbitrary timeline of challenging patients with metastatic urothelial carcinoma after prior checkpoint inhibitors receipt? And the answers were all over the place. Just commenting on how important to look at that, in a real-world manner. And to Silpa's question, we just launched an important phase 3 trial in the US. The first trial asking the challenge question. It's actually, Andrea and me have both worked on that, SACI plus Pembro combination, building on the neoadjuvant trial and our metastatic trial, SACI plus Pembro versus platinum chemo or taxane chemo in patients who had progression or prior immunotherapy. It's EcoCacrin 8231. We just launched it 2 weeks ago. Hopefully we can get some answers there. Sorry, Neeraj, to interrupt you.
Neeraj, and we'll close.
Yeah, so love the talk, by the way. This is fantastic. Kudos to you guys and Andrea's mentorship here. Any plan to get into the genomic aspect of real-world data? Because as Jeff mentioned, that will bring in ultimate strength to these analyses.
This is a good question. We tried to perform analysis focusing on the genomic alterations, but here there is a problem, the granularity of data. In most of cases, we don't have this data. There are some patients in which genomic alterations are recorded, but more or less are 10%, so the numbers decrease a lot. And so we can't, in my opinion, perform this analysis for most of our patients. It could be possible to perform this analysis, in my opinion, when we consider very common tumors, urothelial carcinoma, renal cell carcinoma, but when we focus our attention on rare genitourinary tumors, for example, in the analysis of rare non-clear cell renal cell carcinoma, we didn't have a lot of information about this topic.
We have Francesca, the guru of trinetics down there, so it's a clear suggestion, how to improve the database, exactly, so the genomic part is very, very important. So, it's time for lunch. So, ladies out there will provide you stewardship and guide you to the lunch restaurant, the new cafe bar, so you will enjoy it, I'm sure. So let's meet out there and go back, let's say, with 10 minutes delay, no more, 2:40 here for the next session. Enjoy the lunch.
But I've been living great.
of a feather, different kind. We were laughing through the pain, you were never once so bad. Cut the cord that kept us connected, blacking out the mirror where your light once reflected. All of the love from up above, we used to feel like a glove. I still think about the you that only exists in my brain. Nothing ever stays the same, guess it's just a shame. There's no one to blame. Together in our prime, we were birds of a feather, different kind. We were laughing through the pain, we were never once so bad. Cut the cord that kept us connected, blacking out the mirror where your light once reflected. All of the love from up above, we used to feel like a glove. I still think about the you that only exists in my brain. Nothing ever stays the same, guess it's just a shame. There's no one to blame.
chance to catch you. I'm a little bit obsessed. Burn cigarette, babe, with your fingertips. Kiss me like last time and my candy lips. you want. Don't give it up. Tell me what you want. Don't give it up. Tell me what you want. Don't give it up. Tell me what you want. Don't give it up.
different kind. We were laughing through the pain. You were never once so bad. Cut the cord that kept us connected, blacking out the mirror where your light once reflected. All of the love from up above, we used to feel like a glove. I still think about the you that only exists in my brain. Nothing ever stays the same. Guess it's just a shame with no one to together in our prime. We were birds of a feather, different kind. We were laughing through the pain. We were never once so bad. Cut the cord that kept us connected, blacking out the mirror where your light once reflected. All of the love from up above, we used to feel like a glove. I still think about the you that only exists in my brain. Nothing ever stays the same. Guess it's just a shame with no one to
just to impress you. I have no second chance to catch you. I'm a little bit obsessed. Burn cigarette, babe, with your fingertips. Kiss me like last time and my candy lips. you want. Don't give it up. Tell me what you want. Don't give it up. Tell me what you want. Don't give it up. Tell me what you want. Don't give it up.
So welcome to the second part of our GU retreat. I hope you have enjoyed the lunch. And now we will start with fresh updates of ongoing studies from abroad. Please, Chiara.
Good afternoon. Maybe I can turn on. Good afternoon. We're going to start from Italy. So with the updates from the Mituro group, I'm very happy to introduce Dr. Giuseppe Procopio from Istituto Nazionale Tumori here in Milan. Please.
Thank you very much, Chiara, and thank you very much to Andrea and the organizers for giving me the possibility also this year to talk about the Mituro, about the activity of Mituro in terms of research program in genitourinary disease. Okay, so here are my disclosures. I'm sorry, I don't know what. I don't know. What up? Quello di destra. Ok. Ok, thank you. So, Mituro is a network, is a neurological oncology network that would to try to answer at two major questions. First one is about the real world data. We will try to collect clinical data in a real world heterogeneous study population. So we'll try to provide more information in patients normally excluded from a randomized phase 3 trial. In the same time, Mituro would also to try to understand if we may consider the opportunity to make possible to access for orphan and rare disease to new drugs, new agents, and so to improve the management of this type of patient. So heterogeneous real-world study population and orphan and rare disease. In the Mituro team, we have a medical oncologist, urologist, radiotherapist, and all physicians normally involved in the management of a patient with advanced genitourinary tumors. Also, an international networking is ongoing to make possible a good cooperation in different areas of research. Mituro was founded in 2017, and in these last 10 years, now I am the president of this research group, involving more than 100 sites, Italian sites, and overall more than 460 medical oncologists are part of this team. So we have a very important number of members in the Italian country. We have an important upward trend in these last years, supporting the good work, the good activity of this research team. Why to improve research? We know well that if we want to raise the bar of the outcome of our patient, we have to perform clinical trial. We may make possible to offer good therapeutic option of our patient if we will be able to design a nice clinical trial from the patient perspective. What is the general situation in Italy? Medical oncologists cover around 40% of all research, no-profit, academic trial. Unfortunately, in the last year, we have a dramatic reduction of no-profit academic research program. Now are less than 20%. So the majority of the clinical trial remains company-oriented trial. Less than 20% of our research program are academic, no profit. And this situation depends on several factors, including the time of the authorization, the limited resource, of course. But we have to try to overcome these issues if we want to make possible to access early to new agents, and we would make possible new therapeutic option for our patient with genitourinary disease. The main focus of Mituro are, of course, the three areas of pathology, the most important, renal, urothelial, and prostate, but also rare genitourinary disease, including non-clear cells, but not only. About the methodology, we want to put the attention to prospective frontline clinical trial, specific need, of course, personalized approach, and also combo for orphan disease, combo or monotherapy. This is the general planning of the activity undertaken by Mituro in these last 10 years. In the past, renal cell carcinoma was the most relevant area of research with prospective and retrospective series. Now we have a more balanced activity involving also prostate and also urothelial carcinoma. And in this slide, I've summarized some of the most relevant clinical trials ongoing, recruiting now in this specific setting. The majority are prospective frontline trial. This is an example of a good cooperation, assessing cabozantinib in collecting renal cell carcinoma, and validated this option, cabozantinib in collecting that as a therapeutic option in advanced disease. And the next step was the evidence of the expression of Nectin-4, 30–40% of the cases. This type of expression in advanced collecting duct disease. And according to this, we have planned the next step, the next clinical trial, recruiting now pembrolizumab plus enfortumab in this rare disease. And this study will try to offer a new therapeutic option for patients with an orphan disease. And in the same time, this trial will try to answer an additional question. May we use enfortumab in an intermittent way to reduce cost, to reduce toxicity for the patient? And so we plan an intermittent use of enfortumab to try to obtain a better personalization of the therapy in the management of the patient. Mituro 31 is another example of a good cooperation. It's a frontline trial undertaken in renal cell carcinoma using machine learning to try to look inside at the radiomic and the transcriptomic, and the data are unpublished yet, will be presented early. 2 radiomic signatures were identified, potentially have expression and associated with response and promising as early biomarkers of response. Frontline renal cell carcinoma, 100 patients enrolled in 1 year in 80 Italian sites. Approach trial is another example of an integration between the different physicians. The question is, may we consider cytoreductive prostatectomy in locally advanced or low-volume metastatic prostate cancer? In this trial, we will try to answer if a perioperative therapy may permit a better outcome. So 6 months of medical therapy, cytoreductive prostatectomy or radiotherapy, and then continue medical treatment. The goal will be to demonstrate a better radiographic progression-free survival over single pharmacological therapy. Also for this trial, the network is very, very active. More than 240 patients enrolled in this country, and we will try to answer at the question in the next years. And the CARE1 is another example of international cooperation. This is a clinical trial planned by Getug, led by Laurence Olbiges. It's a clinical trial that would to understand if PDL1 could be a predictive biomarker of response in advanced renal cell carcinoma. Now the results are disappointing, but in this study, the question is, PDL1 could be a driver of choice? Is a certification factor in this clinical trial. The goal is different. In patient PDL1 positive, the goal is to demonstrate the superiority of a double IO over IO plus TKI. While in patient with PDL1 negative, then the point is different. We have two co-primary endpoints, radiographic progression-free survival and overall survival, and the superiority in favor of IO plus TKI over IO-IO. The accrual is ongoing in several countries, and of course, we are waiting for this type of question that will try to understand in a real-world population, because in the CARE1 trial, we have an heterogeneous study population, similar to the patient of the clinical practice. And this is an important additional meaning in this setting. And the Saturno trial is a prospective registry that would to collect data. Would collect data in more than 1,000 of patients with advanced urothelial carcinoma. It are unselected patients, of course. And this study would permit to add information in the management of a patient, of course, but also about the treatment exposures, about the duration of response, a population completely different of patients normally enrolled in randomized phase 3 trial. So, and this is another information. And how to overcome the issues of the activation of the startup process, the authorization. FICOG is the Federation of Medical Oncologists in Italy that will cover all research group, all group having activity in the context of medical oncologists, not only genitourinary disease. And in the FICOG we have 18 group of research, and FICOG will try to reduce the time of the startup, to reduce the cost of the management, to make possible to each site to perform a good research with quality. These are the group, as you will know, Italian sarcoma group, gynecological, all type of disease, gastrointestinal, and also genitourinary tumors. And this is the team for the next 2 years of the Federation of Medical Oncologists unit. So, my last slide is about the need of a good cooperation. In my opinion, we have to work together. Only in this way we may try to overcome the difficulties, the problem, the issue, and we may try to answer better to our patient. We have to reduce the mortality due to cancer, and I think a good cooperation from scientists and physicians may permit a better result. That is the last crucial goal of all our activities. And thank you very much.
Thank you, Professor Procopio. It was amazing to see how many projects the Nituro is conducting in Italy. Also with all the limitation of our countries, it's something incredible.
Thank you, Van.
Okay, the next speaker is Sarmad Sadeghi from University of Southern California in Los Angeles. Thank you to join us. We want to hear from you the updates from the SWOG and the SUCOL.
Thank you very much for the kind introduction. Thank you, Professor Necchi, for having me here. And the organizers, this is my second time, and it's a great pleasure to be here. So, let's see if I can move the slides. Which one?
Should be this one.
All right. Thank you. My disclosures. Disappeared. Okay. I'm not counting this as my time. Sure. So, let's see. Okay, so let's go one slide back. I'm going to give you an overview of currently active and accruing clinical trials at SWOG. This is just limited to the GU group. So we have 3 open studies for prostate cancer. The first one is SWOG 2312. This is for patients with aggressive metastatic castration-resistant disease. It is defined based on the presence of those alterations by IHC, and this is a test that will be performed at MD Anderson. It is led by Paul Korn, and co-PIs, Anna Aparicio and David Vanderweel, are leading this trial. The goal is to randomize 528 patients. And the study is going to compare cabazitaxel for up to 10 cycles versus adding carboplatin to this regimen to see if we can improve the outcomes. This study is open. It opened September of last year, and as of now has accrued 7%. So for a trial that's been open about 1 year, this is doing really well. The next study is SWOG 2210. This is a phase 2 study using carboplatin in neoadjuvant setting for BRCA1/2 mutated prostate cancer patients. So this, the idea here is that patients with high-risk tumors who also happen to have BRCA1 and BRCA2 mutations, as long as they don't have metastatic disease, they will be treated with 3 to 4 cycles of carboplatin, AUC of 5, to see if we can put the tumor in remission. The primary endpoint is pathologic CR. This is a Simon 2-stage design, and in the first stage, 20 patients will be accrued, and as long as we have 1 or more pathologic CRs, we proceed to stage 2, and if after 40 patients, if we have 5 or more pathologic CRs, this will be a positive study. It opened in 23, and it's 11% accrued. It's led by Heather Chang, and Dan Lin, Evan Yu, and Tanya Dorf are co-PIs for this study. Next study is Brian Chapin's study, SWOG 1802. This is a phase 3 trial for metastatic prostate cancer. This is for castration-sensitive patients, and the idea here is to see if offering definitive treatment on top of the standard of care for metastatic prostate cancer is going to improve the outcome. So this is a randomized study. It's got a large sample size of 1,273 patients. The interesting thing for this study is that the definitive treatment could be either radiation therapy or radical prostatectomies. There are other similar studies that are doing one or the other, but here both options are available. It opened in 2018. It's 76% accrued. Now I'll go over a couple of studies in kidney cancer. The first one is SWOG 2200 or PAPMET-2. This is a sequel to Monty's PAPMET trial, and this one is led by Benjamin Mohan and, of course, Monty Powell. They are co-leading this study. This is for metastatic papillary renal cell carcinoma that are previously treated, but no more than 1 line of prior systemic therapy. No PD-1, PD-L1 exposure within the past 6 months, and no cabozantinib exposure. The primary endpoint is PFS. The goal is to randomize 200 patients. Control arm is cabozantinib, and the research question is whether adding atezolizumab to cabozantinib improves the outcomes. This one opened in 2022, 17% accrued. And the next study is SWOG 1931. It's also called PROBE study. And it's a phase 3 trial. The idea here is to see if cytoreductive nephrectomy has a role in the age of immunotherapy combinations. So for this trial, patients can be treated with 3 months of standard immunotherapy combinations, and at the 3-month mark, if there is no progressive disease, these are patients who can proceed to randomization, and randomization is going to be cytoreductive nephrectomy and continuation of systemic therapy, or just systemic therapy. This is led by Olka Vashampayan and Hyun Kim, and it opened in 2020. It's 42% accrued. Now, a couple of trials in urothelial carcinoma space. The first one is the newest addition to SWOG portfolio. It just opened in September of this year. SWOG 2427, also known as BRIGHT. This is a phase 2 single-arm study, and it offers radiation therapy in combination with pembrolizumab that continues for 1 year. The ideal candidate for this trial is a patient who has completed neoadjuvant treatment. This could be the standard of care in anticipation of these regimens being replaced by EV-Pembro. We just left it at standard of care. And when the neoadjuvant treatment is complete, if an imaging and TURBT, the patient does not have any evidence of muscle invasive disease, then this is a patient that can be offered participation in the study and proceed with registration and enrollment. Radiation therapy will be given as shown on the slide, and we will proceed to follow up and assess the endpoints of the study. This is led by Leslie Ballas and has a very strong investigator team. As you can see, Sia Danishmand, Abhishek Tripathi, Dan Hamstra, and James Yu are leading this study. We just opened this study. We haven't had our first accrual. As you can imagine, 3 months of neoadjuvant treatment, even if we had one patient the day we opened it, we still have to December to complete that treatment. Next study is my study of gemcitabine eribulin. This is a phase 3 clinical trial of gemcitabine eribulin regimen in comparison to the standard of care for metastatic urothelial carcinoma that has been treated with EV and also immunotherapy. It doesn't matter how many lines of treatment and what sequence of treatment. As long as patients have been treated by enfortumab vedotin and immunotherapy, they would be eligible to participate. I am lucky to have Dr. Lara as my co-PI, and our study champions and ECOG and Alliance are Jason Brown and Stephanie Berg. So this trial opened in 21. We are 64% accrued, and recently the accrual has picked up, so we are very happy about that. For those of you from the US, please consider this option for your patients. It's a very good option. Now, for the next few minutes, I'm going to briefly talk about our research at USC, and of course we have collaborators. This is just bigger than USC, but the first item that I want to share with you is that We're focusing on immunotherapy resistance and what happens in that process. And we have focused on Ephrin-B2. Ephrin-B2 is part of the Ephrin-F family of receptors and ligands, and it's a bidirectional signaling, and it's part of the angiogenesis during embryonic period. Knockout of these molecules is fatal to the embryo. The capillaries don't form, and the expression of these molecules just goes away. So the normal tissue in adults, they don't express it. But we found that in tumor tissue, in urothelial cancer, you can look for Ephrin-B2 by IHC or in situ hybridization. As you can see, the tumor is stained very nicely. The normal tissue doesn't have any staining. So this has the makings of a really nice therapeutic target. We also know from TCGA analyses that are published that both of these, expression of Ephrin-B2 and FB4, they are negative prognostic markers predicting for short survival. So we did a clinical trial, a single arm. We combined an inhibitor, a dummy FB4 soluble molecule, and combined it with pembrolizumab. We treated 70 previously treated urothelial carcinoma patients, and the results were very interesting. We found that among all 70 patients, the response rate was 37% higher than expected. For pembro monotherapy, expectation is about 20%. And then we looked at the subgroup that expressed higher levels of Ephrin-B2 as defined by membranous signal and 2+ or 3+. So we had 46 of these patients. That's about 60% of the patient population. In that group, response rate was 52%. And we had 20% complete response. So this was very impressive. It seemed like we have turned a negative prognostic marker into a positive predictive marker for response. So we published our results in JCO and looked at this target in other cancers, including prostate cancer, kidney cancer, and head and neck cancers, and they all have higher expressions of this, and at least for head and neck cancer, we have clinical data that this is a reasonable therapeutic target. Then the next question is, what happens in monotherapy if patients are getting PD-L1 targeted therapy? Do we see the same negative prognostic effect that we have from TCGA data, which was analyzed at the time of chemotherapy alone? So we partnered with Dana-Farber, UC Irvine, and the University of Colorado. We put together over 150 patients that we could collect tissue for, and we had all of these tissues stained for Ephrin-B2. So this table summarizes our finding. If we look at the objective response among all of these 159 patients, the response rate is 20%, exactly as expected for immunotherapy monotherapy. But if you look at those that had higher levels of Ephrin-B2 expression, then the response rate is 12%, and 60% of patients fall in that category. So this effect is not just for objective response. We see it in overall survival. Those that don't express Ephrin-B2 or have low levels of expression, survival at median is 20.6 months. High expressors, 13.5 months. And these results are statistically significant. We have seen this slide. This is EV Pembro, very impressive data. EV by itself has changed the landscape of urothelial carcinoma significantly, and it's even made bigger changes in combination with pembrolizumab. At median, survival is 31.5 months versus 16.1. for the chemotherapy arm results are statistically significant. But Nectin-4, as data is coming out, and we heard some of that data today, needs further investigation. And I have a couple of pieces of data here for you. This is on the left side, we have a slide from Jonathan Rosenberg and his group. This shows that over the course of disease from primary to metastatic disease, Nectin-4 in some patient goes up, in some patient goes down. On the balance, it may be going lower. And about 40% of patients don't have any expression of any detectable levels of Nectin-4, which begs the question, are these good candidates for enfortumab vedotin treatment? On the right side, we have a slide from Nicholas Klumper and Marcus Eckstein. They looked at Nectin-4 expression. They found that amplification is a part of the Nectin-4 expression. And it is very interesting that if there is amplification, virtually all of those patients were responders. So this was very interesting. They continued this analysis and had two presentations at ESMO this year, and showed that amplification actually correlates really well with higher membranous expression of Nectin-4. And then membranous expression of Nectin-4 correlates with response, and not just response with PFS and overall survival. This is a slide we have seen many times. This was presented at ESMO 2 years ago, I think. The point of this slide was that wherever we draw that line, Nectin high and low, the outcomes are the same. Everybody benefits from that. But this is what we tried to do using the series from Klumper and Eckstein. This is our reproduction of that same curve. As you can see, it's a little bit different. The frequency of expression is not as high, and the intensity of expression is also different. And the green bars are the responders, and they're more concentrated to the right side of the curve. If we draw that line at H-score of 100, we see a statistically significant difference in terms of objective response. We also combined this with expression of FRNB2, and we found that Nectin-4 high and FRNB2 low had the highest response rate of 62%. But if this was reversed, Nectin-4 low and FRNB2 high, then the response rate was 20%, which was much lower than expected. So I leave you with this. This is the newest thing that we saw at ESMO this year, HER2-directed antibody-drug conjugate combination with immunotherapy. And the results are reminiscent of what we saw with EV-Pembro. Only this time it is in biomarker-selected patient population. So it underlines for us that it is very important that we continue to look at the expression of these biomarkers in the context of treatments in clinic for our patients. And with that, I'm going to stop. Thank you.
Thank you very much for your presentation. There were so interesting study designs, really clinically meaningful. And now I'm happy to introduce Professor Ashir Kamat from MD Anderson. He will present us the work of the International Bladder Cancer Group.
Thank you, Chiara. And it's always a pleasure to talk to this group and update you as to what's been going on with the International Bladder Cancer Group. Many of you know a lot of what I'm going to show. Some of you are actually involved in it, so I'm happy to take you through it. The mission of the International Bladder Cancer Group, just to put it out there, is actually twofold. Number one, it's to take existing data and leverage it for the benefit of patients on a global basis. And then, of course, to create educational tools that we can then help disseminate in different parts of the world. So it's not just specific to North America or other regions, it's truly something global, and I'll give you some examples. This is the original member, Maurizio Brasi, sitting right there, was part of the original, what do you call it, mafia? Yeah. And of course, over the years, we've now grown. This is an AI-generated picture. If you're a member, you should be able to see your picture in there in 6 seconds. So I'll leave it up for 6 seconds. Yep, I say Brigitta's finding herself. If you don't find yourself in 6 seconds, you need to make an appointment with your ophthalmologist, Petros. Okay? Good one here. Okay, 6 seconds are up. You see yourself? Great. And our members truly come from all over the world, right? Because like I said, it is a global organization. We want people from everywhere so we can actually have work that we do applicable globally. These are our new members. Some of you, again, are right here in the audience. These are new members that we added this year. And every year, anyone who wants to apply. You have to have a sponsor from within the membership. And then, of course, the board will vote on it. And it's unusual, very unusual for someone not to be accepted, but we have had to turn certain people down. This is the original IBCG board. We have expanded it this year. I think you recognize somebody over there in the bottom right-hand corner, Andrea. So welcome to the board. It's always a pleasure to have you be part of the team. And the editorial board has changed as well. Dr. Grievous said that he is too busy to help the IBCG with the editorial board because of something private that got announced last night at dinner, I think. But anyway, so we'll miss you, Petros, but this is the editorial board for the newsletter that we put out. We have a health services research arm. Sharuk Shariat's been an integral member of that. It's also led by Seema Porton and Stephen Williams, and this is where we do real-world data, international sort of registry, and I'll give you an example of one of those as well. We have an integral partnership with the Global Society led by Phil and Andrea. Again, this is an ongoing interaction between friends, organizations to amplify each other's work. Some of you asked me in the dinner last night and even today, why do I do so much stuff with Euro Today? Why do we have a partnership with Euro Today? The answer is very simple. Many years ago, I was doing some stuff at Euro Today, and during COVID, I was a little bit bored, decided to do some online videos and interviews, and turns out that in many parts of the world, people don't have access to journals, they can't access articles, they can't afford to come to meetings. So it's almost like a labor of love. We interview experts like you, put it on Euro Today, and then people across the globe can see what's going on, they can see what's happening at conferences, they can hear from the experts what your viewpoint on the latest publication is. We have forums at the AUA. Many of you have been part of this, of course. And then, of course, our publications. So we have a track record of publications. We have meetings, and the meetings are working meetings. So we don't meet unless we're going to publish, right? So this is an example of many of our publications that have made it into guidelines at the AUA, EAU, referenced by the FDA, of course. And over the years, you can see just a snapshot of consistent publications. The last collaborative effort that we did with SITC before the SIG guidelines dissolved, as many of you know, I used to head SITC's SIG committee, but unfortunately because of funding issues that dissolved just this last year, but this was something we did with them. We do work with governments across the globe. We worked with the Chilean government in 2023 to help them with their bladder cancer guidelines. And that was actually the first year that we had an international retreat in Houston. We used to have small meetings with selected groups, but the first large group retreat was in 2023, held in Houston, and the publication for that you can see down there. We've done work in Morocco with our good friend Karima that heads the oncology section in Morocco. We've done work in India, launched the Global Registry Project, which is a global registry looking at patients treated with non-muscle invasive bladder cancer with any therapy to track them across the globe. Of course, we had the 2024 retreat that had a sister project that we did at this meeting. And I have to say, that was the quickest publication from a meeting to a publication. Andrea, you led that effort. It was like 3 months, boom, boom, meeting, publication, JCO. It was really quick, and hats off to you. This year was busy for the IBCG. Of course, we had the retreat. We worked with the Mexican government to help them with their bladder cancer guidelines. That was just last month, putting together the 3 groups over there. We also launched a collaboration with the Japanese Society of Urologic Oncology. You can see Mikio, who is the president of that society. He had spent some time with me in Houston in my lab about 18 years ago, and now he's like leading the efforts in Japan. And of course, we're here now. And tomorrow we'll be having the joint session to now further refine the biomarkers at the San Raffaele retreat. One of the things that we're most proud of at the IBCG is our patient-centric care center, right? And this was launched last year. And as part of that, we've had multiple initiatives. One that we have a strong interest in, and Shilpa co-leads this at the think tank, the BCAM think tank in the US, is the young onset bladder cancer. And we had a consensus meeting at the think tank 2 years ago, borrowed from our colorectal colleagues, and actually formally defined young onset bladder cancer as 50 and above, because before that there was no agreement. People would consider 40 young, 60 young, 70 young, 65, it was all over the place. So that is one thing that we've done, and then we've got several ongoing studies for molecular analyses and of course, real world data there as well. Patient-centered care is, really the core of what we all do here in the room. It's an effort that I'm very interested in and passionate about. It is really treating not just the patient, but the family, the cancer based on the patient's values, preferences, and expressed needs. And as part of that, one of the things that we've done across, and this was 45 countries, close to 1,500 participants, is the World Bladder Cancer Patient Coalition Survey. This is really important and good resource for anyone in the audience that is trying to do research and come up with novel ideas, because this is where patients and their caregivers have told us what they want us to study. The US think tank is also replicating this with a more North American survey that went out about a year ago, because this is global, and the US was about 10% of the responses, and if you want to download it, you can have the QR code. This is also sort of the genesis of where I've heard people talk today, this morning, about cystectomy is not something that patients want. After you look at some of the data that's come out, patient-reported, patients' quality of life after cystectomy, self-reported, is higher than if you spare their bladder with intravesical therapy beyond 2 cycles, right? And this was presented at the AUA, and it just came out in JCO a couple of months ago. So this is something we really need to ask the patients. We may think we shouldn't take out their bladder, but the patients are telling us, no, please take out my bladder. I'm happier without my bladder than waking up every 30 minutes at night or every hour at night trying to save my bladder. So really, we have a lot of efforts. You can go to our website and let us know what you want to participate in. This is a walk that Petros helped initiate at one of the AUA sessions, where we come together, we do an AUA session, then we have a walk for bladder cancer, again, just to let the patients know that everything we do, and everything we do here too, is all about improving the lives of patients. And we've done this at ASCO as well this year as a patient-centric care center initiative. We also do this for camaraderie, right? So this is just snapshots of pictures of many of you who've been there in Houston, been at our working meeting. I don't know who this guy is down here who keeps having cocktails served to him. I think it's Andrea. But anyway, we also work, and then we also play. So we go bowling, we try to, Marco's in there, couldn't find his picture otherwise, he told me he was drunk somewhere, but he's right there, you can see him bowling. So it's camaraderie, it's friends getting together. This is our double helix picture from many years ago. We just did one during lunch today. And with that, I want to thank all of you who participate in the IBCG and for making it what it is today.
Thank you, she's amazing. So the next speaker is Johan Loriot from Gustave Roussy in Paris. He will show us the update from EORTC via Teams. So, okay, welcome, Johan.
Hello, can you see me? Yes.
Yes, we can see you.
Okay, so I will try to share my screen. Can you see my slide? Yes, no. Okay. Can you see my slide? Yes, I guess. Okay. So good morning, good afternoon, everyone, and my sincere thanks to Andrea for this invitation. I'm truly sorry not to be physically with you today in the wonderful gathering that you have brought together. Last-minute institutional obligation forced me to remain here in Paris So now an update on the GETUG and EORTC trial. I noticed at the last minute that the scope was limited to EORTC this year, unlike last year. I hope that you won't hold it against me, but as you know, it actually makes perfectly sense since we work hand in hand on this so many trials between GETUG and EORTC. So to remind everyone that the GETUG perspective, what we try to do is to develop practice-changing phase 3 trial to reinforce international collaborations, to do trial in rare tumor, to develop biology-based trial, and of course attract young investigator. So it's a collaboration with multiple academic center and partner, as you can see on this map, and especially in Europe, but also in Australia and in US. And for the GETUG, I selected two important trials that we reported in this year, actually. The first is ALBAN. ALBAN, as you know, was reported at ESMO a few weeks ago, and it was an European trial that we started with Morgan Rouprey in France, and then we expanded in Belgium and in Spain. To remind maybe everyone, so the trial was a phase 2 trial, an academic trial that combined BCG and Atezo IV versus and compared to BCG alone. And the primary, in of course, high-risk non-muscle invasive bladder cancer, and the primary endpoint was EFS. So the result on the left shown that there was no difference between the two arms for EFS and overall survival, of course. And it was in contrast to the Potomac that was reported at the same time at ESMO, and also to CREST reported earlier this year. Another trial that we reported was in the UNDICT trial that was reported at ASCO GU, so early next year, and published in GCO. So the trial here tried to assess the combination of platinum-based chemotherapy given as neoadjuvant combined with durvalumab for a TUC. So in patients with non-metastatic high-grade TUC, that was based on ureteroscopic biopsy or urine cytology or imaging. The primary endpoint of the trial were the PCR, and as you can see here, the PCR was quite low. The YPT0 was 13% in the cohort 1, so with CIS, and 5% with cabo. But the downstaging was pretty good, so around 30%. So probably there will be an UNDICT-2 trial that is something that is currently discussed in the GETUG. I selected some trials that are still ongoing this year. So the first we discussed earlier this afternoon, the K1 trial. It is a pragmatic phase 3 trial conducted by my colleague Laurence Albiges in first-line kidney cancer, metastatic kidney cancer, and that tried to demonstrate that the combination of immune checkpoint inhibitors improve overall survival over TKI plus immune checkpoint inhibitors in PD-1 positive patients, and vice versa, that the combination of TKI and immune checkpoint inhibitors improve overall survival over the double immunotherapy in PD-L1 negative patients. So it is an European trial. It is ongoing and accrued very well, and a big transnational program has been set by Ronan Flippo, along with the clinical activities. Another important point is the PEACE program. You know that it is a prostate cancer consortium here in Europe that tries to develop academic trial in prostate cancer and in both localized and metastatic prostate cancer. So, of course, we're reporting PEACE-1 trial, so 3 years ago, and it was led by Karim Fizazi. And the next, probably the next trial that will have some readout will be PEACE-2. PEACE-2 investigating the combination of chemotherapy and ADT and radiotherapy for high-risk, very high-risk localized prostate cancer. So in this trial, two questions have been addressed. The question of the role of cabazitaxel, and number two, the extension, I would say, of the radiotherapy. So there is another question whether or not we should give radiotherapy only on the prostate or on the pelvis. Another ongoing trial in this context is a PIS4, very, very pragmatic trial, straightforward trial that just has the question whether aspirin or statin improve survival in metastatic castration-resistant prostate cancer. And again, this trial is ongoing. There is also a lot of trial under the PIS6 program, and especially this one, the Oligopresto trial, led by Pierre Blanchard. So this trial addresses the question, the role of radiotherapy on the oligometastasis. So patients here are the hormone-sensitive prostate cancer patient with 1 to 5 lesions, measured by functional imaging, and patients are randomized between the standard of care plus SBRT on this metastasis, so it could be bone, node, or lung oligometastasis. So the trial completed the accrual, so 550 patients were randomized, and now we are waiting now for the data to mature. Another trial ongoing is the vulnerable PIS6 trial that include patients that are very, very frail and not eligible for any chemotherapy or any RP except darolutamide, which is expected to be more tolerated or better tolerated for this patient. So the randomization is again, so standard of care, ADT alone or ADT plus darolutamide, and this trial is accruing patient. Another important trial that we opened this year was the PIS6 poor responder. If the patient is still detectable PSA after 6 to 8 months, the idea here is to intensify the treatment by adding lutein PSMA on top of the standard of care. So we're just starting early this year. The first patient have been enrolled. And so accrual in France for the moment, but of course we will extend to other countries in Europe. Another new trial that has been developed is a PIS7. So PIS7 again is for the patient with high-risk prostate cancer, very high risk. And here the question is again a drug, so whether darolutamide can improve the metastasis-free survival, and number two, the way we are giving radiotherapy, and the question here is to address the question of SBRT boost prostate compared to the standard radiotherapy. And finally, the PIS8, which is starting now, so focus on oligometastatic castration-resistant prostate cancer, so patient with 1 to 5 oligometastasis on functional imaging. And here the question is, should we give radiotherapy to this metastasis on top of ADT and darolutamide? So again, we started earlier this year, and we have our first patient in accrue in France, and of course we will expand in Europe again. Moving to the testis cancer, so we have a lot of trial, and we'll focus on two. The first is EDEN trial for the low volume metastatic seminoma. So what is the concept here? So the patients have a positive PET, so they receive 1 cycle of EP, and after 1 cycle of EP, the patient has a second TEP, we would say an interim TEP, and if negative, there is a randomization between carboplatinum 1 cycle versus a boost of radiotherapy. If the patient has still positive PET, the patient is treated with standard of care with 3 additional cycles of EP. There is another study, the MIRAGE study, in stage 1 non-seminoma. So here the goal is to treat the MRD. So basically it's patient who, of course, has a stage 1 on imaging, the markers are normal. But if we detected microRNA on the blood, the patient will receive 1 cycle of BEP, or standard of care, the patient is still on the monitoring. So the patient, the trial is not starting the accrual, but we expect to have the first patient Q1 next year. Moving to ERTC perspective, so the perspective is very similar. So what we try to develop at ERTC is de-escalation phase 2 trial, pragmatic trial in a rare tumor. And again, it's a platform for attracting young oncologists. So the biggest update was the Peace 3 trial. You know that this trial compared enzalutamide combined with radium-223 versus enzalutamide alone in mCRPC patient. So we reported last year and published in Annals of Oncology that the combinations improve rPFS. But we will have some update in the coming weeks or months because we have this press release that showed that the final analysis actually confirmed that adding radium-223 to enzalutamide improve the overall survival. In the PCS program, URTC is leading the good responder trial, so this one. So meaning that after 6 to 8 months, if the PSA is not detectable, the goal will be to de-intensify the hormonotherapy. So this trial is open to accrual, and the first patient has been accrued in France, and it's a very ambitious trial with a lot of patients, so more than 1,500 patients to be accrued. Another trial that we opened this year, so late this year, so in the coming weeks, it's the Renalut trial here in kidney cancer. You know that PSMA expressed in kidney cancer, and this trial will assess the PSMA mutation given to this patient. So the patient will start with 2 cycles of PSMA mutation, and based on SPECT-CT, the patient could receive either 2 additional more or 2 additional or 4 additional cycles, so up to 6. Another trial that we try to get for which we try to get some funding is the de-escalation in bladder cancer with the EVOLVE trial that is led by Michiel van Heijden and Tom Prols. The goal is to de-escalate the numbers of cycles of EV in patients with good response. So basically, the standard of care will be EVP until progression of intolerance. And the experimental arm will be just EV up to 6 cycles and then only maintaining pembro. The primary endpoint will be both PFS and overall survival, but here we still have some discussion under the funding. And one other trial that we discussed last year was the Starburst trial, so a trial that tried to find new strategy to offer bladder preservation to patients who achieve very good response after induction treatment in MIBC. So there is different cohort, and we will start Q1 next year, the Starburst 1. So here, whole patient proceed with cystectomy after neoadjuvant treatment, so the standard of care, but there will be a reassessment just before the cystectomy, and the goal will be to refine the definition of clinical response. And the primary endpoint will be the correlation between clinical response and pathologic response. And in the same time, we have the Starburst 2. So here, focusing on patients who achieve clinical response. And here, the goal will be to investigate new strategies. So and not proceeding to surgery for this patient who achieve clinical response. So we are discussing with different partners to fund this trial, and specifically this Starburst 2 trial. And lastly, the BRACE trial that focuses on BCG unresponsive high-risk NMIBC, ineligible or who declined the surgery. And the trial is very straightforward, so we will assess radiotherapy because I think we lack some data here. And Vera Nachar, who is a radiation oncologist, is leading this trial in France and Belgium. And so we expect to accrue more than 60 patients, and the first patient will be probably enrolled in January next year. Thank you so much.
Thank you very much. I hope we are going to have you in person next year. Now, we are a little bit late, so I'm counting on the next speaker for that. Please welcome Dr. Philippe Spies from Moffitt Cancer Center.
Thank you. We will do it Modena style. Ferrari. There we go. So first of all, it's a pleasure to be here. Congratulations to Andrea, Francesco, Alberto. This meeting is exceptional. I always learn a lot, but it is truly a gathering of great friends and great thought leaders. So thanks for carrying on the tradition, and the helix keeps getting bigger and better, so onward and upward. So I will just give a little bit of an update on the Global Society, and Ashish sort of shared a really exciting collaboration that we share through our friendship and through our common vision to try to advance rare cancers, particularly variant histologies, where there's a huge unmet need. Let's see if I go forward. No. This one. The yellow one? Oh, yellow one? Okay.
The Ferrari goes forward.
All right, let's see. All right, here we go. So just to give a quick update, we've done a little bit of a refresh of our leadership team. I think we've achieved a lot in a few years. You know, we always say that it was Andrea's and my vision during COVID to try to develop something which was thoughtful and meaningful, and particularly in rare GU cancer space where we have a passion. And so we have some really incredible thought leaders. I'm looking at one on the stage up here. Chiara's done some exceptional work with the rest of the group, and we've done a really refresh of our website, which I'll be happy to share with you. Will be going up live fairly soon, but I think a lot of our focus has been on patient educational resources. I will tell you, I just got back from the NCCN meeting, and the NCCN does a lot of great work, but when it came to talking about patient advocacy in the rare GU cancer space, I will tell you the crickets are chirping in the room. There's really not that much, I would say, focus at this point for large organizations to do this, so I think there's still a huge unmet need there. Also, our patients across the globe clearly know there's a huge educational gap that is present across the world related to rare GU cancers, and I think that's our society is very dedicated in learning from our patients what the needs are, meeting those needs, and letting it being patient-driven. And I think we can learn a lot from what's been done by, for example, the IBCG in bladder cancer in sort of doing that. Also, I'll sort of briefly share, again, I'll start speeding up here, on updates in testicular penile variant histologies and in kidney cancer, and Monty has sort of taken on the leadership role related to our rare cancers and variant histologies and kidney cancer, so excited to see what we accomplish. So just to highlight some of the members, Luis Medina is a young, bright, rising star who's now on faculty actually at MUSC, completed his fellowship at USC actually. He reached out to me, he was very interested in doing some meaningful work, and I would say to many of my friends in the room, be careful what you wish for when you approach Ashish, Petros, myself, or Andrea to do work. You will end up with a whole lot of it very quickly, and I would say him, Chiara have embraced it and have really accomplished a lot in a very short period of time. Nahuel and also Amandeep from our good friends at Tata Memorial have been part of our new leadership type of refocus group as well. So again, what are the core pillars of our society? Really to peer support and help connect and really bridge a network of collaborators across the globe related to rare cancers. As we know, the word rare cancers is really a very broad term. It's not about testis or penile or adrenal tumors. As we all know, and many times when we go to meetings, when it goes to variant histologies, oftentimes that's where I would say a lot of the debate in the room sort of happens is there's a critical need, as was really eloquently said by Giuseppe, to really gather thought leaders across the world in this space. And again, I would say our society has been very tactical to try to answer questions thoughtfully, much as was discussed through retrospective studies and through collaborations, and we'll talk a little bit about some of these efforts. And last but certainly not least, again, education is critical to our focus and to our mission. So again, just to give you a little bit of our focus for our educational refresh, we're going to have some webinars. There's going to be some key highlighting of salient articles for clinicians to be aware of in this disease space, and also to post for patient-specifically educational resources. And last but not least, getting regular newsletters. And I will tell you the website refresh, as we'll discuss in a few minutes, will have two components to it. One will be clinician-facing, and then there will be a patient-facing. That will be run by patients, for patients, with clinicians providing some thoughtful input when it's sought on various topics. So I think that's going to be a critical need, and I'm glad to see we have a really great group of patient advocates that are leading this effort. Again, this is going to be, we sort of talk about a concept of developing an ambassador program. We really know, many of us in the room know there are some thought leaders and some really talented clinicians across the world, and we want to elevate these clinicians to be given the ability to sort of serve as ambassadors across the globe. Clearly, we amplify our mission and our ability to impact patients and families across the world if we do that. Again, patient educational resources is going to be critical, and I think we do have a very engaged group. So the refresh for the patient advocacy group, it's going to be called PCARE, Penile Cancer Advocacy Research and Education, specific to penile cancer. We're developing a lot of that material right now, so probably in the next 2 to 3 months we'll be sharing a lot of that with our members and with many of the thought leaders on this topic. This is a little bit of what the website will look like. I think there's still a lot of components, but it's going to be a much more dynamic website, which will be much more engaging. I think we've learned from the past, you know, many of us in the room, if it's a very static, non-dynamic type of interface, it's just not very useful, and honestly, it won't be used by many clinicians. So we are planning on having regular updates related to educational material on there. And again, adding some resources that patients and their families could go to with some very practical type of clinical information, such as things on management of lymphedema in patients who have, for example, inguinal lymph node dissection, those types of relevant topics. Our patient stories are very impactful. Obviously, they lead us to want to do more, but I would say that we're learning a lot from our patients in terms of unmet needs. You know, many of us in this room know this, is sometimes we think we know what the needs of the patients are, but oftentimes they are very different when you sort of speak to the patients and understand that it could be very simple terms of how they deal with having some penile sparing surgeries, or how they deal with, for example, with testicular cancer and being 20 or 30 years out and having that continual fear, or some of the long-term challenges related to dealing with their diagnosis. So I've learned a lot, and I know many of our leadership team have as well. You know, a couple things and a couple of initiatives that I really have been very pleased to see, and this is one here, is we've developed a Delphi and consensus guidelines, the management of complications and management of how you should care for patients with inguinal lymph node dissection. The CAL, as you know, many of you have participated in the CAL meeting. They've developed penile cancer guidelines. Many of us have served on that group. So try to, again, elevate, much like it was like Ashish and IBCG has done for globally, try to impact the ability of our society to sort of amplify its message and its impact across the globe. Not the least, obviously, we've been working now with ESMO, developing some educational resources on rare GU cancers, and I'll be fortunate to be attending this year ASCO GU, and we'll be having a session, a dynamic session related to penile cancer and other rare GU cancers where our society will be highlighted. A couple of things that are coming up. There's a couple of issues that will be focused and will be sort of co-led with the Rare GU Society on rare cancers. This is one that Ben Ristow and myself will be leading, and Louis is sort of leading this other effort as well. Something I'm very pleased, and I would say it's always great when great science comes with great friendship, and I will give credit to Ashish. He brought up this thought to me, I remember 3 years ago, about trying to work together, and he sort of defined the rare variant histology space in bladder cancer was a huge unmet need. And I'm always impacted when I go to the IBCG and we have really great discussion. When we start talking about variant histologies, that's where it all goes out the door and everyone sort of has different debates and different things. And the mission of this collaboration between the IBCG and the GSRT to me is crystal clear. I think, you know, we've had a very positive first meeting, and it's about keeping that forward momentum. This year we'll be holding and hosting a meeting again. This will be held in February 20 and 21st, specifically focused again on variant histology, bladder cancer, but starting to really dive in to the clinical trial concept and really try to define not only the endpoints, but how these studies should be done thoughtfully in the variant histology disease space. Obviously, there are some consideration there related to the rarity of cases, statistical design, criteria, what histologies would be relevant to include in trials. All those types of things will be sort of led and sort of be discussed. Glad to see my good friend will be there, as well as many of the people in this room as well. And just to briefly discuss other initiatives, just to try to sort of speed up a little bit. A couple of our committees have been very successful. Roger Lee, many of you know him in the room. He's a very talented faculty member. Ashish trained him as well when he was at MD Anderson. He came to Moffitt several years ago and has really hit the ground running. He's really leading our genomics committee, and they've accomplished much. They have a prospective registry right now in variant histology they're developing, and several major, they have a review as well for EU they're developing at this point in time. Axel Heidenreich, a good friend of mine, who, as you know, is an exceptional germ cell testic cancer expert and also leads the European Society on Germ Cell, is leading as well our testis cancer subgroup. He has several important initiatives related to prospective validation of microRNA, for example, also doing some prospective questions that he's answering in the post-chemoseminoma space. So many things we're doing and planning to do, and eventually embarking potentially in clinical trials in the variant histology disease space as well. Penile cancer, I think there's much that we're excited about, doing some collaborations, validating the role potential of ctDNA, global experience with novel agents. Guru Sampabde is doing some nice work that he's sort of leading on behalf of our society. Last but certainly not least, I'm there just ecstatic to have Monty leading our variant histology disease space. As many of you know, Monty, you just give him the concept and he's able to get global engagement very quickly, but also very thoughtful, giving these people the mentorships, support, and letting them sort of lead these types of initiatives. So I'm very excited that Monty's involved, and I know much will come from our kidney cancer variant histology subgroup. Last but certainly not least, I'm very excited. I think the future of our society is bright, but it comes through collaborations, it comes through partnership, and most importantly, it comes through great friendship. And I'm very pleased that I get the pleasure and fortune to work with many of you in this room in trying to build and advance the care for our patients and their families. Thanks again for your attention, and looking forward to some questions later.
Thank you, Philip. Collaboration are essential even more in rare cancer. So the next speaker is Petros Grivas from Fred Hutch Cancer Center. Please, Petros.
Grazie mille. Thank you so much. Kudos once again, Andrea and team. What a wonderful opportunity to connect, learn together, and get inspired with each other. You know, I told my mentees, you know, we all work so hard. We come to these meetings and we get re-inspired and really get the fuel and the juices going for more innovation. I have to tell you, you know, this is the 4th edition, of course, and time flies. The major change that happened since last year for me, I can share with you publicly, I got a couple of new leadership roles at Fred Hutch. And I put them in the slide here, medical director of an international program. I think it's a wonderful opportunity to even establish more collaborations. There's so much need across the world, you know, for, of course, patient care, for research education. So as we evolve this program, I look forward to discussing with you more ideas and assist IBCG, Global Site of Hereditary Tumors, Phil, and other opportunities. So something to keep in mind. The other thing that I'm doing is more work on regional outreach in the Washington state and around Fred Hutch. And the other thing that happened in the context of my talk here, I was very honored to take over a new role in the ECOG ACRIN system. I became the co-chair of the GU committee at ECOG ACRIN. So it was a very honorable opportunity for me to get more involved in that group. These are my disclosures in the last 2 years. My major disclosures, I slept only 4 hours, so please bear with me as I try to stay on time with limited sleep. And by the way, I still have one more article for the IBCG newsletter. I'm going to send that to Prem for ESMO, so I'm still active. So as I mentioned to you, I took more roles in the ECOG ACRIN system, and it's such a pleasure to work with amazing colleagues and friends there, and I want to highlight some of the initiatives across the ECOG ACRIN group. Keith Flackett is the president-elect for AACR. Kristen Spencer is a colleague, she's an NYU, and they're both leading some important kind of across cancer type committees, developmental therapeutics and genomics committees that bring together different cancer types and look at biomarker-based clinical trials, in like basket trials, umbrella trials, looking at biology and how this can inform clinical trial design based on biomarkers. And of course, there's many examples of why these collaborations are important. Of course, this is exemplified by this meeting here. We have key opinion leaders at ECOG ACRIN. We work together in clinical trials with complementary expertise. We have a gamut of investigators across institutions, across geographical areas, different talents, translational clinical investigators. And of course, we want to collaborate more, right? We have, of course, colleagues and friends at SWOG, colleagues and friends at NRG, Alliance, who try to work with multiple cooperative groups in the United States, and of course, beyond internationally. And of course, through this collaboration, I think we can conduct large-scale clinical trials. Some of them can be practice-changing. So one example that, I think it's really important to highlight is the combo match trial. This trial is actually bringing together talents, again, the ECOG ACRIN group and beyond. This is a National Cancer Institute NCI initiative, and it's a trial that is across tumor types, a basket trial, looking at the premise of identifying signal-seeking study across tumor types based, again, on biomarkers that can potentially predict response to targeted therapies that comes through combinations. And this is a continuum after the NCI match version 1 that happened about a decade ago, a lot of lessons learned. And one of the lessons learned was that resistance can happen, relatively fast with single agents. So with combinations, The idea is to target this tumor heterogeneity. You know, we heard some amazing lectures today about tumor heterogeneity from many colleagues. How can we target that in a combinatorial approach? So that ComboMatch trial gives us the opportunity to design trials that are based on particular biomarkers and therapeutic targets, genomic drivers, and how can we think about the biology as the driver of trial design. And of course, because the tumor is heterogeneous, hitting it from different mechanisms of action with potential synthetic lethality may actually have some benefit and some hopefully higher effectiveness. Let's see here. Oop. So this is just the design of the ComboMatch. In a nutshell, this is again a biomarker-driven approach, tumor tissues being analyzed in the sequenced in particular labs that are accredited for the study. And depending on the presence of particular biomarker, there is a bioinformatic analysis that can identify patients who are candidates for a particular combination of treatment. And I will give you some examples in a second. Of course, the patient goes through a strict eligibility review, and if they match the trial, they get assigned to a particular arm, they get treated, and then there is, of course, baseline tissue analysis, there's biopsy progression, and of course liquid biopsies. Jeff, you talked about liquid biopsies today, so we can try to learn through serial longitudinal ctDNA analysis through this platform of the ComboMatch trial. These are just examples of ComboMatch different arms or cassettes. As you see there are different study agents, different molecular eligibility criteria, and there are different mechanisms of actions. Again, these are just illustrative examples of how combination regimens can be tested in tumor type particularly, or across tumor types in order to find signals that can lead to a larger registrational trial. This is a signal syncing trial, as I mentioned, biomarker driven. These are just other examples of how we can utilize biology and molecular analysis, again, similar to what we had earlier today, through tumor tissue analysis, and we're discussing about ctDNA as a screening test. And when we define the particular biomarker, these combinations can enter the trial cassettes. Of course, there has to be robust data, preclinical data, including in vivo data that show enough rationale to have a combination, and ideally phase 1 clinical data when available. Now, I'm going to switch gears now from this more basket type approach and molecular biology approach to the GU-specific trials. And as I mentioned, I was very honored to take over as a co-chair of the GU committee a few months ago. This is a rapidly evolving field, and there's so many trials to cover, so I'm going to focus on a few examples in the interest of time of what we're doing with ECOG ACRIN. In this slide, what you see here is you see different disease spaces and therapy settings, from localized bladder cancer, non-muscle invasive bladder cancer, BCG naive, BCG exposed, BCG responsive disease, muscle invasive disease, neoadjuvant, adjuvant bladder preservation, and metastatic disease, and of course, variant histology is part of that. So with this cadre of therapy settings, we try to design clinical trials that are specific to its disease space and therapy settings. So, as examples, as I mentioned, cannot be comprehensive here because of in the interest of time. This is a trial I want to highlight called the BRIDGE trial. This is my good friend of mine, Dr. Max Gates, who is in Johns Hopkins. Max is a great guy, and I want to really congratulate him for putting together this almost 1,000-patient trial comparing intravesical BCG, the standard of care, to gemcitabine docetaxel chemotherapy, sequential chemotherapy. That trial is actually fully accrued right now, and we're waiting for results. This is for BCG naive patients, and I think it's going to be very important to evaluate whether gem-doce is non-inferior or not to the high bar of intravesical BCG. This is a non-inferiority trial, fully accrued, results are pending. If we go to muscle-invasive bladder cancer, there are many examples, but I want to focus a little bit on upper tract disease. This is a trial that I'm honored to be the co-chair, and this is an effort with Dr. Ginny Hoffman-Sensic. Like Max Gates, Ginny is also at Johns Hopkins, and this is a trial where we try to ask a very important question. What is the role of chemoimmunotherapy in upper tract urothelial carcinoma? We have data from Niagara trial. We discussed earlier today with Andrea and others that Niagara has an established role in muscle-invasive bladder cancer, but I think upper tract requires dedicated trials. So this is a trial that we put together a few years ago. This is the schema of the trial. We have a cisplatin-eligible population, and we're comparing dose-dense MVAC alone or dose-dense MVAC plus durvalumab. So we're asking the chemoimmunotherapy question in the upper tract disease, which I personally think is a separate question compared to bladder cancer. Some people extrapolate right now based on the Niagara data. I think we need to ask the question separately in upper tract disease. And this trial is ongoing. We have a cisplatin ineligible cohort, which is fully accrued. This is gemcitabine and durvalumab combination in patients with cisplatin ineligible phenotype with upper tract disease. So that data of cisplatin ineligible population is fully accrued, and we're hopefully going to present the data at ASCO GU, hopefully in the next couple of months. So if you're in the US, Phil, I talk to you, I see it doesn't listen, but you may listen to open the trial if you can. It's an unmet need to answer the upper tract neoadjuvant therapy trial answer. And in bladder preservation, I know we're going to hear more by Jason in a few minutes. So just to give him kind of hold on. What happened here? Jason, I think you want to show the slide, right? That's why. Hopefully the slides will come back up. Let's go here. Okay, so this is what Jason plans to show you as well. This is SWOG NRG 1806 trial, phase 3 trial, trying to answer the very important question of adding checkpoint inhibitor to the backbone of chemoradiation as a method for bladder preservation in muscle-invasive bladder cancer. This trial fully accrued, I think it was February 2024 when we finished accrual, right, Jason, about a year and a half. So we're waiting for events. As I always say, if patients have no events, that's a good thing for the patient, so the trial may take longer to read out. So keep an eye on that. Again, concurrent chemoradiation with or without atezolizumab, with bladder intact event-free survival being the primary endpoint of the study. And we're doing a lot of translational work. We have monthly meetings, look at translational endpoints in that trial. And last but not least, metastatic disease, talking about group effort, and this is another huge endeavor that we worked hard in the last 2 years with my dear friend, Dr. Monica Joshi, who is on the left part of the picture here. Monica is the chair of the trial, I'm the co-chair, and we have a great group, of course, of people working together. This is a trial that we just launched a couple of weeks ago. So again, from colleagues in the US, if you can open the trial in your institutions will be great. This is the 8231. I mentioned this trial earlier when Antonio was talking about the real world data. This is building upon previous work that we have done, and I was personally involved with sacituzumab govitecan, antibody drug conjugate against TROP2. This is a long journey, but I can tell you that over the last 7 years, we work with this drug in metastatic disease. We published a number of manuscripts with this drug, phase 2 trials, phase 3 trials. The drug got approved by the FDA in I think it was April 2021 as monotherapy in advanced pretreated urothelial carcinoma. A subsequent phase 3 trial that I had the chance to present at ESMO Asia last year did not meet the primary endpoint, so there was withdrawal of sacituzumab govitecan from FDA approval. However, I think we all have patients who benefit from this drug. At least in the US, we have used the drug. We use it with primary prophylaxis of growth factor, and the question is, can you evaluate further its efficacy? So I had the honor to lead this phase 2 trial with SACHI plus pembro metastatic disease, similar to what Andrea, you did with the neoadjuvant trial here in Italy. So SACHI pembro was a phase 2 trial, 41 patients, and this was actually a positive trial with a 41% response rate. Half of those were complete responses. Some of those responses were durable. This is platinum refractory patients, immunotherapy naive. We published this last year in JCO, and based on this positive phase 2 trial, we built this phase 3, which is SACHI plus pembro versus platinum-based chemotherapy or single-agent taxane, depending on whether the patient was previously exposed or not to platinum-based chemotherapy. So this is a large trial, 320 patients. Again, we need help opening sites in the US. So if you can open the trial, it will be much appreciated. We just launched it 2 weeks ago. So this is SACHI plus Pembro versus platinum gemcitabine or taxane chemotherapy. A lot of qualitative analysis and overall survival is a primary endpoint. So a few last thoughts as we move forward to the end of this session. Before Jason talks about bladder preservation more, I think as you have said that the strength of the wolf is in the pack, and this is how Clinical Trial Network works in the US, similar to what you're doing here in Italy, how ERTC works, how many other groups, Mituro and others, Giuseppe. So I think it's important to think about particular questions. Think about, trial designs that have, applicability to a broader population. We have to also to think about beyond therapeutic trials and advanced disease. We think about screening, about early detection. How can we use molecular residual disease in a serial manner to help with potential earlier detection of cancer? We have to think about, what makes sense in terms of applicability to a larger scale, geographical areas, diversity. And of course, we have to make sure we collaborate both with industry and academia and patient advocacy groups to make these trials happen. There's opportunities for database work, registries, biobanking, working groups, think tanks, and of course, patient advocacy groups keeping the patients in mind. Funding and time, there's a limited resources, but when we work together, I think we can make the best use of those resources. So this collective effort has the potential to keep changing the landscape globally. With that, I want to thank you for your attention, and thanks again for bringing us together.
Thank you. And now welcome on the stage our last speaker for this session, Dr. Estadiou from Harvard Medical School. We will present us the updates from the Radiation Therapy Oncology Group. Please.
Great, thank you. Yeah, I'm so excited to be a friend of all of you. No, it's really, really incredible. What a beautiful meeting. And let me just make. It's not going ahead. Wow. Whoop. There we go. Okay, there we go. Yes, so I'm going to be presenting updates from NRG Oncology. We have a huge portfolio, and I'm doing this on behalf of the team. I'm the vice chair for NRG GU, but Felix Feng really set the stage for this portfolio. Paul Nguyen, Howard Sandler, Todd Morgan, Raina McKay, Oliver Sartor, Dan Spratt. It's a huge, huge team, and all the PIs of the trials that I'm going to highlight. Here are my disclosures. And I just want to say it is an incredible honor to be in Milan at San Raffaele and in the home of the GU Avengers. And Andrea leading this incredible conference. I'm very honored to be here and to be a friend of all of you. So thank you. I'll put that on our feed later. The other thing is NRG stands for energy, right? And we are also in the city where the unit of energy is an espresso shot. And so I think NRG plus an espresso shot, this is going to be an explosion of trial acronyms and clinical trial work. So in NRG, we really have a vision for a trial in every disease space. So I'm going to start off with prostate cancer. And you see all the disease spaces. You see all the trials, their status, and potential successors. This is in intact prostate. This here is in post-op prostate. And I'll be touching on all of these trials. So a vision for a trial in every disease space. There's also a vision for biomarkers to personalize therapy. And as you can see, and I think we have Eli and team here, Decipher is integrated into a number of these trials, and we're also integrating AI biomarkers. I'm going to pepper this talk with some updates from ASTRO, big trials, randomized phase 3 trials that were just presented, not published. And the first one in the high risk, unfavorable intermediate risk and favorable high risk setting was, do we need to treat the pelvic nodes? There's a number of trials that have looked at this. A couple of big ones have been negative. There's a small single center study from India that's been positive in the very high risk setting. But this trial is a huge trial trying to answer this question. Basically, unfavorable intermediate risk or favorable high risk randomized to prostate only or whole pelvic radiation, and here are the results. With long, median follow-up, well over 7 years, overall survival is not different. Prostate cancer-specific death is not different. Distant metastasis is not different. There was a modest benefit to whole pelvic radiation in terms of biochemical failure, but as you can see, very, very modest, 17% versus 13% at 10 years. And GI toxicity, grade 2 or higher, was a little worse when treating pelvic nodes, as you might expect, but grade 3 was not different. There was no difference in GU. So at 10 years, whole pelvic radiation doesn't seem to improve overall survival in some of those other endpoints. So I think I'm also the only radiation oncologist. Is there any other radiation oncologist in the audience? No. So it'll be very interesting.
Radiation Oncology Congress today.
Oh, okay. There's a competing radiation oncology congress that I'm missing. Yeah, great. So basically, I think many of us are going to not be treating pelvic nodes in unfavorable intermediate risk and favorable high risk probably moving forward. I mean, this was a 2,500 patient trial. All right, so let's go back to the portfolio. So we're going to touch on all of these trials. And again, I'm going to go relatively quickly. So we have in the intermediate risk disease space, this trial was just presented again at ASTRO, and it was moderate hyperfractionation versus SBRT. And what did it show? But I have to point out, SBRT to 36.25 gray. And here is what the trial was trying to do. It was trying to show that SBRT would be superior to moderate hyperfractionation in terms of patient-reported GI and GU outcomes. And it was trying to show that SBRT would be superior in terms of disease-free survival. What ended up happening? Well, actually, GI, bowel outcomes patient-reported were worse for moderate hyperfractionated IMRT. SBRT was actually better, interestingly. There was no difference in urinary irritative or obstructive outcomes. And look at this, disease-free survival. The futility bound was crossed. SBRT was not superior in terms of disease-free survival. And if you actually look at the curves, it looks like there's a benefit for IMRT. So I'm going to argue, though, that this dose was too low. It used 36.25 gray. PACE-B was 40 gray to the CTV. I think there is a very sharp dose response that's happening at these very high doses. And I'm generally using 40 gray. But with 40 gray and PACE-B, you saw that urinary toxicity was worse compared to more conventionally or moderately hyperfractionated therapy. So I think these are very interesting trials to put into context with one another. Biochemical failure was better with hyperfractionated therapy, interestingly. All right. So that's basically what that trial showed. In the intermediate risk space, we have NRG-GU10, which is a genomic risk-stratified study in unfavorable intermediate risk prostate cancer that uses the Decipher score. If you have a low Decipher score, you go into a de-intensification of radiation alone versus radiation plus short course hormones. If you have a higher Decipher score, you go into an intensification randomization of radiation plus short course ADT plus minus darolutamide, okay? And so it's using Decipher to prospectively risk stratify patients and looking at treatment. And as you can see, I just want to highlight one thing on this trial. It finished accrual to the intensification arm. The de-intensification arm will finish by January. This trial is accruing at about 80 patients per month. NRG can accrue massive amounts. This next trial that I'm going to show you, GU009, is the same idea in the high-risk localized prostate cancer space. Using the Decipher score, if it's low, you're in a de-intensification to radiation plus 1 year of hormones versus 2 years of hormones. And if it's a high Decipher score, you're randomized to radiation plus 2 years of hormones plus minus apalutamide, intensification. Look at this. This trial fully accrued at 2,500 patients. So this trial accrued at about 90 patients per month. And so our current trial open in the high-risk space is GU013, called the High-5 trial, looking at SBRT in the high-risk localized setting, prostate cancer, versus conventional or moderate hyperfractionation primary endpoint non-inferior failure-free survival. This trial is accruing at about 45 patients per month and is at 563 of about 1,200 planned patients. And this trial here, GU007, is in the very high-risk space. And it showed that actually in the cooperative group setting, you can run phase 1 trials. So this is a phase 1 trial of niraparib with radiation and ADT in very high-risk prostate cancer. Small accrual, and data is maturing. These are the planned next trials. So in the intermediate risk, unfavorable intermediate risk space, we're looking at radiation alone versus radiation plus ADT, looking for superiority of radiation plus ADT for metastasis-free survival, powered to detect superiority in a biomarker-positive luminal B subgroup, and I'll get back to the luminal B subgroup shortly. And in the high-risk space, this is our successor that's working its way through the NCI right now, which is using Artera, so an AI biomarker to risk stratify low or high risk for distant Mets. And again, it's a de-intensification if you're a low MMAI score, looking at shorter duration ADT with darolutamide. And if you're a high risk MMAI score, it's intensification, 2 years of ADT plus minus darolutamide. So again, biomarker risk stratified prospective trials. In the post-op space, these are the disease states we're looking at. Here are the trials. The BALANCE trial was just presented at ASTRO. This is a very interesting study. So it's a placebo-controlled biomarker stratified randomized trial of apalutamide and radiation for recurrent prostate cancer in the salvage setting. And basically, it's looking at a novel luminal basal classification adapted from the breast cancer PAM50 signature. And the hypothesis is that in transcriptionally defined luminal B tumors, they're going to derive greater benefit from the addition of apalutamide with salvage radiation for recurrent prostate cancer. And basically, the randomization is to salvage radiation plus 6 months of placebo versus 6 months of apalutamide. This trial was just reported, 295 patients. 43% of the patients were luminal B, and here are the results as presented recently. In that luminal B subset, there was benefit to apalutamide added to salvage radiation, but in the non-luminal B subset, there wasn't. Okay, so very interesting. This is the first prospective validated trial of the role of ADT with radiation based on a biomarker. And the same applied to metastasis-free survival, as you can see in the luminal B subset, there was benefit to apalutamide. And so again, this represents the first and only prospective validated predictive biomarker to guide the use of hormone therapy. And in luminal B tumors, there is a benefit to the addition of apalutamide to radiation. The STEEL trial, this is going to present at GU ASCO, and this is also in the salvage setting, but a bit of a higher risk subset of patients. And the randomization here was salvage radiation plus 2 years of ADT plus minus 2 years of enzalutamide. And so this trial here will present at GU ASCO if you're going. And then in the node positive post-op salvage radiation setting, there's this trial, GU008, which is a randomization to radiation plus 2 years of hormones plus minus apalutamide in the pathologic node positive setting. And the last prostate trial is GU011, which is looking at SBRT plus minus darolutamide for recurrent PET-detected oligometastatic prostate cancer after prior radiation or surgery. And again, so this is looking at SBRT with relagolix. And this trial is, all the trials are actually accruing very, very well. So the summary of the prostate trials is the past. The NRG, which used to be RTOG, has a long history of looking at addition, duration of ADT, radiation doses, field sizes, brachytherapy. But as you can see from the current portfolio, it's really looking at use of genomics, AI, imaging to improve risk stratification, patient selection, the use of next generation anti-androgen therapy and other novel agents with radiation in earlier disease spaces, and more aggressive management of oligometastatic disease. That has been really the themes of these trials. In just the last couple of minutes, I'm going to go over our bladder cancer portfolio. So here are we have studies in non-muscle invasive and muscle invasive disease. In non-muscle invasive disease, we had this very small study from RTOG 0926, only 37 patients, that showed that in recurrent high-grade non-muscle invasive disease, where the next step is meant to be cystectomy, you use chemoradiation as a way of an attempt at bladder preservation, and an 88% free from cystectomy rate at 3 years. That little study has led to this GU014, which recently activated a few months ago, which is looking at high-risk T1, stratified by disease history, is it de novo or recurrent, by histology. It allows for mixed histology. And it's randomized to chemoradiation, like that last little trial I showed you, or radiation plus pembrolizumab for a year. So it's integrating IO in this setting. Now, these patients could have received, because they're, of course, and Ashish did a great job of showing all the new treatments in non-muscle invasive disease. These patients could have received new novel intravesical therapies. They could have received, well, I'm not sure about IO, but they could have received all the novel intravesical therapies. And again, it's the next step would be cystectomy. Those are the patients eligible for this study. It's a niche space, but we've already accrued 9 patients. The goal is 160. It's only been open a few months, and it's still activating at many centers. SWOG NRG 1806, Petros referred to this study. This is chemoradiation plus minus atezolizumab for a year in muscle-invasive bladder cancer. This trial fully accrued, largest bladder-sparing trial ever to accrue in the world, I think still. And this trial accrued in March of 2024. As Petros pointed out, it was pretty impressive. And early safety toxicity results we have presented that show very favorable things you'd be worried about, colitis, cystitis. Those rates were the same between both arms. So adding IO to chemoradiation appears to be safe. Here is the new large phase 3 randomized bladder-sparing trial with an accrual goal of 486 patients, very recently activated, has 4 patients on study, and that is looking at T2, T3 disease. It allows any neoadjuvant therapy, so EV Pembro, Niagara regimen, NAC, whatever, stratified by the use of that neoadjuvant therapy in a randomization to moderate hyperfractionation, 55 gray in 20 fractions, or bladder SBRT, 32.5 gray in 5 fractions. If this works out, this will make bladder-preserving therapy so much more accessible. And I think if we see great responses to neoadjuvant therapy, this could be very, very exciting. ctDNA is embedded at 7 time points throughout this trial, so that's going to very much, I think, also help inform results. This trial, unfortunately, closed due to slow accrual. It was in node-positive bladder cancer. It's a very hard group to actually define node-positive bladder cancer and accrue to, and this was in partnership with ECOG Akron, and unfortunately, it was looking at chemoradiation plus minus IO, and this failed to accrue. Last study, renal cell. Yes, first time NRG ever entered renal cell. We know there's a lot of exciting work with radiation in renal cell. SBRT for primary is gaining traction. SBRT of oligorecurrent, oligoprogressive disease has data to support it. And then there's the question of cytoreductive treatment. This study here, the Samurai trial, is looking at that, cytoreductive treatment. So in metastatic renal cell carcinoma, receiving immunotherapy, it's plus minus SBRT to the primary. In this trial, this study has already accrued 101 out of 240 patients. So, as I said, I was going to go through a huge portfolio. I hope you can see NRG has a massive portfolio. It's obviously very much so in prostate cancer, but also in bladder, and we've also entered renal. And I hope that all of what we're seeing today is providing, from all the speakers, is providing data that informs guidelines, we know it is, that informs physician practice, ideally in a multidisciplinary environment like this meeting is advancing. And I also hope that you see that we're in the city of fashion, right, Milan? I hope you see that our portfolio at NRG Oncology is clinical trial chic. Thank you.
Thank you very much. I think we need to proceed directly to just a question.
Fantastic talk, guys. I'm just curious to know
it's something that I tried many times unsuccessfully to see if there is any chance for us as well as for any European center to join the network of ECOG, of NRG, and so. The point that I realized, the limitation that I realized is that when shifting the trial and translating the trial to the European Union, we as a single center should act as a sponsor, European sponsor of the study. This raises a lot of concerns with regards to bureaucracy and so. Do you think it's feasible somehow to overcome this limitation and to open up the door to European centers?
Unfortunately, I think it's more challenging, and I'll speak to this. I'm the NCI-GU Steering Committee co-chair, along with Dan Lin and Michael Morris. And basically, we've met with the EORTC to discuss this, and there's a lot of challenges in this. Not only like things like drug availability and monitoring and this and that and regulation. Some countries like the UK, it's very hard regulatory-wise to do that. We have in the past, so we have umbrella organizations with NRG. So Christie Hospital, for example, used to be under the University of Maryland and could accrue to some studies. Tata Memorial currently is part of NRG under the University of Maryland, and we're trying to get them on board for the bladder studies, for example. So there are some ways that it can be done, but unfortunately, it's probably the difficulties are much greater than we would have thought. And so one of the proposals that we had when we met with the URTC is developing shadow protocols, so that basically the same study opens and that there's a pooling of results later in the future. Yeah, it's possible. You have to look at, so some universities and some centers have very strict rules on sharing of data and patient data, okay, like very strict where this is not allowed. This has happened at the majority, like in a lot of UK centers, for example. So I think it is absolutely worth exploring. We have had singular examples where we could do it, like Tata Memorial, and I think it would be awesome. Yeah.
Time to join US for bladder cancer, non-muscle invasive, or also radiotherapy. Unfortunately, we couldn't do it. We spent a lot of time in trying to do it. At the very end, it was not possible. But it's possible you do the same trial here, and then maybe you join with the result.
Yeah, I think the shadow protocol is really worth considering for trials that are tougher to accrue to and where one needs, numbers.
Yeah, just to allude to that, the shadow protocol, in fact, we've done that with the BRIDGE study. So the BRIDGE study is a US study, and then Wei Shantan, who was with me, came from John Kelly's group, has opened it up in the UK through the official UK program, because it's hard to do that. It's a governmental thing, as you said, because even when I was on the task force, it's not that the organizations don't want to do it, it's the US government. The NIH, NCI doesn't allow that sort of data sharing to occur. So just like that, we've had other universities in India, Tata Memorial, come through the US universities. I think Cleveland Clinic has that as well with Abu Dhabi. So you can do it that way, but you would have to essentially have San Raffaele become part of MD Anderson, and then you could open it.
I agree.
I see so many possibilities for multiple, and the reason of this session, giving fresh updates from many centers, many networks, But the point is, try to overcome this separation, trying to see if at least for certain studies, key studies, in particular, wherever you don't have, or whenever you don't have any experimental therapies to share, to ship with labeling issues
I agree, Andrea, I agree totally with you, and I think you raised all the issues very well, Jason, all the challenges. I think a good example is the ambassador trial. If I remember correctly, there was a huge effort to open it in Europe through Alliance, and there was effort and sweat and blood and tears, and then they couldn't open it, and there was multiple reasons for that. But I think there are opportunities. There are some examples, I think, as you mentioned that, there are some examples in Jason. With EcoCacra, there are some trials open in Ireland, for example. It's a track record, and there is through affiliation with individual institutions that Jason mentioned. So there is an avenue. It has to be a selection. There are examples, exactly. So let's talk more about that, and maybe it can be a formal process with individual groups, but has to be very rigorously selected and go through a very strict process. But I think individual affiliations is probably the way, a potential avenue, but it's not easy.
I'll keep it really brief, but I think it's very salient. I just took over as the SWOG GU international representative, and so I've learned a lot about this. So SWOG actually has a number of sites open in Latin America, Colombia, Argentina, et cetera. If you look at a map of South America, the only reason that there are some countries who can't participate in SWOG studies has nothing to do with NCI. It actually has to do with the country's policies around ensuring clinical trials and safety around those. I'm happy to dive in a little bit deeper and try to get a better sense of the situation in Europe, but we've actually had not shadow protocols, but actual direct participation. So Sarmad had mentioned Brian Chapin's prostate study, looking at radiation or surgery as definitive treatment for metastatic prostate cancer. Mexico is actually one of the highest accruers to that trial. They have 60 patients that they've enrolled. So there's certain protocols that do exceptionally well with external collaborators, and we're taking an active approach to enrolling ex-US.
And it's also a matter of accepting indemnity by the institution. So these are institutions that are willing to accept that indemnity, some are not. So it can become very much institution specific. I think the other important thing is just the share, what we're doing here is getting all the groups to share that kind of communication does not happen very much. And so, for example, European trials with US-based trials or North American-based trials, just the sharing of what's happening, seeing where there's overlap, trying to reduce redundancy, that's a huge step.
Yes. I'm happy now to move on to the next session focused on women in GU cancer research. So I'm welcoming my wonderful colleagues. Please come all over here. And the session will be led by Shilpa and Smriti here. Please.
Names, right? So I'll start with introductions. Hello everyone, I would like to thank Dr. Necki for inviting me again this year, and really an honor to be a part of this retreat and be invited to lead this session on women in GU cancer research with my co-chair Dr. Smriti Patodia from London, UK. She works with she's a senior editor with Lancet Oncology. I'm a GU medical oncologist at the Cleveland Clinic. We'll start with quick introductions and then start discussing the burning issues that women are facing in today's world.
Hi. Thank you, Dr. Gupta. My name is Smriti Patodia. Thanks for introducing me, and thank you, Dr. Necki, for inviting me. This is a very exciting meeting. Really nice to see all the friendships and the collaboration, and really grateful to be here. I work for the Lancet Oncology as a senior editor, so if you have any questions about publishing in oncology, then please feel free to catch me at any time during the meeting. Thank you, and I'll pass on for the introduction.
So maybe, as you maybe already understood in the past 2 hours, my name is Chiara Mercinelli. I'm a medical oncologist here in San Raffaele Hospital.
Valentina Tateo, I'm a medical oncologist here in San Raffaele Hospital.
Martina Sollini, nuclear medicine physician here at San Raffaele.
Sara Scagliarini, medical oncologist from Cardarelli Hospital, Naples.
Patrizia Giannatempo, based on Istituto Nazionale dei Tumori here in Milan.
Good evening again, I'm Brigida Majorano, medical oncologist from San Raffaele.
So we have to cover a lot, but we'll keep it very brief. So, we get moving with the program. I'll first start by, the Lancet Commission on the Women, Power and Cancer as to what the overarching goals are and what progress we've made. We don't want to talk about all the doom and gloom that women face in the GU research because there's a lot of progress and opportunities now available. So, Smriti, why don't you give us an overview?
Thank you, Shilpa. I know you said there's a lot of progress, but I'll start with the doom and gloom just for the start. So the Lancet Commission on Women, Power and Cancer was launched because, yes, we've made big strides, but there's still a lot that needs to be done. So, as I'm sure this is no news, but women dying prematurely from cancer still is one of the biggest causes of women's premature deaths. And it's striking that in lower and middle income countries, it causes nearly 72% of this premature mortality compared to 36% in high income countries. So obviously there's a huge gap that needs to be bridged. Also, the Commission highlighted that there is, regardless of the socioeconomic or demographic status, women are more likely to be less aware of the treatments available and less likely to access them. So these are all problems that, yes, we are getting better at dealing with them and solving them, but there's still problems that remain. And also, people in power make decisions about what projects are funded, what research is funded, and what becomes policy. And again, we need more women in leadership positions to make those decisions. So yes, lots of progress, but lots of gaps. And this commission, I encourage you to have a look when you can. It's really eye-opening in terms of highlighting the challenges that remain. So with that, I'd like to pass it back to Dr. Gupta. You work in the women in cancer workforce, so I'd love to hear your thoughts about how you feel, how things have changed over the last few decades, and what challenges remain. And then we'd love to hear from our panelists as well.
Yeah, I think, we all know that women are underrepresented in the workforce. I think in the US, last I checked, was about 30% women medical oncologists in GU, and I think about less than 20% in surgery, but the numbers are increasing every year. And per the ESMO update, it's about 47% women oncologists in Europe. So it's higher in Europe than the US. And of course, there's a lot of challenges, and I think getting into the talking about mentorship, and no clear example than our male colleagues here, Dr. Neki, Dr. Sumanta Pal, Dr. Agarwal, Dr. Kamat, Dr. Spies, they're all, sponsoring, even if you're not directly working with them at that institution. Like, I've personally had opportunities from all of them through their sponsorship and mentorship. So I would love to hear what have your experiences been. I know you're all in Italy and you work together, and would love to hear what's.
Yeah, that's a critical point. I think in Italy we miss a lot of time the figure of mentor, and because it's difficult culture. I think nowadays stuff are changing, and of course we have a huge gap in terms of woman as mentor. I grew up with Andrea, and he was my young mentor, even if we passed just 3 years. And but in the meantime, in our hospital, there is, only one woman was a strong mentor, and sometimes even the woman mentor in Italy, I don't know how it is in the other country, think about to be a man. So all the problem that we can pass according, for example, pregnancy, maternity leave, breastfeeding, all this period is not completely understand when you don't have passed all this stuff, and there is not really empathetic behavior as a mentor. So yes, I think in Italy we have a discussion before with Sumanta Pal. We need to improve how to be a mentor, in general, and of course, as a woman.
If I can add a comment, I fully agree with Patrizia. In Italy, we have no law dedicated to the possibility to include the woman, no specific law. For example, some of you are mothers. There is no specific law, for example, for maternity compared to paternity. So there is still a social prejudice that there is no possibility for a woman to be a mother and to follow also a proper career, especially in the academic field. In Italy, we are no low or middle income country, but still only 10 to 12% of academic positions or leading position in the hospital are held by women. So this is an important social, I think, social gap that we still have even here in Italy.
Yes, I'm a mother, and so I perfectly know this situation. In Italy, paternity leave is just 10 days. So, if you are a man, you don't have to choose between your career or your family, because the majority of the charge is on the woman. And a mother, the maternity leave is of several months. So when you return to work, you have to start again every time. And so I think this is really important, and it is important to protect the career of a woman that decide to be an oncologist, a neurologist, but also a mother. I think it's important to give the possibility to choose both things, because it's possible to do both things, but it's important to have a context that allows this.
Valentina, can I ask you a question on that? Because some of the people in other countries get very little leave and they would love to get more maternity leave. So what solution do you think could be so the woman, even though she may be on, and I think in the UK is 1 year, right, sweetie?
It's
10
6 months.
Okay.
6 months of paid leave.
Yes.
So what would you think is a good solution to this?
I'm in favor of a long period of maternity leave for a woman. Personally, I stay at home for 10 months with my child, but I think it's important to give the freedom to a woman to choose, and also to give to the father more time for the paternity leave, because in some countries the paternity and the maternity leave is shared between the two parents, and the two parents can choose how many time to stay at home. For example, if my husband could stay at home for some months, probably I could choose to return to work sooner. Before.
You could split
so
the time.
It's important to give this freedom, and because the problem is that if a man is outside of work just for 10 days and a woman for months, it's obviously that a center decides to invest more in a man than in a woman. And so also the problem of disappear from the scientific scene, from work, it's completely different.
Patricia, do you want to share what, like, you're a clinical trialist, PI of important trials, like, do those suffer when you go on the maternity leave from your experience?
Oh, sure, absolutely, yeah. I have 3 kids. For the last, my pregnancy, I was in maternity leave, and in Italy it was not allowed to still a PI of the study if you are in maternity leave, so we changed the PI, and I lose the name in a huge publication, even we were the top accrual worldwide. So I think we're still young, and we have the opportunity to be not only in Italy, but in a country in Europe. There is a lot of country where women have these problems in terms of recognition. I think we have the power now to be a part of the world, to be a part of ESMO Association, to be a part, to stay here with the USA colleague. So they recognize to be well known abroad sometime give us some effect, not only for us in our countries, but even for all the other women. So that's why I think as a woman, as a young woman with kids, but even without kids, it's not that that's the only problem. We need to learn how to be a good mentor from country where mentorship is something standardized in the academic pathway of the medical doctors.
What you mentioned is important and interesting, and also if there are any other example is intriguing. But the decision to achieve, for example, the PI leadership of a certain study has been made by which? By the sponsor, by the local.
No, in Italy,
if you
it's
can
not,
say that.
Sure, in Italy, it's not allowed. It's not allowed if you're not there in the hospital, but because you are at home with kids, to be a PI of the trial. So you have to change.
Go back.
Theoretically, you should change again. Change the name again, back, or otherwise there is a common well behavior where, okay, I'm still the PI, I don't want to do all the stuff or the bureaucracy, but you can stay there on the name, on the paper. So theoretically it's like
basically
that.
It's
it
a matter,
depends.
it's a decision that it is in charge of the.
It depends on the team.
In charge of your department, you know. Let's say, more politically correct, internal communication, you know, within your center, right?
I think it's a priority of the team. It depends on the priority internal the team to give some, good feedback to someone that worked there for 10 years, so instead stay, out of the work for kids for 3 months, or
do you think that establishing, for example, formal requests of this kind, so for example, having back a leadership position that you had before, and et cetera, so publishing kind of guidelines, a recommendation, let's say, of common sense, good sense practice, you know, I cannot say what you call it, may be useful for having a paper in your hands and saying, okay, guys, we should do something more politically correct and more scientifically correct, and so do you think that moving this way, so with the paperwork of this kind, with pointing to special requests, pointed to special situation like this one, as an example of many, would be useful to improve, maybe, or to overcome certain concerning situation, you know?
Absolutely, I think it's.
I'm not. Maybe I'm biased, but I'm not aware of any publication of this kind.
No, there is a publication about how many PI women published in GU cancer and how many PI of published trial of men. So there is a gap, there is a big discrepancy. There is not, the reason behind these numbers. No, not really. On maternity leave, yeah, it could be.
So Andrea, to your point, if somebody is away, obviously you need a PI on site for oversight of the study, but you are saying there could be a good faith agreement that when this PI returns, would get the authorship, so that would be within the institution, right? Sponsored doesn't have, yeah.
May I ask you this question? How about competition when you have an husband doing the same work you do? Can you comment on this?
Sorry?
Competition with your husband when your husband is a doctor or is a professor, you do the same thing. What happens in family?
Yeah, that's a difficult question.
Would be
do you all have any experiences?
Nothing. There's no competition.
Not happen?
Not happen.
I cannot believe it. I know.
We are both
I know in
doctors.
some families it is like this.
Yes,
and everybody can do the same things and.
No competition.
Not at all.
No, not at all. Not in my family.
At least if you want to survive.
No, I do think Andrea brings up a thoughtful comment there, and I think I would elevate that maybe that's an opportunity for a consensus statement type article to be generated from societies, stating proper etiquette on how this is handled. I very much agree. Much like someone is away, they're sick, someone becomes the interim PI, and then when the person comes back, they automatically reassume that PI role, and we do that for each other when we're not well or for away, and I think that this is just a natural transition. But it takes a position for societies, particularly larger global societies, ASCO, ESMO, all of these type of things, to sort of put on paper that there's a consensus on how this is handled, and I think this is an opportunity to do so through these types of conversations.
And I think it's the same, yeah.
Otherwise, there are quite a lot of discussion on this kind, not very much.
But no action.
Everything is lost. You have to be precise with something that may remain on time on the paper.
Yeah, so again, apropos to this point, and I think Shilpa and I have talked about this, so this is something that's near and dear to my heart. I've been a mentor for women in surgery in the US since 2002. And recently, we've actually launched a global initiative. So we've had an effort in Santiago. Marcela Castillo is the dean of the medical school there. So through the Invoke Potential, and I put that on the chat, we actually had a workshop there. We've had one in Houston. We were doing one in Scotland, exactly along these lines. And the action items are essentially things such as these: maternity leave, PI-ship on clinical trials, authorship. So this is something that's an ongoing effort, and I think it'd be great to kind of join forces, right? I put the link on the chat if anybody's interested, but these are things that it's a problem everywhere. It's a problem in the US, it's a problem in South America, and people are recognizing it. The thing to recognize is, like you said, it's not doom and gloom, right? So in the corporate world, there's a lot of recognition of the challenges that women face in things such as maternity leave, et cetera, et cetera. In healthcare, it's lacking. So the initiative that we are sort of working on is taking corporate strategies and putting them into the healthcare field, because it's not that women are not leading in other areas. It seems to be particularly lacking in leadership in healthcare. If you look at the flow chart, in the US at least, 49% of the entering class is women. Only 7% of the leadership class is women. Something's happening somewhere.
Do you think that it's something that is shared among specialties, or do you think that there are particular specialties like oncology rather than surgery, or urology, or nuclear medicine? So do you think that there is a kind of disconnection between specialties, or it's a shared problem? Because this is another important point to make, and the focus to make in your statements.
Well, by now in Italy at least, the majority of students at med school are women, more than a half. But at the end, we choose all the same jobs, because there are some female jobs and some other, like the surgeries, which are not for women. Because when you have to go to the operating room, of course, it's a physical impairment, let's say, having being maternity. So I think, yeah, there's a lot of disparity still across the different residency. There's another point which is common to all of them, that is the research point. I'm a young woman, I'm not a mother. I'm trying to be a researcher. I started my PhD. As regards Italian law, if I decide to have a child, I'm not paid at all for all the months I'm home. So basically, when you want to do research, at the beginning of those 3 years, you need to make a choice. Or if you have a man by your side who can economically support you, maybe you can do both look both for research and family. But you have not. Basically, if you want a family, you decide not to start an academic career in some cases.
Neeraj, do you have a comment?
Yeah, I think Phil partly addressed my comment on the PI-ship. Like you have to give up your PI-ship on a trial or a project if you become pregnant. I mean, this is absolutely appalling. How can you are a young investigator, you are trying to build up your career, and you have to give the PI-ship. So you can solve it at the institution level. Just allow a sub-investigator to take on the PI responsibility on a temporary basis. So why it is not happening? I'm just curious. No, I'm just curious why it is not happening. I mean, it's not a national rule. You don't have to change anything at the national level. This should be an institution thing.
Yeah. No, I think first of all is the company, so the supporters that normally ask us to replace the PI in case of maternity leave.
I don't think it's a rule by pharma. I wanted to clarify, we have never seen that happening in the US. And there are female PIs, women PIs who are leading the trial. They go on leave, they come back, as Phil said, people get sick, people have accident. We don't tell them to change the PI-ship to somebody else. So I think I'm pretty sure it's not pharma.
I think, Neeraj, what you are saying is when somebody is away for prolonged leave, you just designate a sub-I to take over the day-to-day responsibilities.
Yes.
But pharma companies don't really ask that, right? So
they are not supposed to ask. They cannot.
Yeah.
So I'm pretty sure this can be solved very quickly.
At the leadership of institutional department level.
I want to take my story. I come from Italy, so Naples. Thank you, Andrea Necchi, for this invitation and for this great session. My story is different because at the beginning of my residency, I have my child that is now 14, but I think that it's not too late. Because now I have the second chance like this, and now I am PI of important clinical trials in my hospital, general hospital, not research hospital in Naples, so I can give to my patient very innovative drugs, and so I'm really happy. But about gender gap, I think that it is really important that we have oncologists and urologists, because we know that we have many women with urothelial cancer, for example, and in this moment urothelial cancer have a worse overall survival because we have also few urologists, I think, and only used to have visits with gynecologists, not urologists for women. So we have to we have a gap, family gap also for our patients. We need empathy for women. I don't like percentage. I want only what I deserve, in my opinion, not percentage, but what I deserve. And in this case, I think that all of us deserve many things.
Thank you. That was really, so some action items can emerge from this, which is good.
Sorry. I'd like to ask the panelists, anyone, please feel free to answer. So as women who are obviously empowered and you have the voice and the platform to spread this message, how would you comment on building stronger networks and bringing more women in? Sorry, Dr. Ashish and Dr. Philippe, you commented on spreading awareness, so educational resources, because I feel like that's something that's lacking. A lot of people don't have access to this information. I mean, it's nice for people who can attend these meetings and who have access to papers and journals, but a vast majority of women wouldn't have access to that knowledge, so they wouldn't know how to even sort of access the system or gain treatment access. So just if you have any thoughts about how to make this more accessible, more widely accessible. Yes, and the knowledge, well.
Yeah, I think first of all we should, of course, there is a lot of groups, in national and international groups, that try to build a collaboration between women. But I think it's important that collaboration or support each other. I think we need to include, of course, men in this process because we are all together. And I think we need another step. Because as a woman, I understand I'm now 43 years, I'm completely different to compare when I was 23 or when I had my first kid. And I think we have to change our mentality. I do a lot of work on myself, and I think we need to think that we have to make free from all the obligation the society give us as mother, as wife, as daughter, and all the society want to us to be perfect in each section of our life. So I think we need to understand that we are similar to the men in this stuff, so we can do what we want, we can empower ourselves first. So I really miss mentor as woman. I had a young mentor as Andrea Necchi, but I miss a woman mentor. And I understand that a mentor for person as me that will miss a mentor should be myself in 10 years' time. So what I want to be in 10 years' time. So I think women, but even men, should do a lot of work on their self to overcome the resistance that we can approach in the real world, in our job, and to convince all the society and all the young colleagues they can do what they want. They could be a good mother, they could be a good researcher. Just don't be what you want, don't be influenced by outside.
Thing, you know, we have, like in the US, we have the ASCO Leadership Development Program, which Monty here chairs, and I think around 16 people get selected each year, right? I'm sure there's something with ESMO here, but what about the rest of the world? Like, how do we get these available there? Like, make more online, globally? Would love to hear, you know, Monty, your perspectives as a leader in this field, and do you think there's bandwidth to expand that leadership coaching to other countries virtually, like what ASCO does with LDP? For those countries, the countries which don't have such programs?
You know, I think, like, realistically, you know, I think mentoring, when it's done in its best form and in its, like, purest form, is really, really time intensive. And I'm not sure that some of these virtual platforms lend themselves very well to mentoring. I think that, you know, for instance, you know, the best mentoring is at the same institution. It can maybe be done within, you know, the same time zones, but I find mentoring at a distance to be incredibly, incredibly tough. That's my personal perspective. I'd like to, you know, take a more optimistic stance, but.
Can I also just add, I did an 8-week program at my institution on, it's called Advocates in Action, and it was focused on not mentorship, but allyship, which is a very different concept, right? It's often somebody who's in a position of power or privilege that can help change inequity, but isn't necessarily a mentor. It can also be a mentor, but not necessarily. And so and there was a book that we read for this called Good Guys. And so it was directed mostly at guys. But I would say that guys can do that work too, because it's not just a matter perhaps of mentorship, super important, but it's also a matter of systematically changing the system, right? And the concept of allyship, I mean, I learned a lot about it when I did this course, and I would encourage men here to try and seek that sort of teaching out as well.
So again, full disclosure, I've taken a course at Rice University, so I'm a certified coach, right? So a lot of what I'm talking is lingo that I learned during that. But one of the things that is really important is not just mentorship, but you also need sponsors and coaches, right? Because a mentor is someone that's gonna like help you and tell you what to do, A sponsor is someone who's going to think about you when they're not in the room with you and then find opportunities, but you need a coach as well, right? Because you may think you want to do 100 clinical trials, but that may not be what you want to do. And it's true for men. It's not just for women, men and women as well. And when it comes to mentorship, we actually have a program where you can match people with mentors internationally, nationally, regionally as well, right? So there'll be a medical student that will want to come and be mentored by you, and they could go to these little portals and get matched. Someone here may listen to this and say, oh, I want to be matched with Smriti. They can then go to this central portal, and then we'll put out a request, of course, and you can say yes or no. But that sort of matching that comes both from the mentee and sometimes the mentor is very important. I think the virtual world does work. You need to have one-on-one as well. But you know, there could be a young medical student in Santiago that wants to learn from you. She can't fly to LA, right? So this virtual thing is, I think, something that allows you, I mean, you guys are great mentors too. So you could be part of this mentor panel and also mentor others as well. So you should consider that.
So you're saying to create such a network?
Yes, I mean, we can partner, right? Like I said, these things exist.
You already have the
absolutely.
resources, so okay. So I think in the interest of time, we will wrap with asking, you know, all you women, like, what is the one thing you think the action can be taken? Because, you know, we can talk all day long, but without an idea to bring it into solving the problem, to solve these problems in your world or, you know, on a bigger picture in the next 12 months.
Okay, now maybe it's not practical in the next 12 months, but I was thinking about starting from education from high school, both on male and women, teaching them that there's no difference in the end.
I agree. In the long period, we have to break down social heritage because we want to be recognized. Besides to be women, we are very proud to be women, but we want also to be recognized as scientists, clinicians, mentors, and even clinician mothers, clinician sisters. So we want to be recognized for our role and not only for our sex. Or we want not to be only the pink quote of a group. We want to be the quote.
I really love this idea to have a course for coaching and create a mentor in Italy, even in Italy, in a young or not young woman. I mean, one that want to find their place in GU oncology. So I will try to be pragmatic and to concretize this idea even in Italy.
I agree with you, but yes, I'm happy to be here. I think that day like this is really inspiring for me, and I can bring in my hospital, in my reality, more energy, and I am a chief of group in my hospital, and it's enough for now, but I have to do more, but my time by time, I think that we have the possibility to have our space without a fight. Mentorship is really important, but only also coach. We are very strong. I think that we can do everything together. It's really important together because alone you can go, I think, fast, but together far, I think.
Yeah.
I fully agree. I think that is not a problem of gender, but a problem of expertise. So if the expertise is here, is there, we should go together, men and women, to try to perform better our practice, our work, to improve our practice for the patient. So it's not a problem of gender, I think. It's a problem of expertise. And again, if, as mentioned by Brigida, the point is not the pink or the blue quote is to be together and to be the quote.
Something concrete that we can do is education, starting from our children, for example, how I educate my child on equity, gender equity, and also patients, because GU tumors are prevalent in male, and male patients are the preferred male doctors, and we have to educate also our patients that we have expertise, we are doctors exactly as our male colleagues, and so this is really important. So starting also from our patients in order to have a population that is not searching for a male doctor, but just for a doctor.
Sure. Do you want to share what
Yes,
you are? Do you have any closing
No.
comments, Smriti?
No, great session. Thank you everyone for your participation.
Thank you,
and thank
Andrea,
you to
for the
your audience for
opportunity.
listening.
Now let's open up the door to the testis cancer session. Valentina. And we will have Sia joining virtually on Zoom call. Please, Valentina.
Okay. So, I'm really honored to be here today with you, with the panel of experts that will join us after my presentation. Today I will present a case of advanced testicular cancer, highlighting the multidisciplinary management and the key points, the key decision point in the management of this patient. Our patient is a 26 years old white European man. He's an active smoker. He has not comorbidities, no family history of cancer, and a normal genitourinary development. He presented to the emergency department with acute testicular pain, and testicular ultrasound revealed a subtorsion of the left testicle with abnormal parenchyma of the testis, suggestive for malignancy. The markers, preoperative markers, were positive, included alpha-fetoproteins, so suggesting for a non-seminoma diagnosis. So the patient underwent left radical orchiectomy. The pathology show a presence of a mixed germ cell tumor with a prevalence of embryonal carcinoma, 80%, a 10% of seminoma, and a 10% of postpubertal teratoma. The pathological stage was a PT3 for infiltration of the spermatic cord, and vascular invasion and necrosis were present. These are the images of the pathology, and then we will ask to Professor Colecchia to comment these images. And at the stage in computer tomography scan, extensive metastatic disease was observed, in particular at the lungs, with multiple pseudonodular lesion up to 90 millimeters, infiltration of left bronchial branches, mediastinal pleura, and the pericardium. Also, lymphadenopathies at the mediastinus were present, and multiple lymphadenopathies in the retroperitoneum, in particular the largest mass of 35 millimeters in para-aortic left, inseparable from the psoas muscle. Other additional adenopathy was present caudal to aortic bifurcation, and also a pathologic tissue in the retrocrural tissue, in the retrocrural area. The pre-chemotherapy markers, post-surgical markers, show a normalization of alpha-fetoprotein and ACG, but LDH were still elevated. According to the AGCC classification, the clinical stage of the patient was stage 3B, and according to the IGCC prognostic classification, the patient has an intermediate prognosis disease. So the estimated survival is 5-year progression-free survival of 78% and 5-year overall survival of 89%. Using the online calculator provided by the most recent IGCCG update on non-seminoma, the individual 3-year progression-free survival of our patient is of 88%. Then the choice of first-line chemotherapy. So we have a non-seminoma, a stage 3, an intermediate risk, and we have contraindication against bleomycin because our patients had dyspnea due to the extensive pulmonary involvement. So according to clinical guidelines, the first choice for this patient is BIP for 4 cycle, but for the contraindication to bleomycin, our patient received 4 cycles of VIP. The treatment was good tolerated with rapid resolution of the dyspnea, and the post-chemotherapy markers were negative. This is the radiographic response assessment after the 4th cycle of VIP. As you can see, there is an important reduction of the disease. The retroperitoneal disease from 35 millimeters, the largest mass in para-aortic, reduced to 25 millimeters. There is an excellent response also in the lung lesions, but we have residual masses. So given the residual masses, we decide to suggest to the patient to undergo surgery on residual disease. So the first step was retroperitoneal lymph node dissection. Our patient received robotic-assisted laparoscopic unilateral retroperitoneal lymph node dissection with the resection of periaortic and intra-aortic lymph nodes, and the pathology report show no evidence of residual viable tumor. And then the patients post-operative have a complication with chylous effusion that was... what happened? I can't... I see here my presentation. Okay. Oh no, spoiler. Okay, so the pathology report show no evidence of residual viable tumor with necrosis, fibrosis, and sign of treatment-related changes. Then the patient has the complication with chylous effusion that was managed with lymphatic embolization and the need of total parenteral nutrition, but then the patient fully recovered. Then the problem of the residual lung masses. We know that there is approximately a 30% of risk of discordance between the retroperitoneal and the thorax. So we suggest to our patient to also undergo surgery on the lung, starting from one lung and considering the high concordance between the lungs, decide to undergo to the second lung only in case of positive histology. The first intervention was conducted on the right lung through video-assisted thoracoscopy with resection of C nodules from the right lung. 5 nodules were positive for necrosis, but 1 nodule was positive for postpubertal teratoma at the level of the middle lobe of the lung. So we suggested to our patient to undergo also metastasectomy of the other lungs. So in a second moment, the patient underwent left resection of the left metastasis with resection of 3 nodules from the left lung and also lymph node dissection of the suspicious nodes. Of the 3 nodules of the lung, 1 was positive for was necrotic, and 2 were positive for postpubertal type teratoma at the level of the lingula and the culmen of the left lung. Lymph nodes were negative. These are the histology of the lung. You can see necrosis and also teratoma. And this is the most recent follow-up at 1 year from the end of chemotherapy. And as you can see, we have only scar from surgery, so our patient is free from disease in this moment. So can we consider him cured? And in case of recurrence, what could be done for this patient? Conventional dose chemotherapy, high dose chemotherapy, trials, surgery, and we have to consider the different patterns of recurrence: early recurrence, late recurrence, single-site recurrence, systemic recurrence, positive or negative serum markers. So I would like to hear the opinion of our panel of experts on this clinical case, and I would love to also hear the answer to this last question. Please, panel of experts, you are welcome on the stage.
Please come. Maurizio, we have Valentina, Brigida. Brigida, don't be shy.
Patrizia, già da tempo. Phyllis Spies.
Patrizia.
And Professor Necchi.
Are you cold?
Yes, of course.
Why did you decide for surgery? The nose were less than 3 centimeters. When the nose is different, it's less than 3 centimeters, the probability of having cancer is very low, maybe 0.
Well, in non-seminoma guidelines suggest to perform surgery if the residual mass is more than 1 centimeter, because in 50% of cases is necrosis, but in 40% of cases is teratoma, and in 10% there is also viable cell tumors. So, we find nothing in the retroperitoneal, but in the lungs, yes.
I think that maybe the case of Sia first is the connected virtually
Yes, yes.
for him to follow, and then we'll jump into the panel, you know. So if you are able to start the connection with Sia. Okay, Sia, we are seeing you in good shape. Hi, Sia.
Thank you. First of all, for the invitation. Andrea, I can't hear you very well, but I can hear Valentina very well. I presume you asked for some comments on this case. First of all, thank you so much for the invitation. I'm very sorry to not be there in person. I would have very, very much liked to have been there, but some unforeseen circumstances didn't allow me to come. In any case, a great case. I was thinking we would have managed it exactly the same way. So the question now is about recurrence and how would that be managed. I think you brought up very good points about what the recurrence is, especially the timing. We certainly know that most of the relapses happen very early in intermediate and poor risk disease. So it's really good to see the patients out already 1 year NED. So if we happen to have a relapse at this point, or more than 2 years out, it would sort of be considered a late relapse. And if the markers are negative, having had teratoma in the chest, the prediction would be that the patient would relapse with more teratoma. So if the markers are negative, we would certainly consider further surgery for removal of the residual teratoma. If the markers are positive and rapidly rising, there's certainly a chance for residual viable germ cell tumor, and the consideration would be for high-dose chemo with autologous stem cell transplantation, in this case at our center, especially since the patient already had VIP, I believe, in the beginning. So, as you said, I think these are individual decision-making based on tumor markers, based on location also of the relapse, whether it's surgically resectable or not, and sort of a multidisciplinary approach to management. I'll stop there so I don't take over the whole time.
Is there any interesting to me, in order to be kind of educational also, is there any cutoff for the tumor markers in order to say, okay, this case is more suited for a surgical salvage approach instead of systemic therapy? For example, a typical situation, I don't remember the alpha fetoprotein level baseline.
At the baseline is slightly elevated.
Yes,
negative after
that's
surgery.
good. That's good. And would you mind having, for example, a borderline positive alpha fetoprotein level post surgery? Would you consider a disease relapse having borderline values, slightly elevated values of alpha fetoprotein alone with a negative CT scan? Would you consider? Would you be scared about having a patient relapsing, or it's just something simply not to consider? Valentina.
Okay. Sometimes we could have markers that remain slightly elevated, but we have also to consider other situations with normal elevation of serum marker. For example, alpha fetoprotein could be elevated in some conditions, also not pathological, also beta KCZ the same, and the other problem is LDH that could be elevated with several other benign conditions. So it's really important to consider the markers also in the whole clinical scenario.
Phil, how many times do you see patients that are very much concerned about having alpha fetoprotein, which is slightly increasing, but without any sign of disease, you know? Would you reassure this kind of situation the patient?
Yeah, see, it's great to see you. In terms of that scenario, I think that's actually a scenario we see fairly frequently, to your point, Andrea, is you do definitely see those patients whose alpha fetoproteins are not quite normal. They're a little slightly high, but you're not too nervous about it. And those are obviously the patients where it makes sense to clinically just survey them very diligently and just see what that alpha fetoprotein is going to do. You know, to the point that's brought up, and Sia, I think I agree with all the points he brought up. I also tell the urologist, always never forget the contralateral testicle. This is not obviously a seminoma, but it's always something, I'm always amazed to see referrals that I get. No one's actually examined the patient, and you find a small testicular mass on the contralateral side. So just a good teaching point for the trainees as well.
And going back to the previous question, is there any cutoff for in second-line salvage setting? Is there any cutoff for serum tumor marker SIA that would you consider for a certain patient just to exclude this patient for an upfront surgical approach? Let's say, for example, an isolated lung met or an isolated retroperitoneal relapse, in-field relapse, let's say, with a slightly improved, increased alpha fetoprotein or HCG. Let HCG, for example, 150, 100. Would you consider surgical approach up front, or would you say, okay, this patient have to undergo a high-dose chemotherapy or TIP chemotherapy prior to be reconsidered for surgery? What is your general approach?
Yeah, I think I understood the question to be slightly elevated markers with a retroperitoneal relapse. Is that correct? Sorry, I didn't hear very well.
An isolated relapse is, and based on this, what is actually the cutoff for serum tumor marker level, just to consider the patient still suited for surgical approach up front?
Right. So yeah, that's a great question, because we don't want to get to the end of the line too quickly. You know, once you failed high-dose chemo stem cell transplant, I think you have very limited options left. So as much as we can, we try to manage the disease surgically, provided the tumor markers are reasonable. So if you do have an isolated recurrence with low-level markers, I would consider the patient for additional surgical resection at that time. One thing to do with occasionally when we see an isolated recurrence is do a short interval scan to make sure the patient is not on that cusp of developing multi-site metastatic disease. So if I see something, maybe I'll repeat the scan in about 6 weeks prior to considering surgical therapy and making sure the tumor markers are not rising exponentially. So, you know, we don't have real cutoff levels, but I start to get uncomfortable when the beta-HCG reaches 100 or is rapidly rising. And same thing with AFP. But low-level markers, I think, are reasonable. Very rarely you do have teratomas producing some low-level markers and some very small viable germ cell tumors. So if it's surgically resectable, if it's not too morbid an operation, certainly would consider it.
Yeah. Nowadays, it's important also the possibility when the biomarkers are not so clearly found, the possibility to have microRNA R371 that sometimes is an early event in recurrences. This is not so diffuse tool in our lab, but there are many experiences now in large series that also in non-seminoma, otherwise than teratoma, we have the high levels of this microRNA. In teratoma, the negativity of these microRNA is also important because it's the chance to avoid the surgery. So it is promising for the future because the concordance among laboratories is not so high. But I think that is the real biomarkers of the future.
And I think the point that Sia brought up about that short surveillance is something to emphasize. As you mentioned, you know, waiting 6 weeks will really allow you to see, if you see progression of the size of the mass, but also if you see that rise and you see rapid kinetics of that marker, you clearly know this is likely systemic disease, and obviously you can obviate doing a surgery, which is obviously going to be a very little curative potential if the patient is rapidly progressing, literally over a couple of weeks.
And I have another question for the panel. And what about ctDNA? Recently was published a work on ctDNA in germ cell tumors. Could be useful ctDNA in the context of early detection of recurrence.
Yeah, I can make a comment. I think it's early in the investigation of ctDNA. We have started doing ctDNA in select cases, and there's the series from Indiana that shows it can be helpful. The question is whether, you know, in the future we'll be using microRNA 371 versus ctDNA. So it's early. I think there are a number of institutions here who are investigating its utility in this setting. But I've already seen some early results which are very interesting.
But maybe I miss something. But in case with rising clearly elevated markers, you know, what do you think could be the added value of microRNA or ctDNA? Do you think that they had anything with to this patient?
No,
in the decision making?
Absolutely not. Not in this case. The ctDNA, of course, is too early, but not in this case if we have an increase of markers.
Maybe if negative markers, maybe.
Exactly. We can have patients that have negative markers that will help us, but not yet. I mean, it's the first study with ctDNA. And to be honest, I think in this case, and in general, in germ cell tumor, the time is important. Don't be rushed to take a decision. Sometimes just time give you the right answer in this specific patient.
Yeah, I think I agree with you and the C and the rest of the comments. You know, yeah, I think that the kinetics of markers and the kinetics of the disease that you may assess with the CT scan is the key for the decision making. You know, just starting a TICE program is just complicated for the patient, for us, for the logistics of a certain hospital. So you are offering something that is deeply impacting the patient, quite toxic, a lot of admission to the hospital. So a quite complicated path for the patient. So the goal is still the cure, so everything is pretty much justified, you know, but the program is very heavy, you know. So waiting a little bit may be fully justified. I agree.
Can I ask if the age could have had an impact in your decision process? Of course, we know this is a tumor which is typical of young people, but in oncology we are discussing so much in some cases the impact of age. Would you mind, for example, you have acted differently with another patient in such a case?
Yeah, that's a very key question. I mean, we know that age is incorporated now in the ECGG score update, and we should publish, and we have presented several Congress that patient elderly, that we define elderly more than 45 years old, they have worst outcome when we compare between all the categories, because you treat not so good this kind of patient due to the toxicity. So sometimes, of course, 45 patient is not different from patient at 40, but patient in this case with 55, 70 years old, of course, if you can, you go through, try to avoid as much as possible second-line chemotherapy.
I have another question for the surgeons, Sia and Philip. Given the higher risk of recurrence in a patient with metastatic cancer, of not recurrence of a second testicular cancer, if our patients during the follow-up develop another small testicular cancer in the other testes, is an option for you testis sparing surgery or just radical surgery in order to preserve testosterone production?
Yeah, obviously Sia probably has some comments on this as well. I think we definitely do a lot of testis sparing at our institution. I'm a big believer in it, and obviously in the right clinical setting, it needs to make sense in the setting that the mass is small, typically 2 centimeters or less, that you feel it's a lesion, that you can preserve a significant component of the testicle. So MRIs are very, very good for assessing that. Obviously, standard principles, early inguinal control, controlling it, assessing the rest of the testicle, make sure you don't have multifocal disease in those patients. But if you do so, I think huge advantage to the patient. We're strong believers in testis sparing.
Okay, in case of testis sparing surgery, will you offer to the patients also radiation therapy on the testis or not?
Only if we see intradermal cell neoplasia would we radiate the rest of the testicle. If we did not, we would not radiate the rest of it. Sia, what's your thoughts?
Yeah, thanks, Phil. I think I heard most of your responses, and I'm sure I agree with you 100%. So, yeah, as Phil mentioned, we certainly would consider testis-sparing surgery in that patient. It all depends on the size of the lesion, the polarity. If it's in the middle of the testis, it's a little bit more difficult to do a partial orchiectomy. But most importantly, I think we have to assess the spermatogenesis in that testicle. So if the patient's already banked sperm or has oligospermia and has elevated LH and FSH with a low testosterone, we can explain to the patient that really this testicle is not functioning very well, and after a partial orchiectomy, it certainly will have further decline in both spermatogenesis as well as testosterone production. So it's always a case-by-case basis. If it's a small mass, certainly consider it for both hormonal function and sperm function, as well as psychological issues. But you have to take into account that that testicle is always at risk of local recurrence, and have to have multiple follow-up scrotal ultrasounds to monitor that testicle, as sometimes it becomes difficult to do physical examinations following a partial orchiectomy. So case by case, I don't do many of them. The incidence is fairly low, in the 2 to 3% range. Most of the time, by the time we found it, there's either hypogonadism already present, and we end up doing radicals. So, yeah, that's.
Patrizia, would you consider, which kind of second-line therapy would you consider? I'm sure that you know already in advance kind of information from the Tiger study. I will not ask you this, but anyway, would you be happy to consider high-dose chemotherapy for all comers, or are you still privileging somehow standard dose chemo? What is your decision-making point to address high-dose chemotherapy to a certain patient?
I mean, in this specific patient, he had VIP as first line, and so we know that VIP, TIP is not so different. Of course, it depends on time, as Valentina said. If the patient relapses after 1 or 2 years in metastatic way, I mean, not resectable way, and we need to give some chemotherapy, we consider TIP or PE that we did here in Milan. In case we have relapse quite close, I mean, within the first year, I should go ahead with high-dose chemotherapy just because he received VIP instead of PAB. Otherwise, I prefer TIP.
And with high-dose chemotherapy, do you mean necessarily TICE chemotherapy, or would you still consider the tandem Indiana regimen?
You know, after Tiger study, we are used to use the Tiger regime, so we go ahead.
So the TICE chemotherapy, so the triple course of high-dose chemotherapy.
Yeah.
And would you consider? I was really impressed by the Indiana results with regards to the maintenance etoposide after high-dose chemotherapy. Would you consider maintenance etoposide in these patients?
Yeah, to be honest, I think it's considered very high-risk patient where it's not possible surgery after high-dose chemotherapy. You know, we have positive markers. Okay, sorry. So. Maintenance etoposide, normally we do not prescribe after high-dose chemotherapy, except in very high-risk patient that is not suitable for surgery after high dose, or we still have positive biomarkers, positive markers slightly decrease. You know, sometimes you have mediastinal primary tumor that, you know, is just time. But normally, no. Normally, we don't use maintenance. And I really like the Indiana scheme with induction. So there is some publication about just go ahead straight away to high-dose chemotherapy. But in our center, the high-dose chemotherapy is performed by hematologists, and they do not consider to go straight away to high dose.
I have another question for the pathologist. How much is important good pathologic report in germ cell tumors to assess the risk of recurrence? Can we have the slides, my slides, to look at the images of pathology?
Good pathological records
yes.
Made
by an expert pathologist.
Good pathological records made by
Maurizio Colecchia, an expert pathologist on germ cell.
But for the primitive tumor is important the semi-quantitative evaluation of the mixed component, in particular the percentage of embryonal carcinoma. In this case, there is a synchronous metastasis, so and there was also PT3 tumor. PT3 tumor is not frequently seen in orchiectomy because the sampling of spermatic cord show the soft tissue involvement of the germ cell tumors. And for this reason, it is high a risk factor for metastasis. Here we know that there were metastases in the lymph nodes, so it is true. But in the primary tumor is important the percentage of embryonal carcinoma and also the presence of other components such as choriocarcinoma or yolk sac. The teratoma in this case is always malignant in postpubertal teratoma, and otherwise the assessment in lymph nodes of necrosis and fibrosis is less important. It's important a percentage of viable tumors, but we don't sample all the all the masses from retro, para-aortic, lymph nodes, because it's too much many times, and it's too much for technical problems. And we have no threshold to see that this is 5%, 10% of viable tumors, and so there is more probability for a recurrence. This is a limit, but in 30 years from Indiana, we have no suggestion or recommendation to sample all the metastases. And what about the recurrences in the or metastases in distant organs? It's the same thing. Generally, they are not so huge, so we sample all the metastases. It's important also the occurrence of viable germ cell tumor. In 30 years, we have no risk factors too sensitive for the follow-up of the patients. That's true. And probably the possibility by microRNA to assess the event of recurrence is the way to follow. But important is the assessment also, for example, in monorchid of small nodules. Small nodules could be also a Leydig or a sex cord tumor. So it's important to be sure that is a second germ cell. And so the intraoperatory exam is also important. I think that so we have summarized.
Yes.
Thank you.
We have to jump to the last session. Thank you very much. Thank you to the panelists. Thank you, Maurizio. Thank you, Sia. Thank you, Sia. Have a great day. Thank you for participating. Thank you so much.
Thank you very much.
So I will now invite Giorgio, Chiara, Brigida, stay here, and Arturo for the last session. Please go here to the panel.
Okay, thank you very much, and it's an honor for me to chair this session together with Chiara, with Brigida, and we have also Andrea, who is going 1 second away. So by the way, this is the trial in progress session, and we start with prostate cancer, and Dr. Mercinelli will now present available trials at our center in the field of prostate cancer. Thank you, Chiara.
So, good evening again to the survivors. I would like to have my slides. However, I'm going to present you the last updates of last year of research activity in San Raffaele Oncology unit as regards prostate cancer. And I'm going to be quick because some of the studies have been already presented before and because you all want to go for the aperitivo. I'm going to present you both. I'm start talking.
But you don't need a slide, so you can...
There was a previous
we are listening to you.
At ESMO, we had a previous episode of no slides and a great presentation, so if you want.
It was wonderful. Well, I'm going to present you our academic sponsored trials and also our scientific production of the last year. So let's start with academic trials, in particular with the study designed by Brigida Majorano that is now active in our center. That is the DRUID study, which is the evaluation of dynamic role of PSA ctDNA on overall survival and radiographic progression-free survival in patients with metastatic hormone-sensitive prostate cancer. This is a prospective, observational, multi-center study, because it's done in collaboration with Università Federico II of Naples. The primary objective is to describe levels and dynamics of PSA and ctDNA in patients with metastatic hormone-sensitive prostate cancer treated with an ARPI, both if used as a doublet or a triplet. And then we want also to explore the association of PSA and ctDNA with survival outcomes and characterize the dynamic changes of those two parameters. So this is the study design. Patient enrolled must have an histological diagnosis of prostatic adenocarcinoma, of course, staged as a metastatic hormone-sensitive prostate cancer setting confirmed at a radiological evaluation. Both metabolic or conventional imaging are allowed in this stage, and they, of course, must be eligible to receive a doublet or a triplet RP-based combination. So all the patients provide, after informed consent, of course, the baseline tissue, and also we took at baseline blood samples, both for evaluate PSA and lab values, and also to ship it with the tissue to University Federico II of Naples, because there they perform an NGS testing on ctDNA with a tissue-based panel. So basically the patient starts with this therapy, and we will evaluate both NGS and PSA at baseline after 6 months in order to look especially to those patients who have a deep response of PSA at 6 months. And also we will evaluate all those parameters at progression disease. Total sample size is of 50 patients treated with doublets and 50 treated with triplets. We're gonna start next week enrolling patients, so it's freshly new. And also we have a collaboration with the JETUG group. Dr. Loriot already presented all those studies, the P6 platform, so I'm gonna discuss too much about the study design. We have 2 different studies that are going to be activated in the next few weeks. In particular, we have, those are all studies conducted in patients with de novo metastatic castration-sensitive prostate cancer. And in the vulnerable cohort, patients are randomized to receive a standard of care, which is ADT plus placebo in this case, versus ADT plus darolutamide. Patients enrolled in this study must not be eligible to docetaxel, abiraterone, enzalutamide, or apalutamide, and they must respect at least one of those Friedli criteria that are listed above. And the other study that we're gonna activate between the P6 platform is the poor responder one, which randomize patients who don't obtain a deep response on PSA at 6 or 8 months to receive a standard of care, which could be ADT plus an ARPI, versus standard of care plus lutetium PSMA. Of course, all the patients before randomization are screened with a gallium PSMA PET CT scan. And now let's move to the sponsor trials. These are all the trials that currently are recruiting or that have patients still on treatment in all the prostate cancer field, ranging from metastatic hormone-sensitive prostate cancer to more advanced disease. I'm gonna present you only the bold one, which are those with which are open to the recruitment. In particular, we have 2 trials that are evaluating the mevrometostat, it's a crazy name, in metastatic castration-resistant prostate cancer. These are 2 phase 3 randomized open-label studies. What is this drug? It is an inhibitor of EZH2, which has been discovered as a possible mechanism of resistance to RP, as it can activate the androgen receptor signaling pathway. So combining both RP and dose inhibition could be a new strategy with the aim to advance, to avoid the disease progression. So these are the 2 designs of the 2 studies. The MEVPRO one is designed to enroll patients in the first or second line of metastatic castration-resistant prostate cancer after progression to abiraterone. So patient will receive enzalutamide plus mevrometostat versus enzalutamide alone. The same drugs are given to patients enrolled in the MEVPRO-2 trial, but in this case, patients must have an ARPI-naive first-line metastatic castration-resistant prostate cancer. And we just had the site initiation visit as regards the MEVPRO-3 trial, which will be conducted in the metastatic hormone-sensitive disease, but I think it's going to be a new for the 2026. And another phase 3 randomized trial that is now active for castration-resistant prostate cancer patients is the Amgen trial. We heard about T-cell engager, which are this new category of compounds, this new way to administer immunotherapy. And we know that there are many drugs that have been developed in the last few years. This is a wonderful review that we conducted with Dr. Agarwal on this topic. And in particular, in this trial is going to be evaluated xaluritamig, which is a TCA directed against TIP1. TIP1, we know it's a cell surface antigen that is expressed in more or less 80% of metastatic castration-resistant prostate cancer cells. And this is the study design of the trial. So patients must have received prior docetaxel and at least one prior ARPI. And they are then randomized to receive the TCA as a monotherapy or cabazitaxel or another ARPI as per investigator choice. And now a very quick overview of our scientific production. So this is a poster that I had the honor to present at last ASCO GU 2025 in San Francisco that was born from our collaboration with Foundation Medicine. In particular, we evaluated a total of 2,200 samples of clinically advanced prostate cancer that have been analyzed with NGS. Our aim was to find define the expression of the presence of a new biomarker, which is the HRD signature that have been developed recently, and that strongly correlates with the BRCA biallelic loss. So basically, this should be a new tool that can define in the best way possible those patients will really have a phenotype of an impairment of the HRD pathway. So in our cohort, 10% of patients were HRD signature positive, and we also analyzed different frequencies of several genomic alteration in both correlated with HRD signature negative and positive. But the paper has been submitted, so I hope that you're gonna read the full work in the next few months. And there's another poster presented by Brigida at last ESMO 2025. Antonio already presented some of those data as she conducted this huge analysis, retrospective analysis on the Trinetics platform. And so in this retrospective study, as Antonio already mentioned, she didn't observe any difference in overall survival in all the patients with metastatic hormone-sensitive prostate cancer treated with triple on double therapy, but after propensity score matching, it seems that in the metachronos cohort, we can have a longer overall survival with doublets compared to triplets, while in the synchronous cohort, we obtain a longer median overall survival with triplets against doublets. And then I have to tell you that one of the hobby of Brigida is to do meta-analysis. So she loves doing them. And I'm starting loving too. So this is the first one that we conducted these years about the incidence and risk of thromboembolic and cardiovascular adverse events with PARP inhibitors in the trial conducted in metastatic castration-resistant prostate cancer. So we selected 11 phase 2 and phase 3 trials. And above them, we basically the cardiovascular adverse events are not so common. They are quite rare, but hypertension is the most common one. But the high-grade adverse events, in that case, in the high grade, there's there's an elevated risk of cardiovascular events with PARP inhibition, which is quite important because now we are evaluating them in combination with ARPI, which have their own cardiovascular side effects. So this is a rare adverse event, but that we need to take in our mind. And then this is something that we started doing during last ESMO when the RSN's results were being presented in that exact moment. We wanted to understand in the metastatic hormone-sensitive prostate cancer how to decide between a doublet or triplet combination. So we selected all the trials that are listed above. And basically, we confirmed that the addition of an ARPI is always necessary in this case. We can improve overall survival over standard of care with a reduction of 30% in the risk of death. And this effect is maintained also when the patients treated with docetaxel were excluded from our analysis. As regards radiographic progression-free survival, the combination with an ARPI almost halved the risk of progression compared to standard of care, and our results remain positive also when the patients treated with docetaxel were excluded from those analyses. But it wasn't enough, so we also conducted a network meta-analysis on this topic. Now it's available from 2 days ago, so it's another fresh new, and we conducted this work in collaboration with other Italian centers. And basically, again, as regards overall survival, we divided patients in different treatment strategies, so triplet, doublet with ARPI, doublet with chemo or ADT, and in 4 different subgroups based on the volume onset and timing onset. So when we take a look on the patients with high volume and the patient with high volume and synchronous disease, triplets obtain the best results. While if we take a look at patients with low volume, but especially in those patients with metachronous disease, this advantage from the use of triplet is lost. And similar results were observed also in the radiographic progression-free survival. So I thank you all for your attention.
Thank you, Chiara. And if there are no questions, we move to the next presentation by Dr. Majorano on urothelial carcinoma, renal cell carcinoma, and rare tumors. So Brigida, please. And slides are working now, maybe.
Thank you for the floor, but I hope I've not broken the microphone. Good evening again, everyone. Let's talk about trials in progresses, starting from the urothelial carcinoma. These are my disclosures. In our unit, we are carrying out and have carried out many sponsored and academic trials for pretty much each setting of urothelial carcinoma. I like to say, what a pity that Petros is not here to use a Greek word. We have a holistic approach to urothelial carcinoma. We are trying to work on different areas, so different unmet needs, the use of a neoadjuvant therapy for cisplatin-ineligible patients with the new drugs and new combinations, and bladder-sparing approach. This providing the backdrop for our academic trials, many unmet needs in the muscle-invasive bladder cancer. The standard of care is now represented by perioperative chemo plus immunotherapy associated with the radical cystectomy, but also for those patients receiving the optimal treatment, there is the possibility to develop metastatic disease in the first 2 or 3 years in around 50% of cases. Moreover, 50% of our patients are not cisplatin eligible, and for this patient there is no standard treatment. And even when completing the perioperative treatment, we have to remember that radical cystectomy is a major surgical procedure associated with the post-surgical complications and also a terrible decrease in quality of life. So many unmet needs, but also how to define the pathological versus the complete response. Many of the previous presents and Professor Necchi, they are working on defining this new endpoint for designing next generation of clinical trials, of brother-sparing and clinical trials, and also to improve not only the quantity of life, but also the quality of life of our patient. This is an overview of the phase 2 trials led by Professor Necchi at our Ospedale San Raffaele Hospital. The Nurecombo using nivolumab plus nab-paclitaxel in the perioperative setting with already published results. The SURE platform with the use of sacituzumab govitecan as a neoadjuvant therapy in the SURE-01 or combined with the pembrolizumab, perioperative pembrolizumab in the SURE-02. And now just for opening the nebula with the avelumab combined with an anti-ephrin, which is involved in reshaping the tumor microenvironment towards reducing immune suppression. This is the SURE platform. This is our most recent flagship for our Unity and a pride point for Professor Necchi as well. In this trial, we are using sacituzumab govitecan before radical cystectomy as monotherapy in the SURE-01 and together with perioperative pembrolizumab with a radical cystectomy or reTURBT in the SURE-02. Whose results were recently presented by Professor Necchi himself at the last ASCO 2025, and the paper has just been submitted. In this trial, patient with muscle-invasive bladder cancer with a predominant urothelial carcinoma histology, ineligible for or refusing cisplatin, but candidate for radical cystectomy, received 4 cycles of sacituzumab plus pembrolizumab, then underwent a radical cystectomy or reTURBT and were treated with another adjuvant year of pembrolizumab for 13 cycles total. The primary endpoint was the clinical complete response rate, defined with the negative imaging and the absence of any viable tumor residual as surgical specimen, so the YPT0 and 0 or X. As we know, the patients, besides the 4 patients who progressed during the neoadjuvant phase, 16 patients among the 49 total patients that were treated in the trial received a radical cystectomy, whereas 29 patients were treated with a reTURBT. And the complete response rate, the clinical complete response was 38.7%. With over half of patients that had an important, so a great reduction on pathological complete or major pathological response, especially in the luminal subtype. So after 12 months, the event-free survival was 71%, reaching up to 90% among patients who reached a clinical complete response, which of course in this case played a prognostic role for the event-free survival. But at ASCO, we also updated some of the other trials. I presented an abstract with the updated results of SURE-01, so sacituzumab govitecan in the neoadjuvant setting. In this case, the 12 months event-free survival was around 75%, with a pathological complete response rate of around 32% and an important downstaging in the 37.8% of patients. And the transcriptomic analysis, the most relevant results in terms of response and event-free survival achieved by the infiltrated luminal subtype, where Chiara presented the updated results of the Nurecombo trial with a 24 months overall survival of around 90%, as well as the relapse-free survival 74%. And also in this case, with the GSC analysis, the non-luminal subtypes had a greater response and survival compared to the other subtypes. And finally, Valentina presented the updated results of the PER-01 trial. After 5 years, the event-free survival was around 78%, and the overall survival was 77%, with a prognostic role for overall survival of pathological response also in this case. The other field are the new agents in the perioperative muscle-invasive bladder cancer. We already heard that visogrumab, which is an anti-GDF15 agent, this is a cytokine of the superfamily of the TNF-beta involved in tumor microenvironment, and so in reshaping the tumor microenvironment, but also in metabolic pathways. Professor Necchi presented at ESMO the results of the phase 2 Neo-Godfather trial, where patients were treated with nivolumab plus placebo or visogrumab. And in this case, there was an interesting safety profile with no grade 4 to 5 treatment-related adverse events. But above all, the pathological response rate was 3-fold higher when nivolumab was combined with visogrumab compared to nivolumab alone, especially in patients with the CPS over 10%. And this also meant an overall response rate 4 times higher with the combination of visogrumab and nivolumab compared to nivolumab alone. Talking about new agents, we can also talk about a new drug delivery system. This is the TAR-200. Professor Necchi already mentioned the study, which was presented at the last ESMO. This is the Sunrise 4 among the platform of TAR-200. The intravesical release of gemcitabine in this study, patient with muscle-invasive bladder cancer received TAR-200 plus the immunocheckpoint inhibitor setrelimab compared to setrelimab monotherapy in the neoadjuvant setting if ineligible for or refusing cisplatin. Here there was a huge increase of pathological complete response of around 10%, which meant a 12 months relapse-free survival of 77 versus 64%, which was clinically significant. And we already heard the prognostic role of UTDNA, both at baseline and in case of clearance, correlated with the pathological complete response and also relapse-free survival. Our working area are quite similar in non-muscle invasive bladder cancer. We are focusing on new drugs, new combinations, new devices, especially in BCG failure or unresponsive patients. So we are participating in different Sunrise trials. For example, the Sunrise 1 in patients with high-risk non-muscle invasive bladder cancer that in case of presence of CIS were randomized to TAR-200 plus setrelimab versus TAR-200 alone or setrelimab alone, and the papillary-only high-risk patients without CIS could receive only TAR-200 alone. In this case, the study celebrated the efficacy of TAR-200 as monotherapy. I don't know. And now we are also participating in the Sunrise 3 for patients with BCG naive high-risk non-muscle invasive bladder cancer, randomized to TAR-200 plus setrelimab compared to BCG compared to TAR-200 monotherapy. I don't know, but there is a problem. I have some like graphical problem with the slide. The mutation has gone, so there is no mutation, but this was like a message to underline how the FGFR mutation are driver for urothelial carcinoma in the different settings. And it was another study we had activated at our center. So imagine, this is quite common here in the urothelial carcinoma field. I had the previous example, we had the previous example at ESMO, so now that's my turn. In the Moonrise trial, the intravesical drug delivery system is TAR-210. The drug which is delivered is not gemcitabine, but erdafitinib. So it's a trial for FGFR altered patients in the muscle-invasive bladder cancer setting, and we are just starting the Moonrise 3 trials. What are our working areas in the metastatic field of urothelial carcinoma? The use, again, of new agents and combinations in the different lines, real-world data, and quality of life and digital devices. For example, we are participating in this trial with the disitamab vedotin, which is an antibody-drug conjugate targeting HER2, plus pembrolizumab for naive patients expressing at least 1+ at the immunohistochemical analysis for HER2. And I think that we are all dreaming about these results that we already saw at ESMO. In that case, it was disitamab vedotin plus toripalimab, but maybe in the future we can see similar results with the disitamab vedotin plus pembrolizumab, we hope. For pretreated patients after progression to EV-pembro, this is a very important unmet needs. There is a lot of talk now in the field of metastatic urothelial carcinoma. We are participating in the Tropion pan-tumor trial using another anti-TROP2 agent, the datopotamab deruxtecan monotherapy after EV-pembro. And this was the trial I was mentioning before, the Forager 1. So next generation of FGFR inhibitors targeting already some of the mutation developed after erdafitinib. So we are also participating in this trial. Real world data, this is another study from the Trinetics platform. You already heard from Antonio and Chiara, but this is another trial that we presented at the EAU. In this case, we studied the outcomes of patients with muscle-invasive bladder cancer that not received the local consolidation with a radical cystectomy or radiotherapy after completing neoadjuvant chemotherapy. These are not common patients, but also in this case, we found that in some specific subgroup of patients, we could reach the same survival outcomes that the general population that complete the standard of care. So we should generate prospective data also on this topic. I won't dwell on this slide because Antonio already talked pretty much about it. This is another study of the outcome of immune checkpoint inhibitor challenge in urothelial carcinoma. We presented the results at the AU, and the paper was just published in ESMO Open, but this was the basis to propose a multicentric real-world analysis within the International Bladder Cancer Group, which is called ROGUE, so we will start this analysis soon. AI and digital devices, this is an app, a web app, to streamline the quality of life assessment and monitoring in patients with urothelial carcinoma. So the name is not so original, it's called UroLife. So we are developing a web app together with the patients for improving their awareness of disease, of drugs management, and quality of life assessment during the pathway during their trip in urothelial carcinoma. There are 3 different steps for these trials that will last for 3 years. The co-creation of the content to be included within the app, the web app development itself, and then the last phase, which will be a phase 2 randomized clinical trials where patients will be managed with the web app versus the standard of care. Now with the co-creation, so we are asking the patients, we are proposing some tools, asking their feedbacks and asking their proposals. For example, we are trying to include the decision-making pyramids for adverse events detection and management, quality of life questionnaires, some educational content of interest, links to patients' advocacy groups, and we are co-creating the content to be included within the app during this step. The other working areas in RCC, second-line choices and real-world data, and rare tumors. We know that now the renal cell carcinoma is in the golden age, the age of combination of immune checkpoint inhibitor and VEGFR targeted agents, but still we don't know, we don't have a high level of evidence after progression to first line. And this is the REJOICE study. This is a phase 2 trial where raludotatug deruxtecan, this is another antibody drug conjugates directed against cadherin, which is quite simple, easier than the name because it's one of the factors involved in the mechanism of cell-to-cell adhesion. And it could be administered, so we had two active cohorts after progression to first line, both in patients with CCRCC and in patients with urothelial carcinoma in the metastatic setting. real-world data. So I won't dwell on this slide because Antonio talked about the Trinetics project of ICI Rechallenge also in renal cell carcinoma. And regarding rare tumors, there was an interesting analysis with Foundation Medicine led by Antonio with an analysis of urachal and not urachal adenocarcinoma sharing some genomic alteration in common with, for example, colorectal adenocarcinoma. So this is a very rare tumor. And the last analysis, an abstract presented by Valentina at last ESMO. This is a global analysis of the use of salvage high-dose chemotherapy. I think that the interesting thing is that the time to salvage chemotherapy is linked not with PFS, but with OS. So very useful for, because there was a high number of patients including in this analysis. Thank you very much for your attention. I also updated the pictures.
Thank you, Brigida. Great presentation. And now I have the honor to introduce Professor Kitty for the last talk of today on the role of our available clinical trials in radioligand therapy.
Good evening. I try to keep it very short in order not to make the already exhausted survivors dying because of my presentation. Let me see if I... No. Okay. So just to give you some straightforward messages, I think that, you know, radioligand therapy, now we are living in a hype. But my impression is that we are not doing it the right way, so you are not taking advantage of all the possibilities that we have with theranostics. Ooh. Okay, so I summarize with some trends that we are seeing in radioligand therapy. So prostate, of course, combination therapy, particularly with Pluvicto, which is the licensed radiopharmaceutical. I think that this will be the way to go. Also early treatment, again with Pluvictos. There are some antibodies, some new molecules that are under evaluation. What we are really missing is personalized dosimetry, or what we heard this morning, what we call dosing. So 6 doses of 740 gigabecquerels per every patient is not the way to go. So we will have a drawback if we'll keep with this strategy. And then there are also alpha-emitting radionuclides that we will see. In kidney, there are some studies going on, particularly CA9. I think that this will fly, with, of course, the caveat that are also true for prostate cancer. For bladder, we have very few studies going on. One is with FAP, and Nectin-4, which we'll see in the last slides. So let me just present you some of the molecules that so far we are developing for diagnosis. One, I think that it's very promising and that will be shifted someday to therapy is the alkaline phosphatase 3 that we were able to develop very fast in this institute because of the great collaboration with the urological group. So this is, you see here, the biodistribution is completely different. And you see here, of course, this is a phase 1 study, so 20 patients, no really solid data. But you see here, for instance, this is a patient with the completely negative lesions that light up on the ACP3. And you see from, if you are thinking about therapy, you see here that there is no uptake in the salivary gland. So this might be an advantage. So a molecule that I think that will be very promising for the future. The other molecule that, again, we are developing thanks to the great collaboration that we have here is this CA9. This is a small molecule that is used, and you see here a clear cell carcinoma that it's clearly light up, but here you have a caveat, so see the uptake in the stomach, which is specific uptake. So It's not something that you can easily get rid of. And of course, you cannot think about treating a patient with this uptake within the stomach with like lutetium labeled CA9 because you're going to have unacceptable toxicity. We are also, let's say, start running a trial with another CA9, which is a full antibody. You see the biodistribution is different because the images are taken 5 to 7 days after the administration. You see, again, very high and interesting tumor to background uptake. Here you have the primary lesion, and here is, unfortunately, a metastasis in the rib. But the main advantage here, you see that you have a negligible uptake in the stomach. So this is why then we will see we already have some studies running with the therapeutic girentuximab. So just to let you have an idea on what is going on, I will not talk about the PSMA addition, but you see that there are many studies, particularly in association with other radiopharmaceutical, also some new PSMA. I don't think that we will get any significant advantage with this other PSMA because the biodistribution is the same, we will see. And there are also some networking looking at the, let's say, real life evidence of what we are doing with PSMA radioligand therapy. We is not us, but particularly Germany and Austria and those countries where they can use on let's say, a compassionate basis and without having the obligation to use the licensed product. The other molecule which could be interesting is the Telix 591, which is a full antibody. So the biodistribution is the same, but the time to target is definitely longer. So that means that you are using a lower activity, and what they say is that this might allow the molecule to reach the target in a better way. So we will see what will happen. Then there are some trials using actinium-225, which is an alpha emitter. Alpha emitters, you know that they are capable of giving higher energy in a shorter in a shorter space. Problem with actinium-225 is that it has 4 different daughters, and it has a horrendously high uptake in the salivary gland. So the trials that the data that have been already published, they show that the salivary gland toxicity might really be a limiting factor. So for kidney cancer, you see it's almost only girentuximab. There are different trials in different phases. You see again with combination therapy, girentuximab at the moment, from my personal point of view, is the radiopharmaceutical that will fly because it has all the characteristics for, of course, we are talking about clear cell renal cell carcinoma. Then there are some trials that are using, one trial that is using FAPI. You know, FAPI is targeting the activated the peritumoral cells. So that means that the targeting here is not exactly on the tumor. And then with FAPI, we have another problem that the molecule doesn't stay attached to the cells for a long time. So the residency time is too low. Now there are other FAPIs that are using 2 or 3 different sites in order to stay within the cells for more time, but I don't think that we will really have FAPI as a therapeutical molecule. It's incredibly good, or at least incredibly promising for diagnosis, but when you need to do radiotherapy, so the residency time might be a problem. And then there are some studies with lutetium PSMA 617. You know that some clear cell carcinomas, they do take up PSMA, but again, I don't think that this will be the way to go. For bladder cancer, there are very few studies. Again, FAPI2286, we will see what will happen. The residency time is a problem for therapy. There is Nectin-4, which might be useful as a target. We will see how it will develop. Now it's a phase 1. And then we just see that there are some studies with intravesical radiopharmaceutical, and there is also a pilot study with radioligand therapy instilled with CXC4 into the bladder. So to be very fast, the future outlook. So we can say that the efficacy for the two PSMA 617 and INT are demonstrated. Again, we need to work on the way we administer this radiopharmaceutical. The 6 doses with the same activity is a no-go. So it's, of course, it's simple, but it makes poor sense. At least what we mentioned this morning, the dosing. So that means that when the PET becomes negative, we can stop, because otherwise there is no sense to treat a patient. And we have a tool that we are not using because we are obliged to treat the patient for 6 courses, which again, it's poor sense. So the long-term renal toxicity with PSMA 617 or INT could be a problem, because the moment that we start treating patients with in the early phases of disease, they live longer, so they may develop renal toxicity. So far, this is not a problem that we are seeing in the countries where Pluvicto is approved, because, you know, for instance, in Italy, Pluvicto is fourth line. So that means that most of the patients, they are not even capable of having all the 6 courses. Most of them, they have toxicity or they die before the 6 courses. We still lack data on dosimetry and dosing. This is something that we have to perform, but if you look at the trials, there are almost no trials working on this aspect. And of course, efficacy on actinium-labeled PSMA is still to be confirmed. I don't see that actinium will fly because of the radionuclide characteristics. There are other radionuclides that are going to be better, you know, like astatine, or we'll see like terbium. And of course, short and long-term toxicity will be an issue. So for antibodies, we will see if they can be as effective and maybe give lower long-term toxicity. Terbium PSMA, in my opinion, will fly. Terbium is a radionuclide that is releasing high energy in a very short path. So we do not expect to have very high toxicity with this, and particularly with micrometastatic disease, terbium could be very interesting. We can also think about of doing what we are, for instance, doing in thyroid cancer, that we start treating patients when the PSA rises. So because most probably we can have the radiopharmaceutical on target also if we can't see it with PET. And of course, ACP3 promising, but no data at all. So we will see what will happen in the future. Kidney, again, very promising CA9, but biodistribution, particularly for small molecules, as you have seen in my slides, is an issue. And we still have to evaluate the efficacy of the antibodies and small molecules. There are some study with CD70, which is another target that has been used for diagnosis in clear cell renal cell carcinoma. And of course, PSMA could be assessed, but I don't think that is the way to go. And same holds true for dosimetry and dosing as for prostate. Bladder, there are very few studies going on. FAPI, brilliant from the diagnostic point of view. We don't know for the therapy. Time of residency is still an issue. Nectin-4, again, we will see what will happen. And intravesical administration, of course, for locally advanced disease could be an option, but we still need data for dosimetry and dosing. So with this, I would like to thank the nuclear medicine group, but most important, the urological group, which allow us to make all these studies. And thank you very much for your attention.
Congrats for this great presentation and
Yeah, so good question. This can be an advantage. The problem is that if you want to do radiotherapy, because we are doing radiotherapy, you need to have, let's say, the radionuclide on target at least until it has physical emissions. So problem is that these molecules, let's say the bivalent or trivalent molecules, they can stay up to 24 hours, but then they tend to detach. So it can be an advantage if we find a way to link it with the radionuclide at a very short half-life, because it goes on the target and then it can release energy.
Do you think that there is any limitation that could be overcome with the next technology, or because FAPI is very, very good target for bladder, you know?
Yeah, but
very,
again,
very,
for diagnosis, it's excellent, perfect. Because diagnosis in 2-3 hours, it's more than enough. So you don't need it more. For therapy, there are also some studies that are in advanced phase, and the residency time might be a problem. I know that in the National Cancer Institute, they will start a study with FAPI for therapy, with rotation therapy, so we will see the results.
So thank you very much, and I think Andrea will leave the word to you for the final closing remarks. It's your responsibility. We leave it to you.
Just to say good night, and thank you for attending. For the few of you who have remained until the very end, thanks to the guys out there. Most of them are outside of the door. Thank you, Clarissa, Elena, Marco, and the rest of the organization secretariat. Thanks to the technicians. You did a very good job in accommodating all the requests for your patient. Thank you for everything in looking at the details. So I hope you have enjoyed the day. I think that there is a lot of movement in EGU cancer. More to come, much more to come, I think, good for the patient. Good night to all of you who are attending virtually via YouTube. I think most being patients, our patients or patients with urothelial or GU cancers. And I think that most of these patients will get tonight with the more promising future, based on the advances that we have made, that we are making, and will make in the near future for that disease. Thank you, sir. Thank you very much.
Thank you, and compliments to Professor Necchi as well.